it has been really well conceived by Dr. Arabind, and I have seen him working so hard for last a couple of weeks, totally engrossed in how to do the best for all the delegates. He has taken pains in covering, in carving the program in such a way that it will cover the whole gambit of investigative approach, how to run a successful urodynamic department. He will give you the tips of clinical illustrations, hands-on experience, and hope this will improve the quality of your clinical practice and bridge the gap of the clinical practice, optimizing it's a very complex science for a normal urologist. You know, we always try to neglect it, but last few years, I think it has become a necessity to understand it properly. I must congratulate Dr. Arabind Panda, and all the best to all of you. And let's start the program. It's already 9:15. I think the first speaker, we have Dr. Sanjay Sinha. All of you know, eminent urologist, expert in neurourology. So he will guide through. I think he is the best person to start the program. Sir, before starting, I request Dr. Arun Chawla to please say go for the program.
Yeah, good morning to everyone, and a warm welcome to you for this Indian School of Urology USI practical course on urodynamics. I think you have already been apprised how much hard work has been put to script this program, but on the top of it is you will find an excellent faculty which will make this program much useful to you. We have a galaxy of the masters in this field, Dr. Sanjay Sinha, Dr. Pavan, Arvind himself, Nikhil, Prashant, and other faculty. All this you may not be aware, but if you reading the IJU, you will find half of this faculty were involved in framing the guidelines on urine incontinence. So I think you can recognize how important will be to come and attend this course, because this will give you a stimulus somewhere to start in your department attached to this specialty, which is function urology. Without wasting much time, I'll invite Dr. Gopi to hand over to him to invite the first speaker, which will be Dr. Sanjay Sinha. Over to you, Dr. Gopi.
For some reason, the blacks are not black. I'm not sure why. Thank you, USI, ISU, Dr. Arun Chawla, Dr.Arabind Panda, Dr. Gopichand, and Kims for inviting me here to be with you today to speak on urodynamics. For this lecture, I must state I'm standing in for Professor Nitin Kekre, who was not able to make it for this program. So why and what of the urodynamics? So we know that urodynamics, and when I use the word urodynamics here, I am using it in a classical sense for invasive testing. You will learn later in the program that the word urodynamics actually encompasses all sorts of non-invasive assessment as well. So when we look at invasive urodynamics, essentially we are trying to get a more precise measurement of lower urinary tract function. Why would we need such a more precise measurement? It's because symptoms are not entirely reliable for making a diagnosis. For instance, if you look at women who present with a clinical symptom of stress incontinence, a significant proportion of these women do not really have stress incontinence. Certainly not enough to make a decision for surgery in all of your patients. Symptoms are not enough to predict treatment outcomes. Again, looking at stress incontinence, you cannot differentiate between a patient who has a higher risk of recurrence compared to a patient who has a lower risk of recurrence, at least in a meaningful manner, without doing a urodynamic study. For establishing safety, you cannot reliably differentiate a child who is at risk for upper tract damage in a neurogenic setting, a high-risk neurogenic setting, from a child who's not, on the basis of symptoms, imaging, neurological assessment, spine imaging, and so on. So for all these reasons, in a wide range of patients, you might need to make a more precise measurement of urinary tract function. Do we have a timer somewhere? No. Okay. So what do we do? The intention is to measure the behavior of the lower urinary tract during the two phases of its function, storage and voiding. What do we actually need? We actually need to make a precise measurement of how hard the detrusor muscle contracted when we are looking at contractility. And we need to measure how much resistance the outlet actually gave when we pass urine. Unfortunately, we really do not have a method to directly measure either of these two quantities. No current technology allows us to measure the actual strength of the detrusor contraction. And no current technology allows us to measure the actual resistance across the outlet. So you need to look at surrogates to do this measurement. So what's the compromise? You measure the pressure rather than the actual contraction. So you're not really measuring how hard the bladder contracted. You're measuring how much pressure got generated in the bladder. And these are not the same thing. Second, even when we do draw conclusions regarding the pressure, we are not really able to measure what pressure was contributed by the bladder. We have to draw indirect conclusions about this pressure as well by measuring the pressure in the bladder and subtracting the abdominal pressure. When we are looking at outlet resistance, instead of measuring the actual resistance across the outlet, we have to measure the flow of urine across the outlet when the bladder contracted. And that contraction is not within our control. So there are certain technical caveats because of all this. You don't really measure the actual contraction. You can't measure the contribution of the bladder to the pressure rise. If the bladder doesn't generate enough of a contraction, you have no way of assessing outlet resistance. So to give an example, let's say I'm standing in this room and I want to walk out of the door. Let's say you're bored by my talk and you want to rush out of this room and you reach up to the door and you try and push the door to open it. Your ability to judge whether that door is jammed or not jammed only starts after you start making the push. If you were the only person on earth or in this room and you have no ability to reach that door, you have no way of telling whether it's jammed or not. It's just not possible. Hence, if the bladder does not contract effectively, you have no method of proving obstruction because current technologies do not allow you to make a direct measurement of outlet resistance. So in contrast to a fluid dynamics in a physics lab, these systems are also distensible systems. So we are not talking of a rigid sphere and a rigid pipe, which is what physics hydrodynamics is about. We are talking about distensible systems, and distensible systems introduce another element of uncertainty into the measurements. What are certain clinical caveats? We have no precise method in the urodynamics of recognizing what measurements are truly volitional, the patient actually carried them out, and which are involuntary. So you need to rely on your discussing with the patient, talking to the patient, your judgment as to what happened. For instance, the difference between what you label as a phasic contraction with an incontinence in, say, for instance, a patient with Parkinsonism, and a void is just the fact that you told the patient to void. Your assessment that the patient understood, had the cognitive ability to understand the instruction, and then carried out that instruction in a manner that actually gave the right information. And many times it's not possible to tell this. Precisely in this example of a Parkinsonism patient with cognitive decline, sometimes you just don't understand. The patient may not understand the instruction well, and you don't know what happened. Was it truly a volitional contraction with a void, or is it a phasic contraction? And this makes a world of difference, because you cannot draw conclusions regarding voiding after a surgical procedure based on a phasic contraction. There was no method to do that. Is it a dyssynergia or an uncomfortable patient? Both of these will produce the same failure of relaxation of the outlet. Again, judgment involved. In fact, similar observations of pressure and flow may give you very widely divergent interpretations of what actually happened. And I'll show you this in a subsequent presentation in the afternoon. Acontractility versus situational inability to void. Let's say you're doing my urodynamics and I don't like your face and I decide I'm not going to cooperate. You find a situation where there's no contraction. But that's not acontractility. It might not even be situational inability. It may just be my failure to cooperate. But then there are situations where the patient wants to cooperate and is still not able to pass. Some of those are actually situational inability. And it's important to differentiate the two, because you may label a patient as acontractile when the patient has a completely correctable bladder outlet obstruction just because the patient couldn't void during the test. Hence, take this example of a child on the street next to the wall and passing urine. You don't know whether he's got an overactive bladder. Is it the stress for an impending examination? Is it a response to this Nike ad? Is it comradeship with his canine friend who's just done the same act? Or is it just normal social behavior? All this will change the interpretation of what this boy did. Similarly, when you do the urodynamics, all these different aspects of your judgment as to what happened will change your interpretation of what actually occurred during the test. In interpreting the observations, in all of science, not just biology, we rely on a demonstration of cause and effect. You take some condition that you're trying to study, not necessarily biological, even if it's a physics condition or whatever. You take a situation you want to study and you try and prove cause and effect. That's the way we arrive at a scientific conclusion as to what's going on. This requires, in urodynamics context, a clean cohort of patients, the ability to make a precise measurement as to what happened. And when I say clean cohort, let's say, for instance, you're talking of voiding dysfunction in women. You need to be able to define a very tight group of women who have a similar kind of a presentation, similar physical evaluations, similar, let's say, prolapse status, and so on. And then in those, and similar symptoms, and then you need to make precise measurements in those women. These precise measurements should be repeatable by different investigators. Each of them should be able to interpret it the same way, which doesn't always happen. You should be accurately able to estimate the actual bladder and outlet behavior. By this, what I mean is, I may make a very precise measurement of what happened in this woman's bladder. But does that actually represent what really is happening in terms of obstruction or contractility? Is the science precise behind that? We did a measurement from the bladder. We made a measurement of the flow. How precisely do we actually measure the contraction by those formulae? How precisely do we measure the actual outlet resistance by certain formula or nomograms that we apply? And then you need the outcome data that when you did this, took a group of 200 patients, performed some treatment therapeutic intervention, followed them up for 5, 10, 15 years, and then did you prove that this was the clinical situation, this was the urodynamic finding, and that was the outcome. When you do that again and again and again across center after center, then you build up the scientific knowledge. And that information is lacking across a large group of conditions. And hence comes the difficulties in understanding what you're doing. So to give you a small example about this, we recently conducted a study. We've not yet published it, in the process of publishing it, regarding, this is a Delphi study, that is a sort of an opinion gathering study of experts across the world. And this is one part of the survey. This is the one on women. We did one on men, women, and children. And this is, we are trying to establish a threshold of consensus between the experts. And you can see here that if you look at the consensus with regard to requiring a numerical measure, so do we need some number to say how much is the contractility, how much is the obstruction? Most experts agree that it's useful. But when you look at, these are the various numbers for contractility. When you look at what is the experts' take on how satisfactory these are in a woman, for instance, you can see none of the measures actually are adequate in terms of accuracy. So they agree that you need a measure, but the existing measures are not accurate enough to be able to give you the right answer. So let me leave you with this short clip trying to identify which patients actually have a dysfunctional void, or where it is a behavioral disorder. Look at this child. Look at his urodynamic uroflow trace and tell me, is it a dysfunctional void? Is it just behavioral? He's produced a perfect staccato void, hasn't he? I'm sure most dogs don't void this way, right? You've seen dogs. They don't void this way. Is this dog having a pathology? Is he having a behavioral disorder? Has he been trained that way to perform? All this will alter how you interpret your patient's uroflow trace. Thank you very much. Over the rest of the presentations, all this, I'm sure, will be taken into account as we discuss the clinical conditions, the underlying physics, and so on. And Arabind has an excellent program lined up. I have no idea how much time I've taken, Arabind. I hope it's not more. Thank you very much. Questions at the end, I guess, right? Questions at the end? Questions now. We'll take questions now. Now, okay. Any questions? It's too preliminary a talk for a question, I guess. Okay, there'll be enough time to discuss questions through the day, I'm sure. Thanks.
Good morning, everyone. We'll be talking about good urodynamic practice. Now, what is good urodynamic practice? what we do know about the bladder is its unreliable witness. By meaning it's unreliable witness, it means that it's very limited response to disease. Whatever happens, the response of the bladder is limited to some very fundamental things. There may be urgency, there may be increased contractility, or there may be decreased contractility, occasionally bladder pain. So the aim of urological treatment is to always maintain a low pressure safe bladder reservoir, to make sure we have adequate emptying, whether the patient is on safe voiding or on CIC, and we of course want to enhance the quality of life in any sort of bladder disease. So we want a low pressure bladder. The entire aim of doing urodynamics is that you want to know whether a bladder is safe or a bladder is unsafe. If there is one take-home message you take from today, is that how to identify a safe bladder and how to identify an unsafe bladder. So what does urodynamics achieve? Urodynamics is basically soft science. Now there is a tendency for us to feel that urodynamics is hard science and it gives you an answer always, yes or no. But that's not always true. As Dr. Sanjay has already said, it's not always that urodynamics will give an answer. It may give you an answer, but not always that it will give you a definitive answer. So our aims of doing urodynamic study is to reproduce the patient's symptom during the study, to provide for a pathophysiological explanation by correlating the symptoms with findings, and to assess, of course, for the presence of risk factor, particularly poor compliance, because that's what will damage the upper tracts and cause renal failure. Also identify sustained high pressure detrusor contractions, and if there is DSED, detrusor sphincter dysynergia. It also helps us to provide documentation of disease in the lower urinary tract and can be used for follow-up. These are the fundamental things which UDS achieves. So before you plan any urodynamic study, before you even say that this person or this patient needs urodynamic, what we need to know is we need to find a cause, a reason for doing urodynamics. For that, we need something called the urodynamic question. The question is achieved only after you've taken a good history and done a good physical examination. Do a voiding diary. I will come to about voiding diary recommendations, but take a good voiding diary, preferably for 2 days or, if possible, 3 days, and review the imaging studies. And after that, you have to frame the question. The objectives of urodynamic evaluation depends on your clinical question. So objective is different for every patient. This is one test which has to be tailored to that individual. So after having the question, you need to ask which urodynamic test will be useful in this patient. Is the investigation likely to benefit the patient? This is the most important question. Potentially, we can do UDS in every patient that walks into the OPD. But it is to be used very selectively, and we need to see, is the investigation likely to change management? Is it likely to benefit the patient? And third, will urodynamics allow us to make a reliable diagnosis? And finally, most importantly, after doing the study, did the study reproduce the patient complaints, and could we correlate those complaints with the urodynamic findings? So of course, these are the prerequisites. You need to take a history from the patients. Many of these patients will have neurological abnormality, check their mentation, check the nature of neurological disease, the nature of lower urinary tract symptoms, its duration, take the history. Take a history about persistent or recurrent UTI, indwelling catheter, is the patient on CIC, has the patient any previous surgery, particularly surgery on the back, past history of meningomyocele, etc. And see the current urinary symptoms, storage symptoms, voiding symptoms, and incontinence. And take an overview of the related systems. Altered bowel functions, that you have constipation. If it is present, how severe is it and what is the duration? Take a sexual history, particularly of the erectile and ejaculatory function in men. Do a good physical examination. Do the usual physical examination which you would normally do. Then also do a focused neurological assessment. See if ambulation, see the mental status, cutaneous stigma of spinal dysraphism. Is there a tuft of hair at the back? This is present in about 50 to 90%, not in all. Check for the motor strength. That's very important, particularly of the lower limbs. Check for sensation and check for reflexes. When you check for reflexes, check for the integrity of the reflex arc, the anal reflex, and the other motor reflexes. Now, do something called the voiding diary. The voiding diary will recommend your daytime frequency, nocturia, the maximum voided volume. These are the 3 important things that you need. If there is no nocturia, you probably would feel that this patient is not really having a organic problem. A patient without nocturia probably has a more of a psychological issue. Check also the 24-hour urine production and the total fluid intake. This is the format which we use, Bladder Diary. Evaluate the upper tract ultrasound, evaluate renal function, do a creatinine, and check the PVR. Now, coming to the core, what is good urodynamic practice? Good urodynamic practice has three main elements. That was the introduction. This is the core. A clear indication of an appropriate selection of the relevant test measurements and procedures, precise measurement with data quality control and complete documentation, accurate analysis, and critical reporting of results. These are the three legs on which the good urodynamic practice stands on. Now, how did this term begin? How did this term begin? It was in 2002 that the first working group met, and they produced this document, Good Urodynamic Practices, Uroflelometry, Filling Systemetry, and Pressure Force Studies. It was published in 2002. And this is what we read when we went through our MCH. This was the first report of the International Continental Society on the development of guidelines on how urodynamics should be done. They were revised more than about 14 years later. In 2016, the second ICS report came out, Good Urodynamic Practice 2016. This did not completely supersede the first one. This only added to the first. Many of the things which were there in the first report are still relevant now. There are certain changes in 2016. And certain additions and some new terms have been added. I will just go through it very quickly. So, what we must know, and when we talk about good urodynamic practices, they reflect the International Continental Society standards. So, what is that? Best practiced, based on evidence, with the use of standard terms. You can't use non-standard terms. And standard techniques, evaluated and reported clinically or scientifically in a complete and validated manner. Each word here is important. Now, what this achieves is that when you give a report or you do a urodynamic test and I do it somewhere else and he does it somewhere else, all three reports can be exchanged and we can make sense of each other's reports because they have been done in a standard validated format. And what it means, it can be used for evaluation of lower urinary tract of adults, also in children, but this was in the report, it's meant for adults. So what did the documents do? There were new definitions and more precise definitions. More than 30 new terms were added. It provides the standard for practice, quality control, interpretation, and reporting of urodynamics, these documents. So the base outline says it has definition of the terms. It gives us information about what you should tell the patient. This is very important. When you're doing it in test, urodynamics can be non-invasive and invasive. But when you're doing invasive urodynamics, you need to prepare the patient for invasive urodynamics. You need to explain that this is what we need to do. And then we need to have urodynamics practice protocol, clinical pre-testing information, which I've already told in the beginning, because I wanted to tell you before I move to this. Practice of uroflelometry, practice of cystometry, practice of pressure flow studies and update of the terms, and technical and quality control points. So this is an information leaflet for UDS. Basically, this is how it is. You need to say why this urodynamic information, what is urodynamic information, why is it useful, and what are we going to do, and what are the different steps that we are going to do, what are the symptoms that will occur, how you are going to protect the patient's dignity, communication, comfort. What would you offer in this regards? You need to tell the patient also when you do the test that there are certain symptoms that are going to occur during the investigation and what you should do, what they should do to prevent or minimize those symptoms. And also you need to tell the patient additional information like length of investigation, sterility, that is going to be a sterile procedure more or less. There are not going to be injections apart from maybe the prophylaxis sometimes. And, sorry. Yeah. So, what you are going to do before the test, medication that the patient has to take or avoid before the test, and this medication is of course individualized, and what they should do after the test. They should drink perhaps half a liter or a liter of water to make sure that they are prompt voiding and relieve the urethral irritation. And tell them also that all usual activities are permitted after the test, and how you would manage, or the patient would come to you if there is urinary tract infection. It may occur very infrequently after invasive tests. So this is even, they have even standardized the leaflet and what you should tell the patient and what you should give to the patient before the test. So definitions, there are some definitions here. This is basically a general term aerodynamics, all measurements that assess the function and dysfunction of the lower urinary tract by any method. Invasive aerodynamics is any test that's invasive that involves insertion of the catheters or transducers. Non-invasive, that anything that is done without insertion of the catheters. Just 3 points. Invasive, non-invasive, and general aerodynamics, right? So, they also have something called a standard aerodynamics protocol. The protocol must include clinical history, a valid symptom score and a bother score. You can use IPSS score, relevant clinical examination, a bladder diary. They have recommended 3 days. Again, 3 days is not always necessary. To see more the number of days you have bladder diary, more information that you get. But generally, adequate information can be got even with even 24 to 48 hours. But this is what they have recommended. You can take a 24 to 48 hours diary at least. But don't do a test without a bladder diary. Representative uroflelometry with PVR and a complete ICS standard UDS test. So these are the tests. We already know all these tests. This is what is Uroflow, Systemetry, EMG, and then you can do video aerodynamics and a filling systemetry and a pressure force studies. So the ICS standard is uroflelometry with PVR plus a transurethral systemetry with a pressure flow study. All tests are performed with the patient's preferred or most usual position. The patient may be comfortably seated or standing depending on what the study is. In uroflelometry, we measure flow rate, the pattern and the shape of the curve, flow time, time to maximum flow, voiding time, and PVR. The limitations, of course, Dr. Arun is going to go through this. I'll just go through this very quickly. There may be considerable overlap between normal and abnormal. That's the point that you need to know. Also, you have to check for the representativeness of the uroflelometry. That's a part of the good aerodynamic practice. So good practice should represent a typical void, adequate voided volume, more than 150 ml, even 200 ml is acceptable, but more than 150. Avoid overdistension of the bladder. Don't tell the patient, drink lots of water and wait till your bladder bursts. No, that's not required. Minimum of 2 flows, and you should do a concurrent estimation of PVR. You can smoothen the curve, do the manual reading of the curve. Now, this is something that's important. Always round off that curve. What do I mean by manual reading? See, there is a reading that will come to you. Let's go back and just show you this one. See, this is a reading. If you look at this, you see these spikes are there. So the PVR, so the Qmax sometimes can be because of this spike. So that Qmax is wrong. And that Qmax is not representative. So if you are going to smoothen the curve, the Qmax is going to be somewhere in this range. So if this is say 35, and the Qmax will actually be 20. These are all, artifacts which you have to smoothen over. And then, so manual reading is very important. Do not depend on just the report. So a recording of 10.25 ml, even after smoothing, should be recorded as 10 ml per second. The voided volume and the PVR also should be rounded to the nearest 10 ml. So a recording of voided volume of 342 would be 340 ml. And the maximum flow rate should always be documented together with the voided volume. You can document it like this: VOID, maximum flow rate, voided volume, and PVR. This is the way to document your uroflelometry. This is how you should document at all times. Invasive, we will come to it later. We have an entire session for that. What I want to tell you is invasive aerodynamics should not be performed without precise indications and well-defined aerodynamic questions. So this is invasive. We'll come to it later anyway. So again, when we are measuring the intravesical pressure and the abdominal pressure, we need to have strict adherence to the ICS standardization of zero pressure and reference height. Why should we have the zero pressure? It doesn't mean just you press zero. Zero pressure means zero pressure is surrounding atmospheric pressure. The atmospheric pressure is never zero. Therefore, the pressure in the abdomen and the intravesical catheters will never be zero. The reference height is defined as the upper edge of the symphysis pubis. So it is very important that you have, when you are doing a UDS, a scale where you can measure and a sort of a right angle thing. So you can see exactly where the upper edge of the symphysis pubis is resting. And to measure the zero pressure, you need to open the transducer to the atmosphere before pressing zero. Don't close it and press zero. Open it to the atmosphere and then press zero. I'll come to it. I'll tell you how it works out. When talking of quality control, these are 3 criteria. And the resting values for the abdominal, intravesical and the detrusor pressure should be in a typical range. I'll come to that range in the next slide. So the intravesical and the abdominal pressure signals are live. So minor variations, if the patient is talking or breathing, that does not affect the detrusor pressure, because detrusor pressure is basically a subtracted pressure. We take the intravesical pressure, we subtract the abdominal pressure, and what we get is the detrusor pressure. And cough should be used very liberally every 1 minute or after every 50 ml of fill to make sure that the abdominal intravesical pressure are respond the same time, and be sure there is good quality control. So this is what I meant by initial transducer pressures. The transducer 0 should be set to atmospheric pressure. The transducer should be placed at the level of the upper edge of the symphysis pubis, and the intra-abdominal intravesical pressure when the patient is supine should be in 5 to 20 normally centimeters of water, sitting position 15 to 40 centimeters of water, and standing 30 to 50 centimeters of water. Because these are intravesical, intra-abdominal pressure, the P det does not vary so much, because the P det should be 0, close to 0 or less than 6 in 80% of cases. And in most of the cases, they should be below 10 centimeters of water. So when you are talking of making the 0, this point I want to emphasize, we just should not close the transducers and press 0. We should open the transducers and press 0, and then you are going to get the intra-abdominal, intravesical pressure in this range, depending whether the patient is sitting or in supine position. And the detrusor pressure will be generally less than 6, most certainly less than 10. So how do we zero the transducer atmospheric pressure? This is how we do it. See, most of you would have done UDS, and you say there is a 3-way tap here. So this is a syringe here. When you want to press it to zero it, you close this. You close the tap to the patient as well, and open the tap only to the atmosphere. Open it to air, and then press 0. When you are flushing, you have to close this and flush. Close the atmospheric tap and then flush. When you want to measure pressures, you have to close the tap to the syringe and flush. So I want to emphasize again, when you want to make it 0, you have to open this to air and then press 0. So you zero it to the atmospheric pressure. And then you are going to get those pressures which I just spoke about. So again, there are different transducer systems. What we generally and normally use are fluid-filled systems. There are two more pressures, they are called microtip and air-filled catheters. They will record pressure without a reference level. Here we have a reference level, that is upper margin of symphysis pubis. But if you have a microtip catheter, that does not need a reference level. It will measure automatically. But these are expensive and they are difficult to maintain. Generally, they are not in common clinical use as of now. So this is about the catheter. The smallest caliber double lumen catheter, 6 French, can be used, or 2 single lumen catheters can be used. You can remove the filling catheter during voiding. It's not always necessary that you have a proprietary catheter. You can use infant feeding tubes also, but you need to remove the filling catheter during voiding and ask the patient to void, so there is no obstruction to the urethra. The rectal balloon catheter, you need to fill to about 10 to 20% of its unstretched volume. Some people put a small hole, and there is a lot of discussion whether making a hole is a good thing. But you need not make a hole, but if you don't make a hole, make sure you don't flush into this catheter. You don't need to over-distend this catheter. You will have erroneous reading if you over-distend the rectal catheter. So again, before starting, you need to prevent errors. This is what good aerodynamic practice is all about. Basically, you can recognize the problems before starting or just when starting the test. What you need to do is you prevent fluid leaks and air bubbles. And what is the effect of fluid leaks? See, the air is actually a compressible thing, so it's going to cause damping. If you have no air bubbles in the tube, you are going to get good transducer readings. If you have air bubbles, the reading is going to be damped, it's going to be small. Okay? And if you have not been able to do this, you should be able to recognize this post-test and tell them, and actually mention in your report that there was a problem and the signals were damped. So the fill rate, again, there are two types of fill rate. You can have a physiological fill rate. Basically body weight in kilogram divided by 4, but the typical filling rate is often a little higher than this. It is non-physiological filling. Whether it makes a difference, maybe yes in certain cases, but not in all cases. And again, the actual, and remember that the actual volumes, what you get at the end of filling may be different from what you have filled, because there may be diuresis from the patient. Often the patient has drunk some water, and maybe up to 20 to 25% of what more than what you have actually filled. So bladder filling, again, I think we have already discussed this. Medium fill, slow fill, and you can do a fast fill is more than 25. And generally the filling is about 10% of predicted bladder capacity. That's also something called natural fill, ambulatory aerodynamics. We'll come to that later. Slow fill, preferable, but not always done. Because the bladder stretching, when you do fast fill, sometimes, it exceeds the rate of stress relaxation, so you may get poor compliance. And particularly in case of neurogenic bladder and in children. So you need to tell the patient to report sensation. This has to be clearly informed. First sensation, and then strong sensation, maximum capacity, all of this the patient has to tell you, so you need to explain to the patient before you start. And when should you end filling? You should end filling when there is a strong but not uncomfortable need to void. Basically, before you start doing the test, see the bladder diary well, know what is the functional bladder volume, and from bladder diary, so you know that this above this, the patient is not probably going to be uncomfortable to hold, and then that's when you should need. And a strong desire to void should be indicated on the graph. In fact, all these markers should indicate on the graph. And when you stop the pump, you must give permission to void, not when the pump is running. And finally, you should also always calculate the PVR and the voided percentage, which is a marker of the voiding efficacy. So this is the formula: voided volume by voided volume plus PVR into 100. That is the voiding efficacy. That will give us how efficient the voiding was. So in 2016, certain new terms have been introduced: cough pressure leak and all that, leak point pressure, cough issue detrusor overactivity, rectal contraction, straining after contractions. You can read that from the document. We'll share it in the WhatsApp group. So finally, when you have to report, how do you report? Your report, when you do for the UDS, it must include the voiding position and the representativeness. The patient has to say whether the voiding was representative or not. And you must also mention during introduction of the catheter, was there any sensation, or did he contract the sphincter? What was the patient's position? Was it supine? Was it sitting? And did the patient's sensation, was it normal sensation during the filling phase? Did he have any urgency or loss? If you have done sort of a sort of Valsalva leak point pressure or some sort of stress test, you need to tell whether there was what sort of stress test was used. If you use an accessory test, you need to mention that also. Finally, you need to give a judgment on the technical quality and the clinical reliability of the test. And you need to mention at the end whether the test was representative for the patient. So finally, I like to end by saying aerodynamics is as reliable as the person who evaluates it and reports it. Thank you so much.
This is like, yes. So good morning, everybody. I bring to you all a practical scenario of a man or woman presenting with lower urinary tract symptoms, whether it is storage predominant or voiding predominant. And we all know that we have been taught how important is a careful history, a thorough history taking, a careful physical examination which involves a focused neurological examination, the urine complete and culture, validated questionnaires, and the important tool of bladder diary, uroflelometry and PVR. I think this is the basic workup for any man or woman presenting to us with lower urinary tract symptoms. So in my presentation, I'll be talking about uroflelometry and the PVR estimation and the importance of bladder diary. We have seen that in our wards or when we are working as a resident, we are doing the uroflelometry quite often in a patient presenting to us for a BPH evaluation or for incontinence evaluation. It's a very simple, non-invasive and initial screening tool for anybody who presents to us with the lower urinary tract symptoms. It's basically a graphical plot of a urine flow rate along with the time with certain parameters. And we all know that how a maturation cycle is involved of storage phase and the voiding phase. And this uroflelometry is focused for the voiding phase, which involves the three key components of pelvic floor or external sphincter relaxation with the bladder neck opening and the contraction of the detrusor muscle. This is a graphic representation of a uroflelometry where you can see there are many parameters which are important. You can see the flow rate mentioned in milliliter per second on the y-axis and the time in seconds plotted on the x-axis. Along with that, you can see a bell-shaped curve with a top showing as a maximum flow rate, which is represented as the Qmax, and a line perpendicular drawn down toward the x-axis shows the time to the Qmax. And the whole width of this bell is represented by the flow time. And down are graphic representation of two abnormal uroflelometry. I'll be coming to these a little later. For the sake of convenience, many articles have classified the flow curve into normal, the prosthetic type, the fluctuating type, the fractionated, and a Pleshu flow curves. On the right side of this slide, you can see a bell-shaped curve, which is typical of a normal flow curve, and down is seen a dotted line, which is a Pleshu-shaped curve, suggestive of a stricture, and another curve which is with initial rise and with a long downslope, which is a constrictive type representative of something like a BP obstruction because of BEP. It is not any uroflelometry graph you have to take casually. There are many parameters which are there on the uroflelometry graph. You have to make note of that. You have to interpret all these parameters correctly. For the sake of residents, I have put all the terms which are to be taken or interpreted: the total voided volume, the average flow rate, the maximum flow rate, computed maximum flow rate, the time to max flow rate, the voiding time, and the flow time. There's a difference between the voiding time and the flow time. The voiding time is the time taken by the person to void. It includes the post-maturation tribble if it is more than 2 ml per second. But the flow time is the time taken by the patient, the start of voiding, and at the time when the first voiding reaches 0. This is the difference between the flow time and the voiding time. The delay time is when the request to urinate is made and the actual maturation started and the graph starts rising up. That is the delay time. In the interval time is the total time during the entire voiding time until the patient has passed voiding. Uroflelometry is not a simple test. It needs little effort and it has to be done correctly to get the good reading, the correct reading, and then to interpret it correctly. The patient has to be counseled what the test has to be done. His cooperation is very vital to get a good graph. Patient has to be made sure that he is comfortable passing urine in a private room so that the psychosomatic effect on the voiding is avoided. The excessive body movement during urination or touching the uroflelometry during the time of voiding has to be explained to the patient. The patient has to be asked in which position he'll be comfortable voiding, whether sitting or voiding, and whether how he has been voiding earlier in the same position can be asked him to void in that position. And we should be very careful when we are dealing with the old patient, because we know that how old patient cannot be asked to store urine for a longer period. They void much frequently. They have sometimes comorbid issues related to cognition or related to tremor and all that. So everything should be made note of that when you are asking a patient to go for a uroflelometry test. All these things are important because you need to have a good graph to interpret it, because after interpretation only your management may pursue forward. For a good uroflowmetry, the bladder should be filled to more than 150 ml, and what Dr. Arabind was telling is it should not be overfull. More than 400 or 450 sometimes doesn't give a correct uroflowmetry graph. And if the voided volume is less than 150 ml, you need to repeat it. And if you are finding that graph, the uroflowmetry graph is not gelling with the history which you have taken, or the PVRs are high, and probably you need to do it again. And we know that the diagnostic accuracy of uroflowmetry for detecting bladder outlet obstruction varies considerably. Less than 10 ml is almost carries a 70% predictive of bladder outlet obstruction. But at the same time, the compensation mechanism can make the Qmax more than 50 ml even in the presence of underlying bladder outlet obstruction. And even the Qmax are less than 50 ml, it's very difficult to know whether this low flow are due to bladder outlet obstruction or due to SIR underactivity. But overall, Qmax is a better identifier of bladder outlet obstruction than the Q average. And this is a very important tool which can be used for monitoring treatment outcomes and to correlate the symptom with the objective findings. It is not just a casual print of a uroflowmetry. The standardization of the whole Uroflow graph scaling is very important, and as per the good urodynamic practice guidelines, 1 ml should equal to 1 second on the x-axis and 1 ml per second, and 10 ml voided volume on the y-axis. A sliding average of 2 seconds should be used to remove positive and negative spike artifacts, which Dr. Arabind was talking about. The maximum urine flow should be rounded to the nearest whole number. As we mentioned, 10.25 will become 10, and the voided volume also rounded to nearest 10 ml, 342 or 344 or 340 will become 345. And all this uroflowmetry graph, when it is given to you by your assistant or everybody, should have a later your conclusion format, which should be 3 important numbers: the maximum flow rate, the voided volume, and the post-void residual urine. So this is one of the example where you can see the artifactual spikes in the flow curve have been rounded off to give a smooth line. This is done manually. And the actual computerized maximum flow rate of Qmax of 21.3 has been rounded to now Qmax of 17 ml. This is the important. So all this the artifactual spike has to be rounded off to this, and you can see the final impression of 17, 180, 20. It indicates the Qmax, the voided volume, as the residual urine. All these things are important and has to be done by you once you get the graph. As per the guidelines, the uroflowmetry is done in the initial assessment of mailers, and it is important to perform uroflowmetry prior to medical or invasive treatment. I'll just bring a few case scenarios which I have taken from the literature, just to keep focus on the graph. That probably will help you in picking up the curves of the uroflowmetry and trying to understand what we are dealing with, the underlying problem. This is a 78-year male who presented with storage LUTs, predominantly urge frequency and urge incontinence, and is being treated with alpha blocker for 21 months. Here you can see the flow rate, which has a normal flow of around 21.3 ml per second, Qmax of 22 ml per second, voided volume of 207, and probably this indicates the bladder outlet obstruction or the BPH obstruction is unlikely and probably symptom related to the overactive bladder. Here you see a graph which is showing an initial sharp spike with a little longer slope in a male who is 70 years, presented with again a storage symptom and is having this symptom and on treatment for the last 1 year. His Qmax is 21.5 ml, and the impression you can make by seeing the initial spike and the overall curve shows this a normal Qmax. Probably the initial high Qmax may be due to the holding of urine and the terminal detrusor contraction occurring just at the initiation of urination. You can make note of a sharp spike at the later part of the graph, which indicates the terminal dribble. This is a 83-year female with the storage symptom with voiding difficulty, with no urgency, no stress incontinence, a poor flow of 5 ml per second of Qmax, voided volume of 200. This is typical of a urethral obstruction, and it was a urethral stricture in that lady. This graph you can easily make out up going back to the baseline, then going up in a 78-year man with the history of TRP done 5 years back. The Qmax is 6.3 watt, but you can make it, the flow pattern looks fairly okay. So this probably looks like a suggestive of a low detrusor contractility without any evidence of bladder out obstruction. So it is important to look at not only the numbers of Qmax or Q average or flow time, it is important to make note of how the flow curves are going and trying to interpret it deeply along with the what history you have taken and what other tools you have, whether Bladder Diary or what you have in your hand. This is a very important observation which I found from an article published. It is a retrospective study, so probably with low evidence. What they have done is they have tried to figure out whether the uroflelometry parameters can discriminate between detrusor underactivity and bladder obstruction. Actually, it is very difficult. What we understand is whether the flow is poor, it may be due to number of causes. But whether there is any parameter where we can distinguish. So this group from Korea studied the delta Q, which is a difference between the Q max and the Q average in patients with bladder out obstruction and the detrusor underactivity, and all these patients with this number had already undergone a urodynamics, and they compared with the urodynamic finding. What they concluded is that delta Q will be lower in the patient having underactive detrusor because of diminished detrusor function, which decreases the flow rate, both average and a maximum, but it will be higher in bladder out obstruction where you have a normal detrusor contraction. And probably they concluded this can be a predictor of discriminating underactivity from bladder out obstruction in men with the voiding LUTs. But again, this is a retrospective study with the low evidence. Again, how many of you know about the flow EMG? So this is to bring to your notice that a flow EMG is another investigation which takes in account the Uroflelometry plus the added component of doing the EMG by putting the surface electrode in the perineum and try to see whether Uroflelometry can predict something about the underlying pathology, which can be dysfunctional voiding or any other pathological finding. So this is one of the study which has been published in Indian Journal of Urology, where they have tried to categorize the flow EMG into 4 types. The one being the characterized by active pelvic floor activity during the voiding, which was a dysfunctional voider, and then you have the voiding with a quite pelvic floor with almost no activity, with the reduced voiding, which was suggestive of idiopathic detrusor overactivity, and then we have a prolonged flat trace with the quite pelvic floor with a large voided volume, which was suggestive of a detrusor underutilization. And then there was the 4th type with a prolonged lag between the start of pelvic floor relaxation and the volitional voiding and the start of urine with a quite pelvic floor, which was suggestive of bladder neck dysfunction. If you see the 4 types of graph, the first one you can see the top is the EMG activity, the second is the Uroflow curve, and the third one is the voided volume. The graph on the left side shows the voiding with a quiet pelvic floor, which is a little normal, but overall, actually the flow are poor. On the right side, you have the flow which is prolonged and little staccato type with a active pelvic floor, which is suggestive of dysfunctional voiding. All these graphs are taken from the children, and later all these have been subjected to urodynamics. The third is what you can say the prolonged voiding again with a short tower of not a typical bell shape, but a quiet floor, which was suggestive of a deducer overactivity. And the last is a long prolonged phase with a large voided volume with a quiet pelvic floor, suggestive of the underutilization of the deducer. Another study which I found was whether Uroflelometry parameters, what we talk of Q max, the Q average, and the flow curves can diagnose the overactive bladder. So this was a study where they tried to put the curves and made a diagrammatic representation that if you can see the blue curve, which is going with a sharp spike and with a slow slope down, is something like which can be due to deducer overactivity. The dotted curves is a normal curve, and the dot with the short dots probably is something related to urethral obstruction, maybe the urethral stricture. And this was a study where they have taken a flow index. This is a ratio of a Q average and Q max, which is additional marker which can be used for differentiating the patients with overactive bladder and the stress predominant urinary incontinence from a group of mixed urinary incontinence and the stress incontinence or the mixed urinary incontinence. So they were trying to, from these parameters of flow index as well as the shape of curves, they were trying to differentiate the woman from the overactive bladder and the stress urinary from the mixed urinary incontinence. Again, is not only the idea is the people have used different parameters and different indices to try to figure out something can be concluded from these studies. But all the studies which I am quoting have been not only on Uroflelometry, but all they have been correlated with the urodynamic study later on. So this is Uroflelometry is important initial investigation for any woman presenting with a low unit income. The method how you do Uroflelometry with adequately filled bladder, repeating it again if the results are not satisfactory. The interpretation of not only the numbers but as well as the curve is very important. The use of Q delta and the use of the shape of the graph and the flow AMG are the studies which are the retrospective study with low evidence has been used to differentiate the underlying abnormalities in children or men and women presenting with low unit X symptoms. I come to the second issue that we all know that once we have done the flowmetry and we all bring them back to the ultrasound room and we do the estimation of the post-void result urine, and sometimes this can be done by catheterization also. So this post-void result urine assessment can be done by ultrasound, a bladder scan, a portable bladder scan, or catheterization, which is an ideal. This is only a small difference is there between the volume estimated by transabdominal ultrasound or catheterization. And when you are doing, when you are busy scanning this patient for different diseases and you are sending the patient flowmetry, make sure that you have asked the patient to come back to you soon, or you make a note that once the patient has gone for flowmetry, you see this patient within at least 5 minutes. Don't let the patient wait outside your office or outside your ultrasound room for longer, because that will give you a wrong estimation. And it is very important that you ask the patient whether the voiding in the flow room was the same as you experienced at your home. This is very important. And we all know that it's always a question mark, what is the significant PVR? And this is a common question which is asked in the exam, both in neurogenic alerts as well as neurogenic alerts. What important to understand is no level of post-void result urine mandates invasive therapy, and there is no PVR cutoff yet established for decision making. Can the post-void result urine differentiate between bladder out obstruction and reducer underactivity. We all know it's very difficult. But one thing we know is a high baseline PVR is associated with increased risk of symptom progression in a patient, the male patient presenting with LUTS. And monitoring of changes in PVR over time allow the identification of patient who are risk for acute urinary retention. And patient with the high PVR, they need close monitoring than the other patients. And there's a good relation of Qmax with the PVR, but not with the IPSS, meaning thereby the patient is complaining of hesitancy and sense of incomplete evacuation, may not have the PVR on when you do estimate this post-void residual urine. Few examples of measuring post-void urine in clinical scenarios. In bladder out obstruction, we all know that residual urine increases as the severity of bladder out obstruction increases. Abnormal measurement of free uroflelometry or PVR can detect only a voiding dysfunction without indicating bladder out obstruction specifically. In certain cases of bladder out obstruction, reducer underactivity may be the only cause of large PVR. That means the BO may persist along with the reducer underactivity. And high volume PVR is associated with increased risks of LUTS deterioration and is considered a predictor for progression of BPO. And again, there is some evidence that large PVR may indicate reducer underactivity and predict a less favorable response to the treatment. But as such, PVR is not considered as a contraindication for watchful waiting or medical therapy. 50, 100 or 150, any number is not a ground for subjecting the patient to intervention, whether it's a minimal invasive or a endoscopic intervention. And the use of residual urine measurement is considered optional in men with uncomplicated LUTS undergoing non-invasive therapy. Again, no level of residual urine mandates invasive therapy, or no PVR cut point is established for decision making. Again, in female it also, the estimation of elevated the residual urine is very important, and elevated residual urine is not uncommon in women presenting with stress urinary incontinence and overactive bladder. So both these conditions are related to the urinary leak or the storage symptom, but there may be associated increased residual urine. And absence of voiding difficulty is not a good predictor of low PVR in the woman. There is a lack of evidence in men with urinary incontinence, but PVI residual urine estimation may help to distinguish the patient who may deteriorate with time. Available evidence is limited, but the antimuscarinic drugs, especially the tolterodine, the Soliton, darifenacin, should be considered only when the PVR is low. They tend to increase the PVR as compared to the mirabagrone, which has less effect on the residual urine. And the residual urine measurement is also recommended in the management of female urinary incontinence. Again, the residual urine estimation in children is also important in the selected condition with voiding LUTS, recurrent urinary tract infection, and the congenital abnormalities like VU reflux, valves, and the neurogenic bladders. This was a study I picked up from investigative clinical urology. Interesting, what they have tried to figure out is whether the post-void residual urine ratio can be used to predict the underlying condition. So what they have done is, we have one voiding bladder efficiency term where the voided volume is divided by the total volume. They did reverse. They took the ratio of post-void residual urine divided by the total voided volume. That is the voided volume plus the residual urine, and the numerator was the post-void. This is called the post-void residual ratio. And they have taken this ratio and compared with the urodynamic tracing. What they figured out is, if a PVR ratio is less than 20%, it is considered as low risk. If the PVR, post-void residual urine ratio, is more than 20%, it is a high risk. But when it goes to more than 40%, then probably it is more likely a predictor of an underlying condition, which is an association of bladder outlet obstruction and reducer underactivity. This was one of the study, again, retrospective study with low level of evidence, and there are not many studies who have quoted this ratio in the forthcoming study. So, to conclude, the post-void residual urine is adjunct to the uroflelometry, and it's difficult to distinguish between outlet obstruction and underactivity just by seeing the volume of the residual urine. PVR ratio, again, only one study, low evidence in distinguishing between, especially the high-risk patient who have associated BO along underactivity. Large volume of residual urine, probably a low level of evidence with a pointer towards the reducer underactivity. Coming finally to the bladder diary. Time is there? Yes. Okay. The bladder diary, as per the International Consultation on Continence, any patient with urinary symptom, the use of simple frequency volume chart or bladder diary is highly recommended to document the frequency of urination, the volume of urine voided, incontinence episodes, and the use of incontinence pad. And I think everybody would have used this chart in there, or they will be having in their OPD or in the ultrasound room, or there in the UDS lab. This is a bladder diary which is frequently used, and there are different parameters. It comes in the portrait form, a single sheet which has the number of voids, the voided volume which a patient measure at home with a measuring container, the amount of fluid he takes or she takes during the day, the time of incontinence, and the bladder sensation along the time, at the time of incontinence, and the pad use. And usually it is a 3-day diary. It should be a 3-day diary, but a 7-day bladder diary provides a little more accuracy and responsiveness for a patient with the urinary incontinence of more than 3 per day. And a month bladder diary will be necessary to detect 50% changes in a urine incontinence for patients with only 1 leakage every 2 days. But as per our USA guidelines, even if for 1-day diary, which is properly maintained, which has a full mixation cycle along with an inspector, can be used for a good interpretation. And to conclude, this is our guidelines which has been published in Indian Journal of Urology. Dr. Sanjay Sinha, who is sitting here, is the convener of this guidance, along with the faculty who are sitting here. Please read this guidelines. It is very useful and very handy, especially when you are managing a case of a low unit action symptom. Thank you very much. Any question I'd like to answer.
We'll have the inauguration now. We are really grateful to Dr. Bhaskar Rao, who is the Managing Director of KIMS Groups of Hospital, for the help rendered that made this program a reality. And it would not have been possible without his help. I would like to invite him to the dais, also Dr. Arun Chawla. Dr. Gopichand, please. We are first going to have a lighting of the lamp by Dr. Bhaskar Rao and Dr. Chawla, and then a speech by the chief guest.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यम्
I now invite Dr. Bhaskar Rao to say a few words.
Good morning to everybody. Let me congratulate the Urological Society of India and the Indian School of Urology has given the chance to organize to Krishna Institute of Medical Sciences. I congratulate our urology department, Dr. Gopichand and Dr. Panda, Neil Trivedi, all the other people in the department. Actually, this is a very good initiative. We always think once we get an MCH urology, that means we are perfect. The seed starts only there, not only for urology, for even I am a cardiothoracic surgeon. The starts of learning starts there. Till that time, we always feel that we are a student. Once you become a responsibility is once you get these two words. So nothing much. I think I keep watching what Chavala was showing that discussion. And it's very important that we all know this type of learning after post MCH or during practice. You learn more, it will be helpful. So I'm very happy to participate in that and to create this type of environment by our department. It's good. If you permit, because it is an Indian School of Urology, I can talk a little bit more for 5 minutes. You like it or you don't like it? Eh? Okay, few what you call as dhyan. Do you people have, it's like an interactive session. Only I will take 3-4 minutes. Do you people have selfishness or no? Is it good or bad? Huh? Yes, it's good. Do you people have selfishness or not? Not many people doesn't. So how do you generate selfishness? How do you get into your body or mind selfishness? You need to have an ambition. When you have an ambition, selfishness will come. Selfishness is different from greedy. We should be selfish to grow ourselves. That's our ambition has created. So what is then when you have an ambition to grow, when you have a selfishness, how do you think you should grow? What are the drivers for your growth? Discipline and attitude. If you have the discipline and attitude, growth will come. You don't need to do anything else. We are supposed to learn up to the intermediate these two things, attitude and discipline, but we learn other than these two things. Am I correct? So how do you get this discipline and attitude? What is the driver for that? How do you get your discipline and your attitude should be set right on your own? It's a feedback. self-feedback. Whatever case that you do, whatever the talk you discuss with the patients, if you're able to analyze yourself as a feedback mechanism, that will put you into a sort of a discipline, and that will create a more attitude towards the patient. So that then automatically the practice will go. I give you some simple example that Uroflelometry. I was thinking I want to create a good Uroflelometry and put all the men and women come in a waiting hall to come there. My selfishness is there to improve the Urodynamics mission as well as the patients to all my urologists and gynecologists. But they never able to agree each other. Because my patients are females, they will be able to feel bad. If my patients are men, they may not be able to club. The factor what my selfishness is, if they join together, they are all same age people who get the same symptoms. They go and convey to their spouses so that they will add more and more patients to you. So that is my selfishness. With that, both urogynec department as well as the urology department will grow. But they never agree to each other because we want separate missions, separate things, separate. So with these few words, I think, I don't know whether I've been overboard on these things. And please keep these things, will definitely help you. Thank you very much.
I request Dr. Arun Chawla to kindly hand over a bouquet to sir. We need to give it to him. Sir, the gifts we will be giving now, sir. So, sir, Dr. Chawla would like to say 2 words. Sir, we have some gifts.
Good morning to all of you on behalf of Indian School of Urology, USI. Actually, when we had our annual conference in Ahmedabad, which was a hybrid conference, and when the new leadership took over, it was decided that we'll be doing some programs which we have missed during the COVID time, and some new programs which are meant both for resident as well as the USA members. And this was one of the programs which we have kept in our objective. If you go before the COVID era, we have already done the program on urodynamics, at least 3 or 4 program under the aegis of USI, but because of the COVID, we couldn't continue. And it was our endeavor to revive this urodynamics program on urodynamics, keeping in view the scenario which we are seeing in the current practice. We have more number of reagents now. If you put the MCH and the DNB stream, we are close to 400 per year. And this is a very good number. And our objective is that out of these 400, we should have some percentage who should be dedicated to the specialization of function urology, and not taking the stereotyped path towards the uro-oncology or the robotics. With this endeavor, we thought of many programs, and this was one of our aim to hold this program. This program initially was to be done in Delhi with Dr. Pavan Vasudeva, but because of so many activity happening in Delhi this July, so I just requested Arvind whether we can have the program in one of the venue of the south, and later in the second half of this year we can go back to the Delhi. And Arvind was very quick to take this opportunity and within 1 month we have seen that everything was script of the program, the venue, and the all logistic arrangement have already been taken place. And this was just because of his passion and trust, especially to this section of urology, as well as his keen interest in teaching and his interest in passing on the dissemination of knowledge to the resident and as his fellow colleagues. So that was very great of him to accept at the very short notice and do this program. And he's doing it in a very good way. along with Arvind, I'll thank Gopi and Dr. Bhaskar Rao for giving us such a good venue to have this program. And I'd like to thank our faculty, which includes Dr. Sanjay, who's a key architect of so many programs on functional urology, both under the aegis of USA as well as on the global platform, Dr. Nikhil, Dr. Pavan, Dr. Prashant, to be part of this program. I think the presence of faculty like this who are the master in this field will be very helpful in planning the next program. Whatever we do here, we'll review our this whole day program and try to come with a bigger and better program next year when we go to the next venue in Delhi. Regarding KIMS, I have not only associated with Arvind. Gopi is a very good friend of mine. Actually, when he was a SOGA secretary, I have been working with him, and I was secretary of the South Zone. And interestingly, one day when this KIMS IPO has opened, so that was the last day to file the IPO, and I called Gopi that what is your take on that? He held the phone for 4 or 5 minutes and tell you go for it, but I was too late because I scrubbed for the case. And I missed that deadline, and the IPO opened with at least 30 or 40% premium. I remember that, so that I missed that opportunity. But we are here because of this program, and I'm very thankful to Dr. Bhaskar Rao for giving us a good venue on all the logistic support. For residents and all the members, I like to urge that please stay proactive during this whole day proceeding. This is a very useful program for you, not only for the examination point of view, but for your selection of a specialty or section of your choice when you finish your 3 years. And probably we need more people who follow in this specialty, because it's a very interesting specialty. And we see the Uroflelometry being the ECG of bladder, and the Urodynamic being the echo of the bladder. So you can imagine so many ECG and echo you will be doing in your patients. And then the lower unit tract symptom is the most common symptom. When you start your practice, you will see that number of patients of this problem will be much more in number than the stone and the oncology load or the andrology load which you will be seeing. Again, a kind request to just make note whatever notices are coming in the WhatsApp group, in the resident WhatsApp group, please join the ISU program. We have one Euromed program coming up on 6th and 7th of August, which will be in a Gurgaon facility, Olympus Gurgaon facility, which have 6 modules, RARS, PCNL, the TRP, the flexible cystoscopy, the PCNL including 2 both with fluoro and without fluoro, and the robotic module by Medtronic. So very interesting, hands-on. Again, those who are not exposed to different procedures, they will have a great time in performing a simulation procedures, actually giving almost a real case scenario type of feelings. And then we have on 28th of August a cadaver workshop program, which will be in KM Mumbai. We'll be having the bowel segment as well as the kidney harvesting and kidney transplantation, and down we'll be having the different type of urethroplasty and penile processes. So this is up to August. Whatever information will be there will be put on through the mail as well as on the resident group. So I request all the residents to just stay active in the WhatsApp group and feel whatever is in your area of trust, please apply and well on time, because all these courses are with the limited numbers, because all hands-on courses, for that you need to have a fixed number to give or to impart a good knowledge and a good experience if it's a hands-on. With this, again, I like to thank Dr. Bhaskar Rao, the whole management of KIMS staff, Dr. Arabind, Dr. Gopi, and my faculty, and all the residents who have enrolled for this, and happy learning to all of you. Thank you very much.
I request Dr. Bhaskar Rao to kindly give the faculty gifts. On Dr. Arun Chawla. Dr. Sanjay Sinha. Dr. Pawan Vasudeva. Dr. Prashant Naik. Dr. Vipin Pal. Dr. Nikhil Khattar. Dr. Gopichand.
Dr.Arabind Panda.
We will restart our program now. I think Dr. Pawan has to oh, yeah. I talk. Yeah, so let's proceed with the program. This is a this is an overview of invasive aerodynamics and duplicate sites. No? Okay, so I'll first go through the basic physics behind aerodynamics. The basic physics of aerodynamics is about fluid dynamics, the physics of fluid dynamics. What we do know is both liquids and gases are fluids. But the difference is gases are highly compressible, fluids are not. We all read Pascal's law when we finished our 10+2. We read Pascal's law, and Pascal's law is basically about the transmission of pressure in fluids. And basically there were two variations. The one variation is the difference in pressure between two elevations of fluid in a column is determined by the weight of the fluid in the individual column. So delta P, which is change in pressure, is equivalent to the fluid density into gravity into the difference in the elevation between the 2 points in the fluid column. This is the formula. But what we need to remember basically, because of Pascal's law, any volume of liquid in a confined rigid space, when you apply a pressure, this pressure is transmitted equally, instantaneously, and with high fidelity throughout the liquid volume, just like this. It's very simple. Gases, on the other hand, are compressible. They don't behave like liquids. So gases have the effect of decreasing the fidelity of pressure changes and the force application relationship. This is called damping. Now, I'm telling this to you because we use fluid charge transducers for aerodynamics, and if there is a bubble of air in that tube, you are not going to get a good tracing. And again, when fluid flows through tubes, there is a resistance between the fluid and the vessel wall. This resistance is a formula you can always calculate. Resistance is equal to change in pressure divided by the flow, change in flow. So by this, we can actually determine the outlet resistance, like the bladder outlet resistance and the bladder contractile strength. If you have a non-living system, you have tubes, then this resistance is a constant. This doesn't change. But unfortunately, when we are dealing with humans and we are dealing with aerodynamics in living systems, this resistance is dynamic. So detrusor pressure at the maximum voiding flow rate, that is P det Q max, and the maximum voiding flow rate, the Q max. These are the most two important figures that you should take home when you are doing aerodynamic study. And if you know the P det Q max and the Q max, you can use a nomogram, and you can make a nomogram, and in the regions of that nomogram you can see which degree has more outlet resistance, which is equivocal, and where there is no obstruction. So again, something called compliance. This is the important term. I told in my earlier talk also, it's very important that you know about a safe bladder. The whole program today is about knowing which bladder is safe. Now, you want a good compliance bladder. Compliance is inverse of stiffness. You want a good compliant bladder, and it's an important component in this aerodynamic analysis. Compliance is change in volume by change in pressure at a point. So a highly compliant bladder, which is normally how it should be safe. It changes little in pressure with increasing volume. So you increase the volume, but the pressure does not change. All of you who have done aerodynamics will notice that the graft stays more or less flat in a well-compliant bladder till the end filling pressure, till the maximum capacity of the bladder. After that, it may increase slightly, but it doesn't really change. But in a poorly compliant bladder, the pressure starts rising as soon as we start filling the bladder. What happens is, beyond a particular point, there was this study by Maguire who said 40 centimeters of water. This was an arbitrary figure he took. He just took a log logarithmic point. He took a point as 40 and he calculated below it and above it, and he concluded in that paper that pressure in the bladder more than 40 centimeters of water are actually going to damage the upper tract. Now we know that 40 is too high a figure. I would be more comfortable with a figure of 20 centimeters of water. So if you have more than 20 or 25 centimeters of water pressure in a bladder, over a long time, it is likely to damage the upper tracts and cause renal failure. So you want a pressure that is below this threshold, about 20 to 25, and therefore you want a good compliance in the bladder. So all the drugs that we are giving, whether giving anticholinergic or whether doing augmentation or injecting Botox, all that you are doing to reduce, to increase the compliance of the bladder and reduce the stiffness of the bladder. A low compliance bladder changes pressure more rapidly with filling volume. So when we talk about setting up the equipment, this is the modern aerodynamic machine. What it has, this is the heart of the machine. These are the transducers, and this is the pump, and this is the monitor, and this is the computer which sort of processes the entire signal. If you talk about subtraction systemetry, I have already discussed fluid-filled lines. It requires the following component. It requires transducers to measure pressure, fluid-filled catheter to transmit the intravesical, intra-abdominal pressure to the transducers. What we know is the bladder pressure is the detrusor pressure, and that's a subtracted pressure. P det is equal to pressure in the bladder minus the pressure in the abdomen, because the vesical pressure is actually detrusor pressure plus the abdominal pressure. So you need a second intravesical catheter to fill the bladder, one intravesical catheter to measure the bladder pressures, and you need another catheter in the rectum, and or in the females you can use the vagina or even in a stoma to measure the abdominal pressure. So you actually have 3 lines, out of which 2 are connected to transducers, 1 is connected to a pump to fill the bladder. And then you need an infusion pump. This is basically a roller pump. It works by the peristaltic principle. It sort of rolls. As it rolls and compresses, water is pushed inside at a steady rate. You can control the rate 10, 20, 30, 40, 50. Whether you want slow fill, medium fill, or high fill, physiologic or non-physiologic, you can control those speeds. And finally, when the patient voids or leaks, you want a flow meter to measure the flow rate. It's quite simple. Actually, if you look at it, it's quite simple. The whole machine is quite simple. So this is a diagrammatic representation. So here you have a peristaltic pump which is pumping water inside the bladder. You have another tube which is connected to the P-vest. You have another tube in the rectum or the vagina which is connected to the abdominal pressure, measures the abdominal pressure. So this bladder pressure is actually the vesical pressure minus abdominal pressure. Correct? So vesical pressure is detrusor pressure plus the abdominal pressure. If you subtract the abdominal pressure, what you get is subtracted detrusor pressure. I hope this point is clear. And then you have this computer, you have a flow meter, you have computer control, and if you want to do urodynamics, you need a particular table and a C-arm. Always do a free uroflow before starting, and when you put the catheter, check the PVR. This is important. You must do this before starting any invasive aerodynamics. So armamentarium, I've already gone through this. I think I showed this slide in last time. I'll go. This is how Uroflelometry will give you voiding function, systemetry, coordination of the muscular outlet. Then you can do a EMG and you can get bladder outlet function. Then video aerodynamics, anatomy and function of the bladder. So video aerodynamics, what it does, it gives you not only the function, the rest of it gives us only the function of the bladder. When you put a C-arm into it, when you take X-rays, you get also an anatomical correlation to that function. So invasive is the systometrog in aerodynamics, anywhere where you put tubes inside, systometrogram, the pressure flow studies, urethral pressure profilometry, synchronous video CMG, PFS with EMG, and finally ambulatory aerodynamics. So systometry has been described as a reflex hammer of the urologist. It can be done at any age because the person does not actually void. This is the filling systometry. It basically assesses the filling phase, not so much the voiding phase. This is not a part of the systometry. This is the pressure flow studies. So lower interact sensation, compliance, capacity, continence. These are the things which you can assess with the filling phase. And this is what systometry is. And then if you have a voiding systometry, you can assess the contractility and the voiding function in that phase. So again, catheterization, I am again repeating, we have gone through this already, water filled, air charge or microtip. Microtip, you don't need a reference point. In a water filled catheter, you need a reference point, that is the upper border of symphysis pubis. And how do you access? You can do a perurethral, this is the most common. Sometimes suprapubic catheter you can put, you can do it fresh or you can use the old one which is there. Use the smallest size possible because larger size may increase the leak point pressure because it causes an obstruction. And spina bifida patients may have latex allergies and you try to use a latex-free catheter for them. Anyway, most of the catheters we use are not rubber anymore. So methodology, we have gone through this many times. I will skip this. You need to calculate bladder capacity. I have told you in the first talk that one way of knowing the functional bladder capacity is doing a bladder diary for 1, 2, or 3 days, preferably 3 days according to ICS. So you know what is the rough bladder capacity. In children, you can use formulas. Sorry, where did we go? Yeah. So you can use a formula, like a cough formula, H plus T into 30, or you can a non-linear Keffer's formula. If age is less than 2, this is the formula. Age more than 2, this is the formula. 30 is basically all of them give you the value in ounces. And when you want to convert them into ml, you just multiply into 30. So these are all ounces because they are all Americans. They tend to calculate it in ounces. So again, set 0, we have already spoken about this. Calibrate, establish the pressure reference level. We have already gone through this. Superior symphysis pubic, please remember. And then you have, again, I have gone through this again. I have told you many times, pressure, what you calculate is the bladder pressure and the rectal pressure. And the pressure is actually derived electronically by subtracting abdominal pressure from the intravesical pressure. So detrusor pressure is what we are concerned about. It is P-Ves minus P-Ad. I have already told this to you. This is something that you all know already. So systometry, what you do, you want to establish what is the bladder sensation, whether the patient sensation is, he has good sensation or not. So you have a first desire, you have a strong desire, and then you have a maximum systometric capacity. So you know how the bladder is filling. The patient has to articulate this to you. So as I told you before doing the test, you need to counsel the patient, you need to tell the patient, you need to give the information leaflet, and then you need to tell him that this is what I want from you. These are the points where you have to tell me when you first feel the sensation of some urine in the bladder, when you feel the desire in the bladder, when you feel a strong desire, and when you cannot take it anymore, when you have uncomfortable sensation and you want to void. Compliance, these again we have already discussed compliance. So where you calculate at the beginning here and here. This is where you calculate, beginning and the end of the most linear part. So you can see if the pressures are going up, it's generally a poorly compliant bladder. Now, this is then you calculate something called the maximum, you see what is the maximum systometric capacity, it is the volume at which the infant or child starts voiding, and then you want the detrusor leak point pressure. What is the point where the patient actually has leaked when you are doing the filling? If the leak point is below, again this 40 is arbitrary, this figure is from Maguire's classical study. We prefer a figure of about 20 or 25 centimeters of water. If the patient is leaking below 20-25 centimeters of water, the bladder may be incontinent, but the bladder is safe, the upper tracts are safe. If the patient does not leak and the pressures inside the bladder goes beyond 25, 30, 40, then the bladder is unsafe because the patient will not know when to void, and the pressures have gone above 40. It's a risk of damage to the upper tract. So this is the point which you need to remember. So the concept you need to know is of the safe period and the safe volume. So period of 45 is definitely unsafe. So before that, when you go to 40 or 30, this is the safe period for the patient, and the volume is maybe 100. So you need to make your conclusions and plan management accordingly. Cystometry, what are the problems? It's invasive. The patient has to be in a capacity to obey commands, when particularly in voiding cystometry. He has to appreciate bladder sensation, and there's a change in the compliance with age. So if you look at the younger age group, they have good compliance, and the higher age group, the older people, the compliance tends to reduce sometimes. And there is lack of standardization of protocols despite all their efforts, and inconsistent infusion rates. And if there is VUR, if there's a reflux, then obviously the compliance of the bladder will be erroneous, because much of the fluid is going up into the kidney. So you are not really calculating what the bladder compliance is. This is very important. So if the patient has VUR, the compliance will be erroneous, and this is where video aerodynamics scores over normal aerodynamics. Of course, if you have done an MCU before and you suspect VUR, you will be able to get a better. Again, if the patient has a huge diverticulum, again the compliance would be erroneous. So anywhere where you cannot measure it directly, the compliance will be erroneous. So filling cystometry pitfalls, incorrect technique, non-physiological fill rates. The temperature of the fluid is important. The fluid should be at the temperature of the human body. It should not be too cold or too hot. And the test is of short duration, and the environment is uncomfortable. You are talking of somebody who is sitting with tubes inside his urethra and naked in a hostile surrounding, in an uncomfortable surrounding. So sometimes you are not able to reproduce the symptoms at that point of time. Doesn't mean the symptoms don't exist, doesn't mean the problem is not there. So coming to quality control, so I have already said you need to check with a cough before starting to see if all the lines are working well. So this is because coughs, to assess for damping, it should be performed at the beginning, throughout the investigation, at every minute, and also at the end. You should also ask the patient to cough before and after any major event, like if you want to change his position, if he is going to void, or there is a leak. This is because when you are moving the person, the catheters can become displaced during these events. And usually the dampening, you can know which line there is dampening, because the deflection in that line will be less compared to the others. So if deflection is less, there's damping occurring there. You need to find out why there is damping occurring there. So you can see here, this is a normal biphasic blip. You can see a very nice blip here when the patient coughs. And here there is the abdomen is damped. You can see quite clearly abdomen doesn't rise as much as the vesical transducer. So here the abdomen is damped. And if there's a negative here, negative PDET, that means that the vesicle is damped. There is probably a problem with the bladder catheter. So this is how you do troubleshooting. By knowing by actually recognizing these patterns, you can actually troubleshoot. You can see which catheter has a problem. Sometimes these catheters can go near the wall and they can get obstructed near the wall. So you need to maybe withdraw the catheter, flush it again, and see. And I've already told you, if you have not made a hole in the rectal catheter, you can't flush the rectal catheter because it gets over distended. Just make sure there is no air bubble there. That's before you start the test. What about synchronous video CMG, TMG? This is the Rolls Royce of aerodynamics. It gives you simultaneous evaluation of the lower tract anatomy and correlation with the voiding cycle. You can see at this point, when the patient is voiding, The bladder neck has opened, but there is a external sphincter dysynergia. This is something you cannot know with normal urodynamics. If the patient has DESD, detrusor external sphincter dysynergia, this is the test to do video urodynamics. You can actually know that this, you can see the bladder neck has opened up nicely, but there is tightening at the level of the external sphincter and very high pressures. This bladder will deteriorate, this bladder will cause the kidney to deteriorate over time. So the advantages, more precise evaluation and detection of DESD, allow determination of pressures at the moment of VUR. So you can detect phosphorus-reduced compliance. The value in high-grade VUR decides the infusion volume corresponding to the bladder capacity. This you can do. The important point in all this is you have to be at the position when you are doing urodynamics. You cannot let a technician do it while you are sitting in the OPD. When you are doing urodynamics, you have to be on site. You have to see the patient, talk with the patient, and be there when you are doing it. That's the only way you are going to get accurate results. And what are the disadvantages? Video EDS makes the examination more complex, it's expensive, there's radiation exposure, and the child may be scared of all those, the C-arm and all that. So pressure flow studies is the gold standard for diagnosis of bladder obstruction. These are the terminologies that you need to know. Opening pressure, prematuration pressure, pdet Q max, maximum detrusor pressure, maximum uroflow, and pdet Q min. That also is important. That has also relevance. I think that's be discussed, and then you can ask your questions. So pressure flow studies, what is the pressure at that particular flow? It diagnoses outlet obstruction. It gives the assessment of the detrusor contractility. You can also grade how much obstruction, and you can sometimes predict the outlet of a TURP surgery. Not always. So indication, young man with LUTs, predominantly irritative symptoms, urge leak, coexistent neurological diseases, and if you had, the patient had previous radical pelvic surgery, not voiding, you need to do it. He is also indicated in neurologically normal men with symptoms of outlet obstruction with a Qmax of more than 15. Why am I saying this? Because Qmax of more than 15 is essentially a normal Qmax. You are looking at high pressure voiding here. If patient symptoms are significant and you suspect high pressure voiding, don't depend on aeroflow alone, do a UDS, and then if the patient needs maybe a bladder neck incision or a TURP, and that will save the bladder over the long term. And of course, suspected outlet obstruction in females. Problems, what if the patient does not void? That does not mean there is no obstruction. It's just that in a new environment, a patient was not comfortable enough to void. Distension or underfilling, again, you may not have representative curves. Abdominal staining and detrusor overactivity on a full bladder. These are the problems. Ambulatory aerodynamics, these are called natural fill aerodynamics, allows the patient to be mobile. And it can be used in children. It uses the child's natural fill. A suprapubic catheter is sometimes preferred, not a peripheral catheter. Low pressure rise during filling, and flow rates and voiding pressures are sometimes higher. So error, calibration, fill rate, and if you put a large size catheter, it will interfere with the PF study. You need to balance it properly. If you are doing EMG, you need to obtain appropriate EMG signal. EMG is very tricky. Surface electrodes don't often give you the correct representation, and needle electrodes are too painful. You really cannot use it for every patient. So this is improper zero setting. This is what you need to troubleshoot. This is improper zero setting. I have told you how to set the zero in my first talk. You need to open it to the atmosphere and set to zero. This is not the way to set it to zero. And this is a proper zero setting. You can see with the sitting position, or this is about 10, but the PDAT is low. So PVES and PABD is correct, and the PDAT also is correct. So you need to set the zero to atmosphere, not just press zero when you start the study. So technical artifacts, you can have air bubbles, they'll give you some artifacts. As you can see, they are both heavily damped signals. Video UDS, the radio picture, you need to take correct radiographic pictures. The problem is that the urethra needs oblique view, not always possible in the sitting position. You need a chair, you need a proper UDS chair. UDS chair is expensive. So have a proper chair, make sure you can tilt and you can get a good picture of the urethra. Finally, I'll just finish by saying about urethral pressure profilometry. It's a graphical recording of pressure in the urethra at successive points in this length. So for doing that, so basically we measure the bladder pressure, we measure the urethral pressure simultaneously. And that is measured when the catheter is slowly withdrawn along the course of urethra. So you have a particular device which sort of slowly pulls the catheter out when you are measuring the pressure. So urethral pressure transducer measures the fluid pressure at the point where it just lifts the urethral wall out of the transducer side holes, catheter side holes. So the urethral pressure is actually the fluid pressure needed to just open and close urethra. The clinical relevance of this is quite controversial. That's why clinicians don't use it very commonly. So this is how it is. Basically, you have these side holes here, and slowly this is a device withdrawal unit. Slowly pulls this catheter out, and then the pressure is measured in the bladder and then along the urethra. And so the difference is what is the urethral closing pressure, and the maximum difference is the maximum urethral closing pressure. So what you need, so here you have a bladder pressure here, then this you have a total profile and functional profile length, this is the maximum urethral pressure, and this is maximum urethral closing pressure. So this is what it is. So thank you so much. We can go to the next talk by Dr. Pawan. Yeah, we can have audience question and answers. There is time for that, but can I take this out, sir?
Yeah, hello, Arvind. Yeah, since the residents are not asking any questions, I thought I'll set the ball rolling. So, why has air charge catheter and microtube catheters not taken up? We have been listening to them for past 20 years, but
Yes,
they have not taken up. Although we know that artifacts are less and all that, but still we're still depending on fluid charge.
I think we have been hearing it since we were residents together and we used to talk about it. The point is, I feel it has not taken off because they are expensive and they break easily. And I don't think these companies are really focusing on that to make better, more reliable catheters. They are not focusing. Dr. Sanjay, do you have anything to say about that?
So there in the urogynecology community across the world, many places they actually use those catheters.
Okay.
So it's not as if it's not taken off. But there are two issues. One is of course the cost. The other is all the data standardization is with water transducers. Yes. As we just noted, you don't have a zeroing to the atmosphere. I mean the way it's pre-zeroed in a sense. And the data of whatever you have, let's say your bladder contractility index, your obstruction indices, everything is based on the water transducers. Water is easier, much cheaper, and I think that's the reason.
And we have all the standards for the water transducer. Other thing is the rectal catheters come out quite frequently. So I think one thing that they should know, it needs to be pushed 8 to 10 centimeters above the anal verge properly, because once it comes out, you need to do it all over again.
And then the mark, try to push at least beyond that mark. The mark sometimes is low, so maybe little beyond. But again, if you push the rectal catheter too much, I have noticed sometimes they hit the wall.
Yes.
And then you get some of the artifacts too. One of the things which has always bothered me is this hole business. Do you need to make a hole or do you not make? I want to ask all the faculty here. Do you actually make a hole in the rectal catheter? I don't.
We don't.
Do you do, Dr. Pawan?
I don't think it really makes a difference. Earlier we used to, now we don't.
Yes.
But Sanjay, what do you?
To be honest, I'm not sure what my technician is doing these days. We used to make a hole to start with, but as Pawan said, I don't think it really makes a difference. So you need to have a little bit of fluid in it. It should not be over distended. If you are not making a hole, it should be crinkled. So it should not be tight. If you have filled it tight, you're going to get into a problem. So it should not be overfilled. Making a hole ensures it's not overfilled. Having a little bit of fluid ensures transmission of pressure. That's all you need.
I have a last
I
question.
think once you prick the tip of the balloon, sometimes there is some amount of air inside.
That's what I wanted to ask.
So
Once
that
you prick it, air comes inside. Sometimes air comes inside. That one bothers me. Even if you prick it.
No, the air will go out actually. That air goes out of it. So it helps in actually,
No, air can go out, but if you suck the air out and then put the water, that was safe.
It comes to the feeding tube into the balloon.
The pressure within the balloon is always slightly more than the pressure outside the balloon.
But when you put in the rectum, sir, if you look at bladder has lower pressure than the rectum. Sometimes rectal can have contraction and there can be.
So you mean the air from the rectum
I'm not saying yes, it is sometimes what happens, I have seen when I make a hole, I'm not very sure whether it's actually going to transmit or not going to transmit.
I do it routinely. I usually puncture it routinely, but with a very small needle, so that the air goes out of the balloon rather than it cannot come inside.
No, it cannot come inside, but my point is completely, if it completely deflates, completely deflates. Second point people have raised is, it's a leakage of fluid slowly. Does that cause rectal contractions?
I think that's about a very small amount, some 3 ml to 5 ml is what I'm going to put inside. Now, other thing, last question, if you may allow. Hydronephrosis versus hydroerythronephrosis. Upper tract changes, can it have isolated hydronephrosis? This question, yeah. Many patients have that. People with obstructive LUTS has a prostatic enlargement or a stricture, has hydronephrosis. Do you see isolated hydronephrosis?
Isolated, my thing is it has to be hydronephrosis.
Yes.
Because isolated upper tract, it has to go from the ureter up there. At some point, even if it starts as hydronephrosis, at some point of time, the ureter also has to get dilated.
Yeah, it should start as hydronephrosis.
Yeah, not only
Yeah. So,
and similarly, can it be unilateral?
unilateral it can be.
Absolutely.
Initially unilateral and then bilateral. That it can be. That we know it can be. It can be unilateral, then it can become both.
Sir, hydro versus hydroerythronephrosis.
So ultimately, the dilatation that you get in the upper tract is a function of the compliance of the wall, right? Not all parts of the system will have an equal compliance or elasticity. So you will always have some degree of urethral dilatation at different points below the PUJ. But you must have seen any number of patients in whom there's a section of lower ureter which doesn't look dilated and some of the mid and upper ureter is grossly dilated. So you may not get a uniform dilatation across the whole ureter. That might not happen. See, you have a Waldeyer sheath below the lower part of the ureter. Sometimes it may not dilate all that much. But if you have an isolated dilatation only of the collecting system of the kidney and there's zero dilatation of the ureter, then you have to be careful whether you're really dealing with something which is lower tract.
I would not ascribe absolute isolated dilatation to a lower tract unless there is some amount of ureteric.
And also our imaging has to be adequately detected. Okay.
Please.
Yeah, sure.
Good morning, everybody. Thank you, USI, ISU, and Dr. Chawla, Dr. Arvind for this opportunity. So I will be speaking on filling systometry, which essentially means that we will be talking about the invasive urodynamic investigation of the filling phase. Now, so this is the method by which the storage function is going to be measured while we are filling. Now, what are the expectations, or what are we expecting the bladder to do during this time? So we want the bladder during filling to be able to store an adequate amount of urine, to store this urine at a low pressure, have normal sensations. The person should have normal sensations, and during this period there should be no incontinence. So this is what we are expecting the bladder to do during the filling phase, and parameters of these is what we will assess during the filling systometry. For this, the bladder must be relaxed and the outlet must be contracted. Now, before we go to the interpretation of the traces, what should be the position of the patient during filling systometry? So whenever physically possible, it should be either sitting or standing, and there is a reason behind it. This is the most representative for real life situations for which the patient has come to you. And also, if you look at a couple of things like detrusor overactivity, you may miss it if you do it in the supine position. And there was this study which looked at the fact that you may miss detrusor overactivity in a large number of patients if you do it in the supine position. The other thing is stress incontinence also. You may not pick it up if you're doing it in the supine position, and so you would want to do it in the standing or the sitting position. And there was this study which said while they were evaluating urodynamic stress incontinence, which we shall come to, they found they could demonstrate it in 2% when doing it in supine and 55% when doing it in sitting. So you may miss detrusor overactivity in USI if you do it in supine position. So whenever it's physically possible, use sitting or standing. So this is the chair normally which most of us would have. If you have the luxury of this chair, then you could even do it in the semi-recumbent position.
And there are certain situations where you would need to do it in the supine position. For example, if your patient, so this was a C5 injury. So if your patient is a neurological patient, you may need to do it in the supine position. Also, sometimes when you're assessing females with mixed incontinence, you get too much of detrusor, and if you're getting too much of detrusor overactivity during the sitting or the standing position, then you may need, it helps if you do it in the lying down position, because then the DO settles down and you can evaluate the other aspects. Coming to resting pressures, now, so what we need to understand is, when we say resting pressure, we are talking about the pressure when you're starting the urodynamic. Now, initial resting pressures are different depending on the position you're doing your urodynamics in, and these are the standard values which have been given by the ICS. So this is a part of your quality control. When you start your urodynamics, depending on the position, you should be getting these pressures, and if you don't, then you need to look into your system. So since the vesicle and the abdomen pressures will be in this range, the detrusor pressure, which is a derived pressure, will obviously be close to 0. So if you look at this trace, so this patient was being done in the sitting position. So the vesicle pressure is about 20, the abdomen pressure is also about 20, and the detrusor pressure is close to 0. So and if you look at this trace now on the right, this was being done in the standing position. If you look at the vesicle, this is close to 0, abdomen is close to 0, and of course detrusor is close to 0. So the first trace is actually right and the second trace is actually wrong. What has probably happened here is, when you set 0, you're supposed to set 0 with the tubes not connected to the catheter. If you're going to connect the whole system and set 0, then all of this will come. This will become 0, this will become 0, this is a derived pressure, so it will obviously be 0. So you will only get the right values if you are going to set 0 before you connect the tubes which are coming from the machine onto your catheter. So you hold the tubes without connecting to the catheter, set 0 and then connect, and then you'll get these baseline values. Coming to the filling rate, Dr. Arvind has already covered this. I'll just repeat a part of this. So the ICS says the physiological filling rate is body weight by 4. And this is what they call as standard. Now anything more than that is non-physiological. The problem with this physiological rate is, sometimes it is too slow and it takes too long to fill. So for example, if we consider a 50-year-old, a 50 kg woman, and if we divide it by 4, it will be 12.5, and let's say she has a systometric capacity of 400 cc, so it will actually take 32 minutes to fill this patient, which is of course which is a bit too long to keep the patient in that position. If you, on the other hand, if you fill too fast, you may influence the results. If you fill fast, you can have detrusor overactivity, the compliance can be artifactually raised, the sensations may come early. And so a pragmatic approach which has been described by the ICS is that you fill at 10% of the largest voided volume and you add the PVRU to it. So they're trying to standardize what they call as the non-physiological filling rate. If you go back to this same patient, again now 10% of that 400 cc would be 40 ml per minute, which is about, which would take then about 10 minutes of filling, which looks to be a better figure or a better time span. You should remember that patients with neurological diseases, the filling should always be started at what ICS used to earlier say as low fill, which is now they've discarded that slow fill, medium fill and high fill. Slow fill essentially meaning that you started less than maximum being 10 ml per minute. And if you find that the compliance is all right in these patients, then you can increase the rate. For children, again, there are various formulas, and depending on the estimated bladder capacity, you can start filling in children at 10% of that estimated capacity. Now coming to interpretation of filling systometry, so there are essentially 5 areas that I will cover, which you need to see when you're doing filling systometry. The 5 C's: the course, bladder, sensation, contractions, compliance, capacity, and continence, and we will see each of these one by one. When we talk about coarse bladder sensations, so there are three sensations which have been described by the ICS. The first being the first sensation of filling, where essentially the patient now tells you that the bladder is not empty anymore. He perceives that. Sometimes this is confused with the urethral catheter, the sensations which are coming from that catheter, and this perception usually comes at about 50% of the systometric capacity. The next would be the first desire to void, which means that at this time, in his normal life, he would probably go around sometime around this time, and so there is no hurry. The desire is not persistent, but this first desire to void corresponds to his usual typical voided volumes on his diary, and this is about 75% of the systometric capacity. And at this point, he can delay if it is required. And then finally, you have the strong desire to void, which means at this time the desire has become more persistent, and he will probably want to go. And this is at about 90% of the systometric capacity. Now, this is what normal is, and what abnormality can you get? So you could get sensations which are absent. You keep filling and nothing happens. So this patient was filled to about 500 cc, and if you look up, he's not reported any sensations. Now, these sensations could be reduced, which means that he is getting that first sensation of filling, he is getting that first desire to void, but that strong desire or the urge to go is not coming. So this patient, the first desire came at about 700, and then we will come to what to do with the capacity in these patient data, but as far as reporting sensations comes, they could be absent, they could be reduced. Now, they could be increased. And what do we mean by increased? We mean that the sensation comes in too early without any detrusor overactivity. We are coming to detrusor activity subsequently, but this is just a sensation which is not related to the bladder contracting. And what this does is it often limits the capacity of the bladder to less than 250. So if you see this patient, the first desire came in really early at about 43 cc, and at about 140 cc, she was full and had a strong desire. Now, so if you get this, and you think you may be artifact, or it may be an artifact, so one thing you can do is that you should check that you're not filling too fast. And the other thing is, when you fill, the pump gets these micro, there are mini pulsations of the pump, which can be perceived by that patient as sensations. So you stop the pump, and then you see what happens. So first you reduce the sensation, see what happens, stop the pump, and I mean, you decrease the filling rate and see what happens, and then you even stop the pump and see what happens. Now, urgency is an abnormal sensation for the most part, and which is defined by the ICS as a sudden compelling desire to pass urine, which is difficult to defer. And this patient had a detrusor overactivity, and as a consequence of that, she complained that she had a strong urge. You can get pain, and if you do get that, you should note the site and the character. Now, sensations, when you report these patients, so the first C must be reported as normal or abnormal, and you must qualify the abnormality. If it is abnormal, you must qualify the abnormality. Coming to artifacts, so this patient, if you look at the bladder diary, most of the voids here are in the, so there's no void which is less than 200, most voids being 350, 400, 500, 400, 550. If you look at the trace, at 150, she's full. So obviously there is some discordance here, and you must look back at your bladder diary if you get something like this. There is a problem here. So you may have been filling too fast, you may have been filling with a fluid that is either too cold a fluid can cause this, or maybe the patient is uncomfortable, the position is such that the sensations are coming fast. So if your sensations or if they're not matching with the bladder diary or the non-invasive whatever investigations you've done, and you're supposed to do all non-invasive before you do the invasive aerodynamics, then you should sit back, look back, and then proceed. Coming to the second point, contractions. So normally during bladder filling, the bladder is supposed to be quiet or relaxed. If you get an involuntary detrusor contraction during this period, you call it as an IDO. You call it as a DO or a detrusor overactivity. If you have a known cause for it, a known neurological cause, it's called a neurogenic detrusor overactivity. If you don't have a known neurological cause, then you call it as an idiopathic detrusor overactivity. Within this range, now there are a few things that it's not enough to report detrusor overactivity, yes or no. There are more things that you need to qualify, and we will look at some of them now. So the first is whether it is spontaneous or provoked. So if you look at this, there is nothing happening in this abdominal area. The vesicle, there is a contraction, and the abdomen is flat, and so this is a detrusor overactivity. If you look here, the patient was made to cuff, and soon after the cuff, you had a detrusor overactivity. So the first one would be labeled as a spontaneous DO, and the other one would be labeled as a provoked DO. The other thing is you should be aware of what are the kinds of DO which can come. So one is a phasic DO, which we have all seen, which is a characteristic waveform, goes up, comes down. It could be a terminal DO, and what do we mean by the terminal DO? If you look at this slide, this is the place where the patient has been given the voiding command. If you look at the area before that, there is a detrusor overactivity. So at about or near the maximum systometric capacity, if you get a DO, then that is called as a terminal detrusor overactivity, and that can lead to it's difficult to suppress and can lead to incontinence. Then you have a sustained DO, that instead of this the characteristic waveform that was coming, you get a more continuous kind of wave which is not returning to the baseline. Then finally you have the compound DO, and what is a compound DO? You have this characteristic waveform coming, but with each contraction, if you see, the pressure is rising, so the slope is going up. So this is what is called, so it's not returning to its baseline pressure. Each time the baseline pressure is going up. So this is what is called as a compound DO. Now, once you've qualified whether it is spontaneous or provoked, and then you qualify all of this, there are certain more things that you should be able to see. And this is the timing, the frequency, the amplitude, and the duration of these detrusor overactivity. So if you look at this trace, you're basically getting, in this entire trace, there is one detrusor overactivity of 26 centimeters of water. If you look at this trace, now this trace, you're getting multiple detrusor activities which are coming frequently, which are lasting longer, and which have higher amplitude. So all of this has an implication for upper tract. It seems to reason that this is going to trouble less, where this is possibly going to trouble more. So if you just write detrusor overactivity, that is probably inadequate. Now ICS has defined a term as the high pressure DO, and what does that mean? That means that you perceive, as the investigator, you perceive that this DO is potentially detrimental to the patient's renal function and or health. And they've also described a ratio where they say that if this duration of each DO, if you add all this duration, if it is more than 1/3 of the total duration, that is a risk factor for upper tracts in spinal cord injury patients. Now, after we've done all this, then you need to qualify whether your detrusor overactivity is associated with incontinence or no. Now, if you look here, with all these detrusor overactivities, you're getting leak down below, and so they've described a leak point pressure, which is the detrusor overactivity leak point pressure. This is different from the detrusor leak point pressure. This is when you are getting a detrusor overactivity. We will come to DLPP, where it is imperative, where that pressure is being calculated when you are not getting a detrusor overactivity. So detrusor overactivity leak point pressure essentially means that this is the lowest pressure rise at which the leak would occur. So if you look at this graph, this is probably the point. This is the lowest pressure at which this leak would have happened, and so this would be which is 26. So this would be taken as the detrusor overactivity leak point pressure. Finally, within detrusor overactivity, you need to see whether it is corresponding to symptoms or no. So, for example, so the idea of doing urodynamics is you do urodynamics to to reproduce the patient's symptoms. So if that patient came to you for urgency, you're doing it for urgency, so you should be able to reproduce that urgency during the test, and during that test find the pathological reason for that urgency so that you can correlate. So when somebody has a DO, and if he says that yes, this is the urgency, this is the kind of sensation I perceive, and on the urodynamic you are able to demonstrate the DO, then it falls into place that you could reproduce the symptom and find the reason for that symptom. Sometimes it could be an artifact which you should note. Sometimes it could be there and the patient may not be having any symptoms. That also an asymptomatic DO should be noted. The reason is you may be doing, a stress incontinence lady today may be having DO, which is not bothering her, but after you put a tape and after it becomes tighter, that DO can trouble her. So even if it is an asymptomatic DO, it should be mentioned. Now, so second C, detrusor contraction should be reported as either normal or DOA. If DOA, you must qualify whether it is spontaneous or provoked, whether the type of DOA, which means phasic or terminal or sustained or compound, the timing, frequency, amplitude, the duration, whether it is associated with incontinence and the detrusor overactivity leak point pressure, and whether it corresponded to the symptoms or it did not. The third C is the compliance. So normally when we fill the bladder is supposed to, the pressure is supposed to stay quiet. Quiet in the sense it's not supposed to rise when you're filling. And this is because of a property in the bladder which is called as receptive relaxation, that as you fill the bladder, the pressures don't rise. If the pressures do rise, then that is what we are meaning as that this bladder is not compliant to increasing volume. Now, if you look at these two slides, the first one, the detrusor pressure right till the end is fairly flat, and this is a normal compliance bladder. If you look at this, slowly the compliance is creeping up, and the total volume was 290 cc, and when you calculate delta V by delta P, for this it came to be about 7. So, for neurogenic patients, a cutoff of 20 centimeters is taken as abnormal. So if the compliance is less than 20, then you would need to document it as poor compliance. Now, more important is also that when do the pressure start worsening, and then there is an importance of end filling pressures. So when we say when do the pressure start worsening, if you look at these two slides, if you look at the first slide, this is practically flat during the initial phase, but at the end this really goes up and reaches a maximum of 100 centimeters of water. If you look at this, this is creeping right from the beginning and going right till the end, though it reaches only 43, but it's been creeping right from the beginning. So intuitively, if you look, you would feel that this bladder, because the pressures are higher going here, this patient is likely to have kidney damage, and this patient may not have kidney damage. But this is a slide from Sir's paper, which I will. So these two patients are represented here. This is the one who was flat in the beginning, and then he had a sharp rise in the end. And this is the guy who, from the beginning, was going up, but it stopped and it didn't go very high. So it appears that this patient would be at more risk. These are both spinal cord injury patients. And if you now see what happens, so we all know that a higher end filling pressure means a higher risk of damage to the kidney, right? What does end filling pressure means? End filling pressure means as the pressure is rising, if the patient doesn't leak, at some point you will stop. So when you stop at the end of filling, that point is called as the end filling pressure. And we understand that if the end filling pressure is high, then the kidneys are at more risk. So if you look at this patient was doing a CIC at about 300 cc volumes. So if you look at what's happening in his life, during his life, he is actually not being exposed to these pressures because his CIC volumes are in this range. If you look at what is happening with the other patient was doing CIC at about 250 cc. And for this patient, about 230 cc. So for this patient, nearly half of his period he is spending in the high pressure, high bladder pressure area. So it is actually this patient who is more at risk than this patient. So the absolute pressure, along with the absolute pressure, the time for which the bladder is exposed to that high pressure is important, and that is where this concept of safe period, that is where the concept of safe period comes, which means safe period is the period before the time that those pressures start rising. This was from Sir's paper in 2017. So if we look at, so we understood end filling pressure when we say that the patient did not leak. But let's say as the pressure rises, the patient leaks. So what is that called? That is called as a detrusor leak point pressure. And detrusor leak point pressure essentially means as the pressure is rising, the lowest pressure at which the patient leaks is called as the detrusor leak point pressure. Now we must understand that this pressure is being measured in the absence of a detrusor contraction. If you are getting a DO, that is detrusor overactivity leak point pressure, this is essentially that the pressures are rising without a DO interfering. Now it seems to reason that if you have a lower leak point pressure, which means that as the pressure will rise, the patient will leak. So these patients are more likely to be incontinent. But because they leak, the pressure comes down and their upper tracts may be better preserved or get damaged at a later date. But somebody who has a higher leak point pressure, he may be continent, but he also may be at a higher risk of kidney damage. So coming to cutoff for detrusor leak point pressures, now earlier McGuire's article, we all know this figure of 40, and this came from the fact that when they saw these, they divided these MMC patients, and they saw that patients who had a DLPP of more than 40, 68% of them had upper tract issues, whereas the ones who had a DLPP of less than 40, only 10% had. So this is where this came from. But then recently, in 2009, this Italian group also showed that a 20 centimeter DLPP has more sensitivity for upper tract damage. Having said that, in this same study, 18% of patients who had a DLPP of less than 20 also had upper tract damage. So you cannot put a number to DLPP in isolation and say that this patient is safe or this patient is safe. What you could probably infer is that a higher DLPP will put him at a higher risk, but a lower DLPP does not mean that he's not at risk. So I hope I can repeat this, that a higher DLPP would mean that he's more at risk, but a lower DLPP does not mean he's safe. So even less than 20, he could be unsafe, and so DLPP should not be used as a sole urodynamic criteria for decision making. And so this is what came from the ICI, that you should try to keep it as low as you can. So if your patient is going to be on intermittent catheterization and you put 100 units of Botox, your DLPP is 30, and you think now he's going to be safe, you should try to bring it as low as possible, because anyways you're not expecting him to avoid. So that is about DLPP. Now, so the third C, when you report compliance, you have to report compliance as normal or abnormal. If abnormal, you qualify it. What is the value? When do pressures start rising? How long is the bladder being exposed to these high pressures? And what is basically the safe period? And if there is no leak, what is the end filling pressure? If there is leak, then what is the detrusor leak point pressure? Artifacts, so if you fill too fast, or if you have an indwelling, sometimes with a catheter, you may get poor compliance, which is actually not there. On the other hand, if you have high-grade reflux, or if you have a pop-off mechanism, you may miss poor compliance being demonstrated. So this was a MMC patient. As soon as we started filling at 30 cc during video, this ureter started getting filled, and by 40-50 cc, the entire kidney was seen. And on the urodynamic, the compliance was normal. The compliance was normal because the bladder was not getting filled and everything was going into the upper tracts. So if you have a patient like this in which practically everything is going to the upper tracts, then you can't, and if the compliance is not worsening, that does not mean that the bladder is safe. That means that the urodynamics is unable to pick up poor compliance because of a fallacy where the pop-off is accommodating that urine. So, one slide which if you could take with you when you go home, that LUT pressures are critical for the well-being of the upper urinary tract. This is the bottom line that we should all remember. And high pressures, now we don't have figures, but high pressures, whether in terms of a detrusor overactivity, whether in terms of maximum detrusor pressure, whether in terms of poor compliance, high detrusor leak point pressure, high end filling pressure, any combination of this or singularly or combination, high pressures can damage the kidney, and this is preventable. So if kidneys are getting damaged because of this is actually preventable kidney damage. And even today we all know that this continues, and we all see patients every day with this. The reasons are, one, if you see your own patients with neurogenic bladder, nobody is bothered about the filling phase. The patient's discussion with you essentially revolves around, will I be able to pee or no, and how can I avoid intermittent catheterization? That is what their concern is. They don't understand the filling phase. If you look at people who treat these patients, the allied specialties, whether orthopedicians, neurologists, neurosurgeons, pediatric surgeons, their concern also is they will maximum stop at teaching or telling the patient about CIC. They also do not understand the filling phase, and that is where they finish. And if you look at our specialty, unfortunately, neurourology is, we are not interested in, most of us are, this is not a priority area for most urologists. And because of these reasons, even though we all understand that high pressures will kill, we still get these patients every day in our practice, which is very unfortunate. Coming to the fourth C, which is continence. So urodynamic stress incontinence is essentially means that when you are filling, if you get involuntary leak because of increased abdominal pressure, you call it as urodynamic stress incontinence. So there are three incontinence. One was detrusor overactivity leak point, where DO had to be there. Then there was one DLPP, where DO is not there, abdomen is not there, but the pressure is rising. And then the third is the ALPP, where the bladder is silent, but this is because of the abdominal pressure. And the pressure at which this leakage occurs due to increased abdominal pressure in the absence of a detrusor contraction is called as the abdominal leak point pressure. Now, how do you elicit and document this ALPP? One very important thing before you start is that you must counsel your patient what is needed from her. So when you are doing a urodynamic for a lady with stress incontinence who has been, who's come maybe after these conservative measures and is looking at surgery, she already has this reflex that whenever I'm about to cough, I should contract my pelvic floor because that prevents me from leaking. She needs to know that this is not what you want her to do during the test. She must relax for it to be elicited during the test. Now the ICS says you should fill it to 200 to 400 cc and ask her to give a single cuff, and if that doesn't work, then give a sequence of strong cuffs. The rationale behind the sequence of strong cuffs is, if somebody who doesn't understand to relax the floor, and when she cuffs once, she contracts it. If you make somebody cuff repeatedly, it is difficult to keep the pelvic floor contracted. Now, if this doesn't happen at 200 cc, then you fill to capacity, you can remove one of the lines and then repeat the procedure. And Valsalva can obviously be, if you don't use cuff, you can use Valsalva. Now, let's say somebody, you're still not able to elicit USI, what can you do? If you make these women abduct their legs, that relaxes the pelvic floor more, and you may be able to unmask the urodynamic stress incontinence. And of course, you can also shift her to a standing position or give her a physical exertion challenge, in which case the leak will not get documented now on the flow meter, but now you will have to see it. You'll have to, visually inspect the leak. So this patient, we tried to make her cough at around 200 cc, nothing happened. Again, we tried to make her cough after a little longer, nothing happened. And here finally, at the last when we made her cuff at capacity, this is where she leaked a little. And so she had an ALPP of 120. Now, when we say ALPP, we mean which is the lowest pressure with which she leaked. Now, what is the relevance of this ALPP? There are three zones which have been defined, that if the ALPP is less than 60, it is called as intrinsic sphincter deficiency. If it is 60 to 90, you call it equivocal. And if it is more than 90, you call it urethral hypermobility. This has an implication for your management, and we shall discuss it during the case discussions. Artifacts, again, you should be careful before labeling somebody as having stress incontinence. So in stress incontinence, the leak is synchronous with the cuff, which means that the leak will start with the cuff and it will finish with the cuff. If the leak starts after the cuff or persists after the cuff, so it may start with the cuff but it persists after the cuff, then that is a negative cuff stress test, because that may be associated with a DO. So if you look at this, slide, the cuff is here. This is the cuff. There is no leak. The leak is actually after the cuff, and this is what is called as cuff-associated detrusor overactivity. Sir has published a very nice paper on what are the types of cuff-associated detrusor overactivity, and it is a very interesting read, where if you have this picture, this is called as a type 1 CADO, that there is no stress leak, but there is a leak with the CADO. Then type 2 is the CADO is there, but the leak is actually with the stress incontinence. And type 3 when the leak is with both. Type 4, there is no leak. So, if when you do your cuff test, if the patient's leak is not synchronous with your cuff, synchronous means starts and stops, then you should suspect a detrusor overactivity. If it starts afterwards, then it could be because of the detrusor overactivity. If it continues afterwards, it means it leaked with the cuff and also continued later because of the DO. So that is about. So for the fourth C, for continence, you will report it as continent or incontinent, and if incontinent and if urodynamic stress incontinence is there, then you should mention ALPP and qualify it. Coming to the last C, which is capacity. Now, systometric capacity is when you tell the patient to void at the normal desire. That is what we call as the systometric capacity. If he ends up voiding, or when you stop the filling at the end of the strong desire, that is what you call as the maximum systometric capacity. Now, it is important to define the endpoint, which means why was the filling stopped. Let's say there is a patient who does not have any sensations. So when do you stop that filling? So it is said that you see how much he's voided on his bladder diary. You add the residual volume to it. So let's say he voided 400 cc on the bladder diary, has 200 cc as residual. So and he has no sensations. So at 600 you stop filling. You don't keep on filling, So it is important to define when did you stop the filling, whether at normal desire, strong desire, no sensations or whatever. Now also Dr. Panda already mentioned this. If you look at the machine gives you a calculated systometric capacity of what it infused through its pump. That is what the machine is giving you. But during the period that you were doing your urodynamic or you were filling, there is urine which is coming from the kidneys as well. And so you can have a difference of about 25%. That is the max difference that can come, which you may need to factor in when you are making your clinical decision. So if you think your safe period is excuse me. So if you think your safe period for a CIC is about 200, because after that the pressures start rising, that 200 is actually 220 or 230, because some urine also came from the top during your urodynamic. So the ICS, so the machine calculates it from what it fills. The ICS says that you should calculate it as what the patient voids plus whatever residual urine is left immediately after he voids, because that would then accommodate the urine that is coming from the kidney. And of course, there are various formulas for which you can calculate the capacity for a child. So again, capacity is to be reported as XML, and you should define the endpoint. Now, summary, now if you're on site, it does allow you to ask or clarify and extract a lot more information and make the study more meaningful. And if you review the trace later, obviously it's suboptimal unless your technician is, is very well trained. And the 5 C's, the core sensation, contraction, compliance, continence, and capacity, must be narrated not only quantitatively, but also qualitatively. Thank you. Any question? Yes, sir.
Come from Delhi, the weather is really cold. So do you, in practice, do you warm fluids or you don't follow that practice?
So so most of the year we don't, but December, January, sometimes we put it in because the cutoff was if it's colder than 20 degrees, then the study said that less than 20 degrees causes sensations and these two become more pronounced. So so in summers, obviously we don't think there's anything that's too warm, but in winters sometimes we will put it in that chamber to bring it to a lower temperature.
Second is many of the patients who are on catheters. So
yes, sir.
What is your practice? Do you change catheters, check cultures and proceed, or do you keep them on CSIC and then proceed with
Sir, so sometimes if what you want to demonstrate is not coming with an indwelling catheter, sometimes we would shift them to intermittent catheterization for a while, only for the purpose of, because sometimes when you do it with an indwelling catheter, the filling phase is so bad that you're not able to get anything out of it. So only for those patients we will shift them to an indwelling catheter, and then but if it's a standard case where you need urodynamics, the first time we have no problem if the indwelling catheter is there and we do it. For every patient we will not shift him to an intermittent and then wait for some time and then do.
How will you define which group of patients?
So when we do, if we have a problem, then we will I mean, pre the first urodynamic, there is no way to define whether there will be a problem or no. If there is a problem and you are unable to take any information, I mean, then and you need some information for decision making, then we will shift them and then call them after 3 to 4 weeks.
That message is clear.
We don't, sir, can for every patient to shift them on IC before urodynamics, I am not sure if that is practical. You would agree? It would be, but the downside is for some patients they've undergone a procedure and now they are having to undergo one more after some time. But for each patient, I don't think it's possible.
Third question is about the SUI patients.
Yes, sir.
And they're in a sitting position you are doing.
Yes, sir.
And you want to demonstrate, then changing positions, I'm not very sure.
So it's
because most of them will be obese.
Yes.
So putting them are in a different legs they cannot raise.
So it's given that you give them a stool and you make them abduct their legs, and that helps them to relax the floor more. But for very obese people, now urodynamic machines have got what is called as a leak point detector. So with that the urethral catheter that you put, there is something which gets snug right there. So even if the patient leaks 2, 3, 4 cc, the machine tells you that the patient has leaked. So you don't have to visually see or wait for it to, or for that amount to become enough for it to come into the so it's called a leak point detector, which.
In practice, what do you follow? Do you follow changing the position, or you ask them to stand?
I ask them to stand and spread the legs a little and leak. I mean and cuff. I have not tried this. I mean this abduction and.
Sir, is it necessary to fill in a patient who is a dilated bladder, about 1 liter capacity? Do you go on filling up to that, or do you stop at 400, 500? Is it necessary to fill up to 700, 800 when you're doing the hysterometrogram?
No, so it depends the reason for which you're doing a hysterometrogram. So let's say there is a patient who has a lower motor neuron injury and he's been doing CIC 3 times a day and taking out 600 cc. Then I need to reach his usual volumes to understand if he's safe during that that period or no. Versus somebody comes with versus you're doing a test for a bladder outlet obstruction, you want to see whether to do a TOR or no, and then you don't need to keep filling. So it depends on why you're doing it. But many times when you start doing it, after 5-7 minutes, you realize that you don't need to go any further. So for example, the same patient has bilateral hydroureteral nephrosis, came with a bad bladder, known case of MMC, came with a 3.2, came with CKD, reversed with catheterization, the creat comes to around 2, and now you decide I'll do a urodynamic. When you start doing the urodynamic, you do a video, and you see that the urine starts going up. Now you filled 50, 70, nothing is happening to the compliance. But the urine, you're seeing both kidneys are dilated. Now you can't keep on filling just because you want to demonstrate poor compliance. It is implied that the compliance is poor in that case, and you will have to do a procedure. So I don't, if I find that everything is going into the upper tracts, I will stop. Would you continue to...
Practically speaking, it's unusual for a patient who's got 1000 ml, let's say, residual to come directly for the urodynamics anyway. So most such patients would have gone onto a catheter, in which case you suddenly find you can't fill 100 after you've catheterized them for a period of time, unless you put them on CAC.
So I have two questions. They should all be asking questions because they're not
That's
asking.
right.
So the question, my query is one: if a patient has a high PVR, suppose 500 ml, and you're doing urodynamics, should we fill beyond that to get any information about the bladder?
You should fill beyond the PVRU and what he has voided at least.
So if beyond the PVR.
So if you have 300 cc of voided volume and 200 cc of PVR, so you are filling to 500 surely.
Yes, beyond that. We should go beyond that.
No, I mean 300 he has voided, 200 PVRU after voiding, so he has a 500
capacity.
So that much you are surely filling
At
to see
least.
what is happening.
Yes. So that's sometimes these machines have a cutoff. You can't fill beyond 700, 800. My laboratory machine has a cutoff.
1000 ml, but you would rarely need to fill beyond.
Yes, that is one. Second point is, mine is a more, this Dr. Sanjay can answer and you can answer. My question is about these patients who come with chronic retention. And then you do a TRP and you've done a good TRP, they still don't void. Then if you put them on CIC, I have realized many of these patients will void over a period of time, 1 or 2 months, they void. Most of them void. In fact, almost all, if you put them on CIC, they do CIC, they would void. Now, so CIC, so do you believe that, though there is very little evidence that cycling the bladder sort of aids in recovery of the detrusor function rather than putting an indwelling catheter?
Yes, I mean, we know that the bladder's physiology is best achieved when the bladder periodically empties and fills up. Whether that's achieved by a normal voiding or by CIC is beside the point. So, and we also know that in many patients with apparently acontractile bladders or underactivity, there's an element of reversibility. So if patients are on CIC, they're in a sense getting a voiding trial every day. I mean, they can do that trial any point of time. So many of those patients will get off CIC, which they anyway probably would have, and they'll detect it and get off the CIC at an earlier point of time.
Sir, so I will tell you a practical thing that I do. So recently there was this lady who came post-delivery and retention of urine.
Yes, that's an interesting subset.
Put on an indwelling catheter, and now what do you do? Urodynamics done, acontractile bladder. Now what do you do? So what I do in them is I tell them to start voiding and to do CIC after their void. And slowly over a period of time, what I have found, and in this last lady also, slowly over a period of time, the voided volume increases and the CIC volume decreases because you're doing it together. So she does CIC 4 times a day, but before she does CIC, she voids. So the diary after a few days tells you that now you can reduce the CIC by 1, 2, and then finally off. I did this with my last patient very recently.
That particular subset, they never really recover good detrusor function. They keep voiding, but they empty, but they don't really have high detrusor, good detrusor contractility even.
They continue to have residues.
Residues are low pressures.
So residue where the symptoms have improved, there is no UTI, appendix is normal, you don't need to do anything then.
So secondly, I want to ask one other question. Do you then believe that we are overdoing the medical management of BPH?
Oh, that's a very touchy question. Even I feel...
Are we overdoing it? We are doing it so much till the bladder decompensates.
Yeah.
So there is no data to say that obstruction results in chronic bladder outlet obstruction does not damage the bladder. There is data.
So
there is,
but I feel absence of data doesn't mean absence of evidence.
No, the other way. There are two studies, 10-year data on the bladder contractility, one by Thomas and one by I'm forgetting. Yeah,
I have it.
Yeah. So 10-year data, which shows that in patients who are followed for 10 years with treatment and without treatment, actually the contractility doesn't change. So whatever the contractility was, just because you've left uncorrected obstruction, it doesn't necessarily produce loss of contractility. So this notion, there are many notions we have in urology. And one of the notions is that if you leave somebody who's obstructed for a long period of time, the bladder will lose power. We've never really proven that. And the data that we have actually seems to suggest that that might not be the case.
And there is another, may not be related to UDS, but there is another practical point here that sometimes you get a patient who has very mild symptoms, but has a high PVRU. 250, 300, but mild symptoms.
We get that.
Never had recurrent UTI and never had, doesn't have upper tract damage and mild symptoms. You do not need to touch these patients. Till you are not touching these patients,
okay.
they
Once
will
you
be
do CIC, they have a problem.
Once you once you do urodynamics, you will never be able to take the UTI out of them. So you should not, unnecessarily go into
intervene. So I had a question regarding the lag time. The pressure construction is instantaneous, but the flow comes after a lag. So do you routinely correct the lag?
No.
No, is it not necessary to correct that one second?
So usually if you've got the patient positioned over the uroflow and the urine, for instance, is not trickling by around the side of the thigh and then reaching into the flow meter, that lag is not adequate, not enough to impact your clinical decisions.
Okay.
So you're right, there will be some time lag, but it may not.
Do they have some correction for that?
Not really. The machine doesn't correct for it because machine can't. It will depend on a whole lot of factors which are beyond the machine's control. But certainly, if for some reason there are people, I remember Professor Abrams once showed a photograph of a patient who's lying down, and then there's a system by which the urine is reaching the flow meter. If you have got that kind of a thing in a neurologically compromised patient, obviously then it becomes
in the West, at least the urodynamics I have seen, they have a tube which goes into the flow meter.
Okay.
Because they don't have people to clean the floor if it spills. So they have a condom catheter and a tube which goes into the flow meter. So that whatever lag that is causing, it is.
Another question about detrusor overacted. How much of that contraction should you take? Is it 3 centimeter, 5 centimeter, 10 centimeter?
Now
is there a limit?
Now ICS says all magnitude of contractions have to be taken.
Because many times you feel even the baseline there are some artifacts and all that, but still you need to pick up the contraction. It should be any contraction.
So they don't specify that beyond X centimeters of water it is to be taken as a DO.
Okay.
Obviously a low magnitude DO may not have any relevance, but
it should be documented as a DO.
Sensory DO means even sensory overactive bladder is there where contractions are not.
that is what hypersensitive bladder is a bladder where no DO.
Little amount should be significant.
Yes. Yes, ma'am.
Sir, sometimes during filling phase, compliance is deteriorating. But patient doesn't have symptoms of they don't have strong desire to pass urine. Should we continue to fill or what should we do?
So
there is no leak also, but the pressures are rising above 60, 70. But patient doesn't have the strong desire to void.
So again, it depends on the clinical situation, but as a ballpark answer, if you've crossed 40-50 compliance and your volumes are in the range of 200-300, you know there is bilateral hydrourethronephrosis. There is no, and DLPP is he's not leaked and the end filling pressure has already reached there. There is no point in now demonstrating whether that whether that end filling is 60 or 80 or 100. It is already high and you need to do something. So it depends somewhere on the clinical scenario. When adequate information you have got for your treatment planning, that is the time you don't need to proceed further. At least this is what I would.
Last point I wanted to ask is, now many people believe in doing a cystoscopy before a TURP to prove obstruction.
Zero.
So
in fact,
I want to just clarify, because that is something which people are taught. Cystoscopy before TURP to clarify obstruction.
So a lot of people.
I just want to, all of you can.
So once my resident also wrote cystoscopy done, high bladder neck, bladder outlet obstruction. So there is no way you can document obstruction on cystoscopy. It has no role. If you want to, if you documented obstruction, now you want to decide the procedure, then cystoscopy may have a role where you want to see the
Sir, I will tell you the counter to it, where it is used.
Is high bladder neck an entity, known entity?
Yeah.
No, on cystoscopy, no. That's what I'm saying. So there is nothing
But
as a cystoscopic obstruction.
But many patients who do not have any feature of any NGB or neurogenic bladder, they have obstructive symptoms, of course, but a very small prostate, grade 1. Then when you do scopy, you find a very high bladder neck with a grade 2 radiculation inside. Is it not enough for you to diagnose?
No, but
bladder neck?
tell me one thing. What would you mean by a high bladder neck? If the patient is, if you're doing it in local, and if the patient is his bladder neck goes somewhere, very comfortable old man, he's relaxed, he's somewhere. So if you have to tell your resident that, okay, A, B, C will be high, low, mid, what is high bladder neck then? There is
in this patient, you would advise an UDS. In all these patients who have a small prostate, significant outlet obstruction, features, LUTS, with features of...
So we will discuss this in the afternoon, but what we understand is, so USI has, in the USI guidelines, they've given guidelines for who should undergo urodynamics, but size of the prostate does not define the need for urodynamics for me. So it's not that if a 40 cc prostate, then I'm comfortable in my mind that this could be obstructed, and 20 cc I'm not comfortable. There is no evidence, because a lot of times we feel, okay, 100 cc he must be obstructed, 20 cc he's unlikely, this under, but there is no evidence which says that the size of the prostate will predict whether somebody is obstructed or no. Ultimately, cystoscopy cannot, the prostate ultrasound cannot. Obstruction can only be documented on urodynamics, as far as my understanding goes.
Last point about ALPP, about 60-90, how reliable is that? I think it's not very reliable, that less than 60-90.
So it can, with some background of history, broadly you're able to differentiate whether this is going in the ISD direction or the other direction, or most of them are mixed pictures. But somewhere, some patients you're able to say that this is, very significant leaks, minimum effort, you do LPP 40-50, so you know that there is a component of ISD.
Just a small clarification on that ISD thing. So
Yes,
if the pressure, if the leak point pressure is more than 90, it's not hypermobility, it's lack of ISD.
Lack of ISD.
So hypermobility could exist across the entire spectrum.
No, when I said hypermobility, I said the reason for the SUI is
but they may take the wrong message.
Yes,
So if it's hypermobility and ISD are two different entities, and you're looking at examining them separately. So if the lack of hypermobility is more important than the presence of ISD in terms of prognosis. So whatever he said is correct, except that it's more than 90, it's lack of ISD. The other important point with the stress incontinence is measurement, checking the patient without the catheter, which of course I think you mentioned, but perhaps we didn't discuss enough. A very large proportion of women don't leak with a catheter in the urethra. And unless you remove the catheter, you'll not be able to make a diagnosis, which is why, sorry.
No, I'm saying that's all the more true for this post-prostatectomy incontinence.
Yes, yes, absolutely. Yes, in men even more true. Yes, it's even more true in men. If the woman doesn't leak, you must have the catheter out and measure. Which is why actually we don't have a clear gold standard of which patient is actually having stress incontinence. So if you look at some of the, let's say, UITN papers, there the standard for making the diagnosis is the clinical stress test. But then the clinical stress test needs to be done very carefully. And again, in the lithotomy position, she may not leak.
So even for me, the diagnosis of stress incontinence is not on urodynamics.
Not a urodynamics.
The diagnosis of stress incontinence is on the clinical examination.
Yes.
If the urodynamic does not show stress incontinence, my diagnosis has not changed. What urodynamics is telling me is the choice of procedure for USI, depending on whether I get a low ALPP or a high ALPP. At least that is how I...
Yes, and let me also tell you about CADO and things like that. So, I mean, obviously, if you had a clinical stress incontinence on a physical exam, and if you're not able to demonstrate it during the test, there is something wrong somewhere.
But do you need to do for uncomplicated stress a UDS? You don't need.
We have 20 minutes of discussion for uncomplicated stress.
That is second. My last point is about Dr. Arun also spoke about uroflelometry. Yes. Now uroflelometry have different calibrations.
Some of them are you know, at 10, some of them are 6. So in some machines, you get a very nice curve, but the same curve, if you put it in, you get a flatter curve.
Very good point.
So that is a point which I think you
Very good point that the ICS has defined that your paper should move at this speed.
Yeah,
so
but
if
it
you're
is not
getting it done from
followed.
an X place where their paper speed is X, so you're getting this curve, suddenly this goes to some other place where the same curve becomes obstructive
much
for
flatter,
your,
much
for your
flatter.
visual. So you must know what your Uroflelometry machine is being, that paper is calibrated to what level.
This was regarding Uroflelometry. Similarly, with the Urodynamic also, I have noticed in one of the machines that if you make patient cough again and again, and if the cough peaks beyond a certain level, then the graph size shortens.
Sir, graph size doesn't shorten, it becomes flat. I'll show you.
It becomes shortened, and there is no way that you can print it larger.
Yes.
Say if the patient coughs till 145
Yes.
and the baseline graph was 75, and if the patient coughs at 150, then the graph size to accommodate it becomes the peak shortens there.
So I'll show.
And then your entire study looks very.
So basically, if you are on the right hand side, there is that calibration now 0, 20, 40, 60. So normally we put it 0 to 100. If it goes above 100, it's not going to show that inverted U. It'll just flatten. At
No, that
level.
is clipping. That is clipping that you are talking about. That it goes above, but if you take the tracer with you, then it will show what was the value at that point of time.
Achha, you're saying it doesn't show only?
It doesn't. The entire thing becomes smaller to accommodate everything. It becomes smaller.
I think the long and short is that you have to look at the scalings of everything. You can't just look at the shape of a trace without looking at the scale. That makes no sense.
Sir, one question, sir. Yes. So the numerical value 13.7 in regarding compliance.
13.7.
13.7.
There is no 13.7. The value is 20. Less than 20 is considered to be poor compliance in neurological patients. And when we say poor compliance, measuring it, so normally you're measuring it from the beginning and at the end, right? But let's say he leaks. So you have so then the volume after the leak cannot be measured. So then the compliance will be measured just before the leak and from the starting point. Measuring the compliance.
It's one of the point given in Campbell, sir. 13.7 is the cutoff. So
13.7. No.
Maybe what?
No. I mean, in what context? But standard is 20 for compliance. 13.7 anyways looks very.
Lower is safer. You want a safe bladder? The lower the pressures, the reducer leak point pressure, whatever, it's better. So compliance, yes. Higher the compliance, the better it is. You want a stiff bladder, it's bad.
There is another thing that you can take home, which we were discussing, that when pressures start going high, you know that this bladder is unsafe, whichever kind of pressure you're seeing and filling. But if pressures are low, it does not necessarily mean that the bladder is safe, because the lower limit of safety has not been defined. So you have to be careful. If you're still getting hydrourethral nephrosis at borderline pressure, that is still a problem.
Sir, in a low compliant bladder, how many times CAC has to be done?
Safe period.
You
do your urodynamic.
Yes, sir.
You institute the patient on whatever anticholinergics or whatever. You repeat the study. When you repeat the study, you know that this much period my bladder is safe, this much volume. Your CIC must be within that volume. If it is out of that volume, then you need to shift to the next level. Whether you're at antimuscarinic, then you need to shift to Botox or whatever.
How do we know that volumes?
How do we know
you
the
need to
volumes?
know how much urine the patient
He will
will
produce in that.
No, so he'll do CIC, no? So you'll have CIC volumes 300. He will get his bladder diary. So you tell him to make his bladder diary. He comes back with bladder diaries of volume 300, 350, 300, 4 times, let's say. 300, 400, 300, 400. Your urodynamic says that the safe period is 200. So then that 100 ml time, he has spent that day in the unsafe period.
Okay, sir.
So that is not what you will let happen. Then it's time for you to go to the next step. Whether Botox, whatever you want to
increase
do.
the frequency.
No, there are two things here. One point is, when you have done the UDS, you have generally done for these patients off anticholinergics.
Okay, sir.
So you institute full dose. Now what is full dose anticholinergics? It's not what you give to a normal patient. It's not 10 milligram of sulfenacin for a patient of neurogenic bladder. Dose is different. It's much higher, and somehow these patients come to tolerate these higher doses better. Secondly, you see the weight of the patient. How much urine do you produce? 1 milligram per kg body weight. Suppose safe volume is 200. So it would mean 3 hours he can go at least without being unsafe. So that is how you have to calculate the safe volume and then the safe period from the safe volume.
And then you have to tell them that many patients use their sensation as a trigger, or their starting of leak as a trigger. So you have to tell them that your sensation comes in unsafe zone, or your leak starts in unsafe zone. So you don't have to rely on that. You have to rely on your timing also. You have to time your CIC rather than...
This is a little individualized also. Sometimes their day volumes are all right, but their early morning volumes are not all right. So sometimes they will be, people will put them on nocturnal drainage. Yes. That during the day you do CIC, night you drain. So it depends person to person how you would want to, but you should be aggressive, because the zone before the kidneys get damaged is
So the urodynamics may tell us that the CIC that the patient is doing is not enough to make the patient safe. But I'm not aware that there's any data to tell you that you plan the number of CICs that you're doing based on the compliance that you're seeing. In the sense that, can you treat a patient's poor compliance by going on increasing the CIC frequency? There's no such recommendation. In fact, if you look at the EAU guideline, it says that roughly a 5-a-day frequency is what is the best balance, which optimizes the frequency of infections versus the safety of the patient. So ultimately, if the patient has a poorly compliant bladder and you make him or her catheterize 10 times in a day, the patient is likely to has a higher risk of getting into sepsis. Yes. And the odds that the patient will get exposed to higher pressures because they've not been able to catheterize with that high frequency over a lifetime is much higher. Yeah. So I'm not aware that in going on increasing the CIC frequency is a method of treating poor compliance.
Absolutely not.
But looking at the urodynamics, you can tell, is this CIC regime with the patient is following, is it adequate or not? Do you need to change therapies?
So what your CIC frequency beyond 4 to 6, then you're stretching it, because there is data for urethral trauma, there is data for stricture, there is data for... So you can't say that, okay, you start doing 100 cc, 10 times a day. Then your therapy is not adequate. Then you need to move to whatever next step. But having said that, if you're within the safe zone also, so urodynamic is not the only parameter. If you're within the safe zone, which you perceive as safe zone, that okay, this is within that 20 centimeters of water, but if hydronephrosis is increasing, so it's the whole gamut, but you know what is unsafe and where you do not need to be, but you don't know what is safe where you should be. So that is not only by urodynamics, that is by a combination of the other things as well.
Okay, sir. Thank you, sir.
I think, Dr. Nikhil, आपकी.
ये निकाला नहीं
ये वो दे दीजिए, ये मेरे को दीजिए, ये अंदर गया.
So now we'll be entering the voiding phase in cystometry, as filling phase is over. So should be a little more exciting also. Let us see. So this is what happens when a patient starts voiding. The pelvic floor relaxes, and then the detrusor starts contracting, and then the flow starts happening. Then as detrusor contracts, the bladder empties, and from all sides it starts shrinking from all sides like this, just as if we have opened the end of a balloon. So when we are doing a urodynamic study, we have done the filling phase. We have adequately filled the patient. So how we are preparing for the voiding phase. We have to know that till what time we have to end the filling and then give a command to void. Voiding phase starts only when we give a command to void. So end of filling can be determined based on the patient's sensation, very strong sensation, or at times by his or her voiding diary, where you have seen what is the maximum capacity that he or she has held during the day. A little more than that, that should be enough. Then position, whether the patient is in correct position in order to void or not. Just before voiding, we have to also make him cough or look at the live signal to ensure that both of our signals from the bladder and from the rectum are coming correct or not. Then if there is any problem with the catheter, catheters have to be secure throughout the voiding also. Sometimes even you can even ask the patient to hold the catheter near the penis, near the tip of the meatus, so that catheter doesn't come out. And then just before void, the room has to be a bit quiet and there should be no movement. People should not be moving around. So patient should be comfortable. And then the command should be given. So when the voiding happens, we see why we are doing this pressure flow study is because there is some problem, usually there is some problem in the uroflow that we want to ascertain whether this slow flow or this pattern of uroflow is because of obstruction or not. So there was a uroflow in the beginning over which we want to add some more information by knowing precisely what the detrusor is doing, what the bladder is doing during that flow. But now what we have is we have one more tube also inside, so that can have its own effects. But then when we see both the uroflow and the detrusor together, then we see that detrusor contraction starts happening before the flow happens. And then there is some time where the detrusor contraction is happening, but the flow has not started, and then the flow starts. Along with it, the detrusor contraction happens, and then the contraction continues beyond the flow also. What all do we see and measure here? What all we can do is measuring the peak flow, measuring the opening pressure at what time, how much is the time between the command and the initiation of flow, what were the pre-micturation pressures, what is the maximum flow, maximum amplitude of Qmax achieved, what is the maximum amplitude of contraction, that is the Pdet achieved, and what is the Pdet at Qmax. All this can be calculated from the pressure flow study. So this is how generally the study will look like, that the filling phase, throughout the filling phase, you have kept on checking the adequate signals from both of the lines, bladder as well as rectum. And then before voiding also you check with a cuff, and then you allow the patient to void. And after the void has happened, again you make the patient cuff to see whether both the tubes have remained intact throughout your voiding or not. So if that has not happened, then also a lot of things you won't be able to comment on. The quality parameter, that is one very important quality parameter that has to be done after the voiding is over. See, have a look at this graph. This was, there was some, both the towers, in the Pdet line, there was some significant deflection was happening. And although I thought that maybe it will not have any effect, but when the patient voided here, I was not able to clearly know whether all this voiding is because of, now the straining has also started happening. So, can you see the voiding phase? The straining is also happening, abdominal contractions are there, along with that corresponding bladder contractions are there. And similarly, detrusor contractions are also there because they were there in the beginning itself. So, I am not able to infer whether this flow is produced because of any detrusor contraction or not. So, when we got this corrected, flushed the lines, repeated the study, then now we can see that initial flow is because of some detrusor contraction, and then the later part of flow is because of some straining, and the straining continues even after to expel the residual urine. Similarly, here also, although just before voiding, the cuff showed equal signals on both sides and there was minimal deflection here, but throughout her attempt to void, the patient continued to strain so heavily that probably the rectal line has started coming down. The rectal, this thing has come down, and that is why there is consequent increase in PDET. This is all artifact actually because of the movement, and this is, if the study is repeated, we will see that this is an acontractile detrusor. Similarly, we have to be careful that the line can also come out. Like in this patient, the bladder catheter suddenly during the void has come out, and there is a sudden drop in the P-West line. Similarly here also. At times it may not come out completely and it can come just in the prostatic urethra or proximal urethra, and the signal that you get will be of lesser this thing, and then it is then you have to have an eye what is happening there. So it cannot come out, it may come and sit there giving some decrease in signal. This is a typical bladder outlet obstruction, urodynamic bladder outlet obstruction, as we expect that any patient where you are going to do a TURP in a male or maybe urethroplasty in a female, then you should have such kind of pressure flow curve. Very high PDET achieved and very poor flow. This is urodynamic bladder outlet obstruction. But then you may not be so lucky every time, and you will have different situations. This is also a typical flow. Here you can see during the entire study, there is good cuff signal, there is good live signal from patients breathing, talking. Earlier when we were students, we used to make sure that patient does not speak throughout the study. Even sensations, we used to tell them signal us by saying 1 or 2 like that. But now it is understood that throughout the study you have to keep talking to the patient, and so that you see the live signals throughout. And then voiding command is given here, and this is the void with very high pressure and low flow, and then you see something which is the after contraction. Can you see that? There are 2 strong detrusor contractions. Usually they are very quick and they are even higher amplitude than what was achieved during the void. And cause is means why they happen, I am not very sure, probably it is not known. And but these are after contractions. You see here how can we interpret this pressure flow study. Probably during the filling here, there was some patient started having some urgency, and during that urgency, probably this was a terminal detrusor overactivity, and during that urgency, he was given a command to void, okay, pass urine. But then there was no additional generation of detrusor pressure. So it is very difficult to say whether this is proper voiding or not. Maybe a study has to be repeated with volumes less than which were able to induce the terminal DO, and patient should be allowed to void before that. Okay, here also you can see there is terminal detrusor overactivity, and during that detrusor, you can also see on EMG the reflex where patient is trying to hold urine, contract his sphincter with each contraction. As the contractions are becoming stronger, his EMG activity also is increasing, and that reflex is also increasing, and he is trying not to pass urine, not to have urge incontinence. And then suddenly, with a very strong urge, you allow, okay, pass urine. But then again, there is no other detrusor contraction. So this is not detrusor overactivity. You cannot comment on this voiding phase. You cannot apply your formulas of PDET Qmax on this, because this is not proper voiding phase. Okay. So pressure flow analysis, as we know all those plots, the AG nomogram, the bladder contractility index, all those numbers are only validated for voluntary initiated micturition and not for incontinence. So they do not apply here. They do not even apply for younger, they are mostly for BPH only, not even for functional obstructions. So we know that urodynamic bladder outlet obstruction, this AG nomogram, AG number is PDET at Qmax -2, Qmax for males, and these are the values for obstruction. These are the values for bladder contractility index, which we keep on applying, but they are not validated for other situations other than BPH. This is a younger pressure flow study in a younger male, 48 years male, who has some residual urine and a poor flow. And we can see that he generates a very high contraction during void. There are two after contractions also. There is increase in EMG activity here, which probably, I do not know whether after contractions, because of after contractions it's there or not, but there is not synchronous relaxation of the sphincter. So here an additional MCU was helpful, and you can see that the level of obstruction is at prostate. We did a TURP for this patient, and his symptoms subsided. The diagnosis was clinched by an MCU. So a video urodynamic in such situations may be helpful in men also. In females, the situation is a bit different. This is one of the areas of interest that I pursue. There was a chapter also written in a book that we had published last year. And we found that there are many variations in the definition of bladder outlet obstruction in women, ranging from PDET at Qmax from 40 to more than 20. There are many definitions which say different things. And then there is a radiological definition which came out with Nitty's paper, which says that definitive diagnosis of female bladder outlet obstruction should be made by voiding images of VUDS, means the video urodynamics, with high detrusor pressure, low flow rate, and increased PVR. So any ballooning of the urethra seen radiologically should be considered as obstruction irrespective of the flow. That is what this said, and that is why video urodynamic, that is how became a gold standard for evaluation of voiding symptoms in a female. So these are other cutoffs if mentioned there. So even in women, unlike males, pressure more than 20 also may be obstruction if the flow is poor. These are some examples of bladder outlet obstruction in women, where this is a very clear-cut example where very high pressure, low flow is there, and you can see a dilated urethra both radiologically as well as urodynamically. This falls in the category of bladder outlet obstruction. But this lady generates a lesser amplitude of contraction during the voiding phase, and pdet at Qmax is 38 centimeters. But we can see a dilated urethra in the MCU. So this finally was diagnosed as bladder outlet obstruction. Similarly, this graph also is you can see a dilated urethra. So this is also a bladder outlet obstruction in a female. Sometimes the contraction is very, very poor, and then we see here that the pdet at Qmax is only 17, and look at the there is no dilatation there, and whatever the voiding is happening with the abdominal contraction, and there is no sudden contraction and shrinking of bladder from all around. So this is an underactive bladder. So that is how video urodynamic or a separate MCU or this urodynamics inferred together are very helpful in determining between bladder outlet obstruction and underactivity in females. This again is a graph with very poor contraction. These are all corresponding just to the abdominal straining, and we can see on voiding attempts also that the patient is just straining and there is no opening there. This is also an underactive bladder. For female bladder outlet obstruction, very recently this nomogram SG number or bladder outlet obstruction index in female is also given. That is pdet at Qmax minus 2.2 Qmax, unlike in males where it is minus 2 Qmax. But still this has it is in initial phase of getting validated. 1 or 2 papers are there, but still a lot of work has to be done to make sure that this becomes a standard as AG number has become in males. Yeah, so that is all that I had to say for voiding pressure flow studies. Thank you.
So if you look at this Solomon this gives a probability, right? That more than it's 50% probability. So when you get these indeterminate numbers, let's say 35 pdet max, 12. So how do you make that decision between underactivity and because the data says it's 50% likelihood of after the, so how do you make that decision?
That is just SG nomogram is just on number. If you are doing purely a urodynamics, not a video. If you are doing a video, then dilatation of proximal ballooning of urethra gives you a fair idea, gives you some idea, because that is based on that entire NITI paper is based on very subtle obstructions which were obstructions by after incontinence surgeries. They were obstruction after incontinence surgeries with very subtle symptoms, and there was some change in voiding pattern which the patients were uncomfortable, and their urodynamics showed these 30, 40 types of ranges. And then this proximal ballooning was seen. And then on those symptoms, just because of the chronology of symptoms, they decided in that paper to cut those tapes and deobstruct them, and found, so because the problem in women, defining bladder outlet obstruction in women is just because there is nothing like deobstructing. There are very few obstructions like, unlike in males, jahan pe, you have deobstructed by doing TURPs. There, they deobstructed, and then they found that there was a resolution in symptoms. And based on that, those parameters, then they applied that to functional and then they saw that there is ballooning here, so this is obstruction, and that's all.
So you also believe that if you add a video,
that
you
will
can,
be
that clarifies at least the indeterminate cases,
yes,
whether it is obstructed or not.
yes, whether it is towards which side.
Right.
The problem will come with video only with bladder neck obstructions and areflexic bladders, where there will be no opening of the bladder neck.
Sir, sometimes in male patient, pediatric Qmax comes 74, Qmax is 1. And what category we can keep that patient? It's a hypotonic or a good detrusor pressure, or what, sir?
You have to interpret the graph again, what has
Yeah,
come.
2 times. Pediatric Qmax is 74, 75, like that.
So that means just opening pressure or just
Voiding.
During the voiding?
During the voiding, sir. And the Qmax is hardly 1 or 2.
So you have to correlate with symptoms. I think that should fall in bladder outlet obstruction.
Because BCI comes as a less than 100, so it comes in the weak detrusor pressure.
But
weak detrusor.
so there is again. So the question here is obstruction and decreased contractility, do they coexist?
Coexist. Because it's coming in a low, weak detrusor. So that is, what should we tell them? Is it
No,
I
think for me this should mean obstruction, and patient should be offered surgery for deobstruction.
I agree with you. The one thing, yes.
Because BCI, if it is less, okay, then you definitely, means you can tell the patient ki after surgery, okay, if you are going for surgery, how much benefit he can have. Okay, so for BCI, I think it is important for counseling. But still, equivocal Jones, you can go ahead with the surgery.
No, we are just seeing that number. We should also see whether there were any residual volumes also.
I think you take multiple things. I don't know how much we should depend only on some of the formulas. I'm not very
if
sure.
there are no residual urines, even before the study, we have seen ascertained that there were no residual urines, and then BCI less than 100 does not mean anything.
And secondly, I just want one more thing to know. The second is UDS is soft science. That you can't. It's not hard science. It's not that if you have this number, it is obstructed, or you don't have. It is not.
So how much pediatric Qmax we can consider it's a normal detrusor pressure? Like some say it's more than 60 is good detrusor, or more than 40 is
So that is where the role of the formula comes. That AG number is now very much standardized. You can, in difficult situations, say that this is coming and falling in range of obstruction and needs deobstruction.
Any more questions? I think people should start asking. It's important that you go from here with clear things about UDS.
Yeah, this is an opportunity you guys should not miss. Whatever doubts, however silly they are.
I learned my UDS when I attended a workshop by Dr. Sanjay Sinha and Varna Schiffer in Chennai in SRMC when I was a resident. I must thank him for that. It was so clarity. I got so much clarity that I really benefited. So this is a chance for you to ask.
I never realized I was that old.
You have to.
You remember that workshop, sir?
Yeah, I think. Yeah.
So I feel that you should take this opportunity and just clarify your doubts.
In video UDS, there is a halt test or stop test. So how frequently do you use it?
That is for assessment of contractility. See, contractility is best assessed in isovolumetric contraction times, where the gap between the initiation of contraction of detrusor and the initiation of flow, where the bladder neck has not yet opened, flow has not yet started, the same volume is there in the bladder, but the detrusor is contracting. So actual shortening is happening at that point of time. So if you have to measure contractility, that is the time. But since there is no way, there are many times this has been tried to measure. There is a cuff test where during the flow you suddenly stop the flow, and then it will become an isovolumetric chamber, and the detrusor contraction will go on, and then you can assess the contractility or stop that test that you are saying that patient should himself or herself stop. But that is most of the times they will not be able to understand how, so it is not reliable, reproducible. So instead of that, actually there is something called 2080, there is 2080 time before the onset of contraction, before the onset of flow, where the detrusor pressure starts rising, and the pressure at which the flow starts, if that is 100, so between 20 to 80, the time taken from 20% of that to 80% of that, if that is isovolumetric zone. So there are some papers on that also. So trying to measure that contractility, I'm not very sure how and.
You've answered it well. So for the residents, actually, when you're trying to assess the contraction power, let's say there's a woman who's voided with a very low detrusor contraction pressure. You don't know for sure whether that bladder is actually contracting, and you're not able to pick up the contraction power because of the outlet. So ultimately, the pressure that you record is a function of what's the outlet resistance and how much is the contraction pressure. So if you really want to see how much was the contraction power, then if you suddenly stop the flow, before the bladder is able to relax, you'll be able to judge how much was that pressure. So how do you do that? In a male, it's very simple. You just squeeze the penis, not at all a comfortable thing for the patient. So he's passing urine, all of a sudden, squeeze the penis. So you've blocked the urine from coming out, and you are now able to see what was the pressure in the bladder. So that pressure is called the isometric pressure, because isometric means no change in volume. So when you block the flow, no change in volume, the pressure suddenly spikes, and that peak pressure is the P-iso, or isometric pressure. In women, it's more difficult to do. You need a balloon catheter, and you need to tuck the balloon catheter against the bladder neck. Again, not comfortable and not very perfect. So when you do that, you can judge what was the isometric contraction power in the isovolumetric contraction power in the bladder. Now, what Nikhil said, that's one method of getting the same information without doing that uncomfortable maneuver. So when the patient starts passing urine, there's a time lag from the moment when the contractions in the bladder starts to the time when the sphincteric mechanism opens. And that is an isovolumetric rise in pressure. So in that slope, if you see between 20 and 80% from the way in which that pressure rise occurs, you can get an idea of the P-iso from that without actually doing the maneuver. So but these are all very small bits of data. We don't have good clinical data to back it up. And without good clinical data to back it up, it's difficult to interpret.
But why would you need P-iso
more complex?
So it's P-iso is one. So Dr. Pavan is asking, why would you need P-iso? The reason is that none of the contractility measures that we have are very good, especially in women. So in men, you have data for contractility because you have a good model. As Arvind said, you have a TORP model. Women, we don't have a model. So we don't have a good method of how to assess the contractility. And many of the methods by which we are doing it, none of the experts agree that these methods are correct. So should we be multiplying by the flow by 2.2? Should we be multiplying by 5? In physics, ordinarily, you don't subtract and add quantities which have different units, right? So you're not supposed to add a milliliter per second to a centimeter of water. That doesn't make sense. You don't do that with just look at any of your formulas from high school. You never do that. So these are all approximations which have been derived by certain methods, and experts don't agree that they're actually the right way forward. So in women, there's something called PIP1, where instead of you take the P dat Q max and add to that this flow into 1. They call it PIP1, and many experts feel PIP1 is the best predictor representation of P-iso. So many people feel P-iso is a good method of getting the actual contraction power in the bladder.
I heard that first time during the Delphi.
Delphi, right.
In males also in post-prostatectomy incontinence, that is another scenario, the patient is leaking. You are not able to record how much is the contractility. In those men, that is another scenario where you need to squeeze and stop,
square.
and then you need to
Cuff test
because
is,
you don't know how what's the contractility.
if that again, if you are planning anything apart from sphincter, because if you are planning sphincter,
talk to them about the master trial, that came out regarding atoms versus AUS and what they found regarding the UDS.
तुम ही बताओ मुझे update ऐसा नहीं.
Sorry. Yeah, so this was about post-prostatectomy incontinence 2021. So master trial compared the sling versus the AUS and whether the UDS made any difference. So most of the primary outcome measures were almost same, but they found that AUS had more satisfaction scores and AUS probably had a better result if it was a pure sphincteric component rather than sphincteric with some amount of mixed incontinence and all that. So that was the master trial.
Actually what is considered is that if you are putting AUS, then it does not matter whether there is contractility or not. Because for a sling you are producing an obstruction and then there has to be some contractility. Yeah. But if you are putting an AUS, then that does not.
So that is what. So both were equivalent in all other, but in pure sphincter probably AUS had better results.
I think the other end of the spectrum should also be clarified that that if a woman does not generate pressure, that does not mean it is an acontractile bladder. So proportion of women will void with pelvic floor relaxation alone. So if on a urodynamic you find nothing happening in the voiding phase, but the flow is good, the UFR is good, the PVRU is negligible, there are no obstructive symptoms, then that cannot be reported as an acontractile bladder. That woman normally can void with pelvic floor.
So question for you.
And that she must have been evaluated for something else.
Yes. So for example, I'll give an example. I recently saw a patient who had stress incontinence and came for urodynamic, had got a urodynamic done, and the urodynamic was reported as an acontractile bladder, and she was told that if you get a stress incontinence surgery done, you may have a problem post-op, voiding dysfunction and whatever. But that woman neither had any obstructive symptoms, neither had any PVRU, nor uroflelometry was normal. And she was voiding with normal pelvic floor relaxation. So the fact that she did not generate any pressure does not mean that the bladder is not working. It means that her relaxation is efficient enough to void, and if tomorrow an obstruction will come, she may generate detrusor pressure.
So just a question for you, Pawan, addendum to that.
Yes,
so in the same woman, let's say she did a Valsalva when she actually voided. So the bladder didn't contract, excellent flow, no residue, but there was a Valsalva.
So there is data that if somebody's, it will come in our case discussions, but there is data that if somebody is using some measures to aid voiding, then she's at twice at as much risk for voiding dysfunction post-sleep. Yes. But if there is no Valsalva and she's voiding only with relaxation, then that's not acontractile or increased risk.
This is one of the fallacies of your indices. So when you look at bladder outlet obstruction index, bladder contractility index, it doesn't take into account abdominal strain. So if the patient strains to produce a flow, it will give you a wrong index of contractility and obstruction because that will aid the flow artificially.
Yes. So if you read, his book also has, so if you read the chapter on how women void, then some women void with
the first chapter written by Pawan.
So some women void with detrusor contraction, some void with abdominal straining, and some void with pelvic relaxation. The BOI index can only be applied to the first set of women.
Thank you.
So, we are more or less on time, sir. Even with discussion, I think.
Anyways, CIC will not need any discussion. So, I'll be talking on a topic which I think most urologists know, and most of you are practicing this. I'll be looking at clean intermediate catheterization. Very basic this thing, and after that we will have a little discussion on the indication of CIC. I think the esteemed panel will then talk about more about the indication later on. So this is the paper 1972. I think the CIC, any discussion on CIC cannot be started without quoting this paper and this man who revolutionized the treatment. Clean intermediate self-catheterization, 1972 paper. The man who came up with the fact that just not increased intravesical pressure and over-distension of the bladder, it causes some amount of ischemia, and this is where the infections begin. This is where the infections happen, UTI happen, and most organisms are hematogenous and lymphogenous route. So this is the crux of CIC. And his contribution was simple but revolutionary: the demonstration of safety and bladder preservation of clean intermediate catheterization. We all know Jack Lapidus. So this is his contribution, and this is the mainstay of treatment in most of the neurological disease today. We will come down to some simple, basics. We have been talking a lot advanced also, so we'll come down to simple basics. What is CIC? CIC refers to active draining of urine by passing a catheter to urethra, past the sphincter. Catheter is removed after urine has been drained. The process is performed using a clean technique. And this clean thing again came from this revolutionary paper. So this is the first time when the word clean was used rather than sterile. From sterile intermediate self-catheterization, it has come down to clean, and clean is what made it what made the urologist adopt to this method. So again, CISC, performing CIC for oneself. Clean technique is conditions to reduce the number of microorganisms, includes hand washing, non-sterile gloves, a clean field, a clean or sometimes sterile equipment. Then catheters, we know there are hydrophilic coated urinary catheters which may or may not be used. The other methods I will not go into detail in this. Why do CIC? So the CIC is the most practical and effective way to drain the bladder of patients who are unable to empty their bladder spontaneously. So there is no doubt regarding this, that there is no other practical and effective way apart from this in patients, in those patients who are unable to drain the bladder spontaneously. Indications, we will have a thorough discussion on indications. Few of the indications I'll write, I'll not go into stricture and all, but neurogenic lower urinary tract dysfunction, we have a lot of cases. I think we'll come down to that. Most of the indications are neurogenic bladder. The recommendations of NICE, ICI, EUAE is that wherever feasible, the patient has to be advised CISC rather than indwelling catheters or SPC. When it comes to infections, CISC has the least amount of patients having the least chances of infection. Next is SPC, and then in the indwelling catheters. What is the prerequisite for CISC? Patients should be cooperative and well motivated. This is what is so very important. And where are the limitations we have in advising CISC is that when there are functional, anatomical limitations, limitations with the caregiver sometimes. In small bladder, it is a very big problem. So as we have already discussed, CIC can be done around 4 to 5 times. If patient is requiring more than that, it is really tough for one should, refrain from advising CIC in small bladders, and persistent incontinence, again, not much of use. One very important topic is autonomic dysreflexia. Kya ji? Autonomic dysreflexia, one should be aware of this autonomic dysreflexia, especially in those conditions wherein the injury is above T6. The stimulus because of CIC may create a kind of emergency, sudden rise of blood pressures. These patients may not themselves tell you that there is a rise of hypertension. Sometimes the rise of blood pressures goes beyond 300. So one should be very much cautious about this autonomic dysreflexia, especially in those patients where the neurogenic bladder, the cause is above the level of T6. Assessment, we will have a lot of cases wherein we will see what are the things that we have to assess. Sometimes dysfunctional voiding symptoms, as in detrusor overactivity. We have to do a urodynamic, see all these things. Ongoing condition that results in neurogenic bladder like meningocele. So the assessment of the patient has to be made. What are the, why we are advising CIC? The physical assessment, once decided, the patients and the family's physical assessment. In India, we have to know the reason of CIC, and before initiating CIC, the patient has to be educated well, the level of comfort, sometimes of the parents, of the child performing CIC. They have to be explained really well, and then this is very important, the fluid intake and the urine output. Again, more than 5 times or 6 times CIC is very tough. So the fluid intake remains a very, fluid intake has to be looked into. So the bladder diary and how much is the urine output, total urine output has to be seen. What is his current discomfort level, and any specific psychosocial consideration has to also to be seen. The various types of catheters available for CIC, from single-use silicone catheters, single-use hydrophilic catheters. Coating of hydrophilic sometimes may be very difficult to grip, but they are little less painful. Sometimes with hydrophilic catheters, it is very slippery sometimes. But there are no currently established benefit of reducing UTI between these two catheters. We have few papers which I'll tell you about the single use and all. And then apart from that, we have the Siemens and Coot tip catheters with an angled tapered, or occasionally used for boys in which there are problems of inserting straight catheters. The size of the catheter which has to be used in adults, it's around 14 or 16 French that we use. Rest of them, this is available. So these are the size that can be advocated. Around 5-6 years, it is around 10 to 12 French. Adults, mostly it comes to around 14 to 16 French. So there are various available catheters. All the Indian companies are also making catheters. So these are the catheters apart from the available normal catheters. For female, these holders are also available. The smaller size catheters also available. So what are the equipment required? Apart from the catheter, alcohol-free wipes, water-soluble lubricated gel, unless using a hydrophilic catheter, a container into which to drain the urine, unless draining to the toilet, a latex-free gloves sometimes if it is child. So essentially, finally, what is needed is a catheter, proper hand washing wipes or soap, xylocaine gel. These are the 3 things which is needed. Sometimes container, or you may ask the patient to do that in the toilet also. There are other appliances also available, from using of mirror. Initially, female patients are advised to use mirrors, but slowly they become used to it. Then there are labial supporters, and in some neurogenic bladders, the usage of this thigh abductors are also available, which can be used, or indigenously also it can be, pillows can be used as thigh abductors. So the procedure we all know. I will not go into detail of this procedure. What is important is that we have to keep it clean. We all know the procedure, how to explain it to the patient. What is important is to just keep the hands, and for males to keep the to just retract and protract the prepuce well back. And there is some amount, one thing we have to tell the patient is there is sometimes initially there will be some amount of resistance will be felt at the sphincter. So we have to tell them to relax. And once it is done, if we are using disposable catheters, it has to be discarded into the proper waste bin. Otherwise, if we are using a reused one, then once washed, it should be dried and then kept in whichever container we have to keep. So catheterization we all know. So these things have to be explained, and it's better that patients start their CIC under supervision for a day or two. Then females also, no specific point except that sometimes mirror has to be used, sometimes the patients have to get used to filling the pubic bone and then slide it down. Potential complications we have to tell, like sometimes UTI and urethral trauma. There is no specific antibiotic which needs to be given, but initiation, sometimes a low dose antibiotic for a few days is the practice that is followed by a lot of urologists, but after that it is not needed. And catheter obstruction, especially if it's a child, if there is a difficulty to pass urine, to pass the catheter, then the parent has to be educated about this muscle spasm and not to force the catheter too much. That is very important, that they should not force that whatever it is, the catheter should pass in smoothly. And in a child, she has to be advised, the caregiver has to be advised to utilize deep breathing, visualization, distraction techniques to pass in this catheter smoothly. So this is one very paper that I went through, clean intermediate catheterization, whether we should use a single or a reuse catheters. So as far as the infection is concerned, hydrophilic catheter is the first option. The least amount of infection. Single-use hydrophilic catheters were least amount of infection, but they become little costly. Otherwise, single-use, there is little less amount of UTI. So if a patient on a normal reuse catheter is getting repeated UTIs, then we have to advise him to go into a single-use catheter. That is much better. Again, US Medicare, the insurance policies in US, they are allowing around 200 catheters in a year. So they are propagating the single-use catheter in US. So the insurance companies in US, they allow around 200 catheters, which is quite a big number. This is another one, the usefulness of CIC in acute refractory retention of urine, waiting for the prostate surgery. Again, here CIC was a better technique in managing the AUR rather than an indwelling catheter. So there are barriers in doing CIC. There may be internal barriers like positioning, dexterity, visual impairment. There may be anatomical barriers, coagulation factors in the neurological patients, misconceptions, anxiety, embarrassment. Initially, a lot of patients have fear, and the stigma behind it is to be taken care of. So you require few consultations with the patients. So face-to-face instruction with the nurse, with the person who is teaching the CIC, choosing the appropriate catheter, use of catheter appliances to help locate the urethra, thigh abductors, mirrors, labia spreaders, visual aids, leaflets, videos, and then small help group. All these things might help. The external factors like access to public toilets, adequate facilities to do that, availability of appropriate catheters sometimes, assistance appliances, quality of teaching and training environment, community follow-up, access, help and advice, availability of people who teach them properly. So definitely teaching CIC, we have to give adequate time for teaching it and ensuring a good regular follow-up when required, especially for the parents. Standardized training of the nurses is also needed, and use of social media, YouTube and all in teaching them has really helped in patients accepting this procedure. Again, cleaning the catheters and how to store it. If catheters are usable, just throw it, wash. Otherwise, it is very important that the catheter is dried from outside and then stored. So guidelines, intermediate catheterization is standard treatment for patients who are unable to empty their bladder void. Aseptic IC may be the choice, but again, clean is enough. Catheter size, we have already talked, around 14 French. Frequency, around 5 to 6 times a day, 4 to 6 times a day. The bladder volume should remain 400 ml. We have already talked about the safe bladder, DLPP and all. Indwelling transurethral and suprapubic catheterization should be used only exceptionally under close control. Silicone catheters are preferred, should be changed every 2 to 4 weeks, but then a little less also is quite advisable. They are quite cheap, so little less is also quite advisable for the silicone catheters. We have already talked about the advantage. Once patients get used to intermittent catheterization, a patient who is on indwelling catheter, he is much more confident, he is free from indwelling catheters. Again, in adults, they have unimpeded sexual relations, there are lower rates of infection, they become much more confident. The initial paper by Lapidus, 14 patients, 12 out of 14 patients, they really became confident, and after that, we all know in our experience the amount of confidence levels that patients who are indwelling catheter for a very, very long time, then when they're shifted to intermediate catheterization, and once they become used to it, we know the level of confidence that they have. Thank you. We will come down to the indications part of it. The whole program is, 30 to 40% of the program is on indication of CIC only for next 2 to 3 hours. But then I'll take few calls. What should be the indication of CIC? Where you should advise CIC? Anybody can answer. Or we have around few more cases in the afternoon session. I think we'll talk about the indications only. Any questions? I think most of us are very confident of teaching CIC. It is the basics. So we'll break for lunch then. Thank you. Welcome back to the auditorium. I think you all had a good lunch. Lunch was indigenously prepared at our hospital. Kim's Hospital's food is little famous in Hyderabad amongst all the hospitals. So I welcome back all of you to the auditorium. Now we have our most esteemed faculty, Dr. Sanjay Sinha, Urodynamics in Children. We all know Dr. Sanjay Sinha, who is into this specific practice since, upteen times. I've been seeing him since 2000, devoted himself to neurourology, apart from the normal urology practice. I think he's the right person to talk about urodynamics in children. He's chair first USI guideline on urinary incontinence, and also regional editor for SIJ, and for the Indian Journal of Urology, he's the associate editor from this year. So I again welcome him to start his talk on urodynamics in children.
Thanks, Gopi. Well, you had a good lunch. If you got to sleep, just put your head down, don't snore. Okay. So I'm going to focus on clinical urodynamics. A lot of technical stuff has been discussed through the morning. You've survived it, reached the post-meal, post-lunch session. So this is primarily going to be clinical. And if there's anything you want to ask me, technical, clinical, at any point, you're free to interrupt me and ask. So as far as some brief technical aspects are concerned, when you have a child as a patient, it's important to explain the child what's going to happen. You should not assume that the child will not be able to understand and hence need not be told. But don't scare the child, obviously. You need to have methods to distract the child through the test. A comfortable position in which the child sits is important, and that includes both the angle at which the upper torso and the lower torso are. This is not the right angle. You need a relaxed child with the back straighter than that, and a support for the legs, which you can see is not there. And if you don't have support for the feet, that can compromise the quality of the test, sometimes produce a pelvic floor that doesn't relax, and you may induce voiding dysfunction in the child. You want to use appropriate size of tubes. A 6 French double lumen catheter is what is recommended. If you see the technique that all of us are using in our centers, and it's important to discuss what we do rather than what's in the textbook, and that is the use of 2 5 French feeding tubes, which what I use in my center. The combined surface area of 2 5 French feeding tubes is equal, in fact, a little lesser than the 8 French feeding tube. So if you look at the surface area, cross-sectional area of 2 5 French feeding tubes, it's not more than 8 French. It's actually less than 8 French from what I recollect. So hence, and especially if you remove one of the tubes when the child is voiding, you should be perfectly fine. A suitable filling rate, we had a lot of discussion on this, less than or equal to 10% of the expected capacity. Body temperature, somebody asked in the morning, do you warm the body fluid? So it appears that the only group of patients in whom this might really become important is infants. In other patient populations, the fluid may not be that important, but obviously if you infuse ice water into the bladder, that can induce reactions from the bladder. In the very young child, you can't ask the child to cough to see verify that the transducers are working, so you do a quick jab over the suprapubic area, a Creed's maneuver, to check for the tubes. So you can induce what looks like a staccato voiding by, as I said, improper positioning. And you can see that when you get the so-called staccato voiding, where you find that the voiding is not a uniform flow pattern, there are various possible reasons, not all of them are dysfunctional. As an aside, we call it staccato technically if between the peak and the trough, the difference is less than the square root of the maximum flow rate. So if the maximum flow rate achieved, let's say, is 9, then you need a difference of more than 3 between the peak and the trough to actually call it a staccato. Right. Detrusor overactivity can be found in significant proportion of normal children. Poor compliance, especially in a child, might represent an error of accommodation. So if you fill too fast, you will induce what appears to be poor compliance, and this is common in children. So what you need to do to check is stop the flow and see what happens. And if it's an accommodation issue, when you stop, the pressure will drift down, and that tells you that you're filling too fast. In some children will be too young to cooperate for a filling phase. Some may not want to cooperate for avoiding phase. Important to differentiate these from acontractility as we have discussed earlier. Outlet obstruction can get misdiagnosed because of obstruction due to the catheter. And this is not at all uncommon, especially in boys, because sometimes, although the literature seems to suggest that a 5 French tube should not obstruct, but we've seen any number of situations where a 5 French tube seems to obstruct. Children are also specifically vulnerable to adverse effects of the urodynamics. The child will remember for life what you did that day. Take it from me. Will remember for life. And one bad experience that day can compromise all the rest of their health care for years on end. And because many of these children, especially with high-risk neurogenic problems and so on, will be having multiple contacts with the healthcare system, that initial adverse effect, psychological impact, can have a profound impact on your ability to treat the child. You might have seen this. You sent the child for an MCUG. The MCUG was a disaster in terms of the child's psyche, and after that, the child is phobic of everything. So very important that you have the right environment. But more than that is the problem of sepsis. Now, when you talk about infection rates after an invasive urodynamic study, whatever is reported in literature is primarily for the uncomplicated female patient coming with stress incontinence. If you look at neurogenic populations, look at populations of compromised children, hydronephrosis, secondary reflux, these patient populations have a much higher risk of sepsis. And if they get into develop an infection, getting into the ICU is also much more likely. So you need to be very cautious to identify high-risk situations. Consider pre-treatment if you are in doubt. In fact, the ICCS guidelines recommend that if child has a positive culture on CIC, to give a 3-day course of antibiotic, which most of us don't do, and I wouldn't subscribe to that either, but I would use prophylaxis. Management of pain, and always ensure that you've emptied the bladder at the end of the test. And this is true for all patient populations, especially in children, because if you don't, you'll end up with sepsis. And radiation exposure when you use fluoro. It's almost always feasible to get the required information. So provided you have tailored what information you need, you are clear in your mind what you're looking for, whatever the age of the child, and even if the child is not very cooperative, usually it's possible to get the information. And most often we are looking for storage, because in any 24-hour period, it's 23 hours and 50 minutes of storage and 10 minutes of voiding. So what happens during storage has a far more impact on the upper tracts than what happens during voiding. So we'll now look at 3 conditions here, 3 examples. One high-risk neurogenic dysfunction, one non-neurogenic, and one other condition to illustrate some of these issues, some of the important issues. And some of this task is made easier because of Pawan's presentation. High-risk neurogenic is a different spectrum in India. In the West, it's primarily spinal cord injury. Their main 2 patient groups are spinal cord injury and multiple sclerosis. Our main condition is spina bifida, an anorectal malformation, along with spinal cord injury. And the child with spina bifida, which is now a rarity abroad for various reasons, is a much more challenging situation and has a much different clinical course than the other patients. So I think I will skip this because most of this has been discussed in Pawan's presentation. This is about the DLPP. Any questions about the DLPP? So when you're filling the bladder during the test, at some point, fluid starts leaking by the side of the catheter, even if there is no bladder contraction. The volume at which it happens is the detrusor leak point volume, and the pressure at which it happens is the detrusor leak point pressure. Both are important. My detrusor leak point pressure might be very high, but I'm not at risk. I hope so, at least. I'm not at risk because that volume never gets reached. So the volume at which it happens is also important. So let's skip some of this, and I think this has also been discussed. So I'll skip this as well and straight go to the 3 cases. Okay, so let's take a look at this patient now. And this patient has apparently normal storage. That's the P vesicle line, the P abdomen line, P det. So the third line, the blue-green line, is the one which is the P det line. The filling has happened to 320 ml. And the compliance is good or bad? Compliance is good. So there's a normal capacity, a normal compliance, no neurogenic detrusor activity or no detrusor activity. Whatever contractions you are seeing in the red line, those are all spontaneous rectal contractions. And because of the spontaneous rectal contractions, you can see dips not sure how to make it work. You can see dips in the PDET line. Those are all artifacts, right? Now, if I were to ask you, this child has been passing urine spontaneously, is now in, let's say, teenage, for instance, and has been passing urine spontaneously for the last 10, 15 years. Is this child safe or unsafe? What would be your answer? Is the storage safe? Is the voiding safe? This child is voiding by abdominal strain, and you can see the child has managed to void out almost all the urine. There's hardly any. That's the end fill pressure. This one? Or this one? Okay, okay. The child has the end fill pressure is about 10. That's the command to void. There's an A contractility, but voided by abdominal strain. You can see an abnormal flow pattern, but there's no residue. So would this child be safe, voiding and storage? Apparently safe. Okay, we'll come back to this in a moment about the safety issue. But what we... So why would you say that the voiding is not safe?
Because he has to continue like this throughout his life.
Okay.
Training, so risk of hemorrhoids.
Okay, so you are talking in terms of the risk related to long-term straining by the patient. Agreed. So here when I talked about safety, I was actually implying safety in terms of the upper tract. So this patient has been managed since birth with a congenital condition and has reached this point. I'll come to the condition in a moment. Has been managed with a congenital condition with spontaneous voiding, and this is the urodynamic evaluation, which looks okay. And this is the question in front of us. Let's take a quick look at this patient's video now. How do I make this run? Okay. Sorry, I had to switch from Keynote to PowerPoint, and I'm not very sure about it. Okay, that's the bladder, and you can straight away see a large volume. Oops. Oh, come on. Sorry. So you can see a large volume reflux here, right? Let's run this a bit further. Okay. Let's come to the void. Okay, that's the voiding. Okay. Okay. Right, that's the void in this patient. In fact, this child is now 31, has a history of anorectal malformation, denies major voiding difficulty. The parents say that he's okay, he's managing. Probably because he's never known what normal voiding is. He has episodes of urgency and incontinence, but he's been reasonably okay with 1 to 2 episodes of febrile illness in a year, constipation, but was managing. He's got a creatinine of 5 and bilateral hydronephrosis. So what I'm trying to tell you, the reason why I showed you this was the point that Pawan also mentioned. Urodynamics cannot tell you that a patient is safe. Urodynamics can tell you that a patient is not safe. So the other way around is true. You can determine from the urodynamics not safe. There's nothing on the urodynamics that will tell you that the patient is safe, child or adult. Safety, the decision or the judgment that a patient is safe in terms of lower tract function is based on the entire clinical constellation of the patient's symptoms, the patient's imaging findings, and the overall clinical course of the patient, not just a pressure measurement number. So some of the key messages from this patient that I wanted to show you was, urodynamics is number 1 mandatory in the high risk diagnosis. So anorectal malformation, open spinal dysraphism, spinal cord injury, you do not need symptoms to decide to do a urodynamics. You must do a urodynamics. And in these children, the congenital children, as early as possible. So we've had children coming at 1 year of age with established renal failure, which is preventable. It must include or combine imaging. So I showed you combined imaging. If most places you will not have access to combine, that's fine. As long as you are doing a separate imaging and intuitively combining it, most of the times you'll get adequate information. As long as you know that you've got to do that. And in fact, guidelines tell you that you can. So in guidelines it's there that you can actually do a combination by having a standalone VCUG. In this setting, the ability to void or ability to store is not important. What is important is the safety of storage and the safety of voiding. And as I said, elevated storage pressures are a reliable marker for lack of safety, but lack of elevation doesn't mean that the child or patient is safe. Now let's take a look at this patient, a posterior urethral valves. Let's see the background history. Vesicostomy at the age of 15 days, PUV fulguration at 4 months, closure of vesicostomy at 2 years, bilateral ureteric reimplantation at 3 years, and we can always debate whether this was ever necessary. And this is the urodynamics in this child. Now, will somebody from the audience, you all had a morning session where you've all discussed about how to read a trace. That's the volume here, 200 ml. Is that volume of filling adequate for a 7-year child? Capacity? Roughly okay. So 7 plus 1, 8 into 30, about 240 is what you say. So this is fine. So 200 ml is fine. Okay. What about the compliance? So this is scaled to 0, 200. Compliance, okay. So no major compliance. Is that a phasic contraction? Not really. You can see a dip in the abdomen line, right? So it's not a phasic contraction. Is it a good fidelity? Is it a good fidelity tracing? That's the first thing we should have checked. Storage pressures, a cough in the beginning, good subtraction. You can see an initial resting pressure. The fine trace matches between the two, right? There's a cough before this voiding has been started, and there's a cough at the end, and they have all subtracted well, right? So it's a good fidelity trace. Okay. Oops, what happened? No, I went backwards. Sorry. Okay. Let's run this. Okay, let's take a quick look at the video for this patient. So again, you can see here that there is a high volume reflux here, and we'll just discuss in a moment, okay? So let me stop it at one of these points. Right, okay, so there's a high volume reflux on the left side. So now let's look at 3 different histories for the same patient. Same urodynamic finding, a hypothetical history 1. Child has urinary frequency, urgency, bilateral hydronephrosis, and a drop in the EGFR. What's the interpretation? What's the storage like? Safe or unsafe? Unsafe. So the storage is unsafe. Our judgment is that whatever pressures we are seeing which appear to be normal is because of the reflux. So pressure is getting masked. So the interpretation with this history is unsafe storage, confounding by the VUR. Recurrent VUR is probably indicative here. This child already had a bilateral reimplantation of an unsafe bladder. Let's look at an alternative history. Child has voiding difficulty, uroflow of 3 milliliters per second, a residual of 40 by 150, history of recurrent UTIs. Now what's your conclusion on that urodynamic trace? Let me go back and show you the trace. History of voiding difficulty and a slow stream. So our initial assumption was that whatever we are seeing, high pressure and slow flow, is not really an obstruction, maybe tube artifact. But if the child has a history of voiding difficulty, then this might not be a tube artifact. What could it be? So one of the things it could be, if you're getting something like this, is, let's say if there's been a stricturization at the place where the wall fulguration has happened. You put tubes, there's hardly any place around the tubes. It's got to be a passable stricture, obviously. So there's a passable stricture, you put this, and you'll get severe obstruction the moment you've got the tubes in. So in any case, if the history suggests that the patient has voiding difficulty, here the interpretation changes now. It's possibly a passable stricture at the membranous urethra, secondary VUR due to a severe obstruction, possibly. What's the actual history of this patient? No lower tract symptoms, no infections, normal flow, stable morphology over years. That's the flow rate of this child. The interpretation here is residual VUR, residual urethral dilatation with a little bit of catheter-induced fullness, which you're seeing the VUR, and this child is actually okay. So you can have exactly the same urodynamic tracing. I just changed the clinical background for 3 hypothetical, 2 hypothetical, and 1 actual situation, and our interpretation completely changed from normal storage to abnormal storage, normal voiding to abnormal voiding, and normal both. Sometimes the imaging can give you some clues. So take a look at this child who has PUV. That's the current MCUG. And that shows, you can see a diverticulum here, bad bladder, dilated urethra. Conclusion? This child has already had a valve fulguration. So there is concern regarding lower tract function. We wouldn't really call it neurogenic, but a lower tract dysfunction associated with the PUV. What about the posterior urethra? Looks dilated. Now, that's the pre-op MCUG. Now what? So now it's quite clear that there's an improving urethral morphology, right? But there's a deteriorating bladder morphology. So looking at serial images can give you an idea as to what's happening. So this child has not been managed for storage, has had a valve fulguration, is voiding well, the outlet obstruction corrected. And that's a classical example to show you how morphology may not tell you what's happening functionally. This child is voiding very well now. And you can see there is still dilatation, but the moment you put the pre-op film, you can see a dramatic reduction in the amount of dilatation that was there. This is the last condition I'll show, and this is one on dysfunctional voiding. Now, dysfunctional voiding is a specific clinical situation where you have a dyssynergic outlet in the absence of a neurological basis to it. So there's no neurological underlying condition, yet there is a dyssynergy of the outlet. In that situation, we would call it dysfunctional void. Now, if you look at the ICS definition, the ICS definition includes a description of the type of flow, stating that the flow will show the kind of staccato pattern that we were talking about. So the ICS definition does not provide any place to classify a patient who has a dyssynergy of the outlet, does not have a neurological condition, and does not have a staccato flow. And we see any number of such patients. So in this patient, anyway, let's come back to this patient's video again. Okay, so how's the storage like? So this is, I think, a 16 or 18-year-old child, 340 ml filled, compliance. Looks good. No phasic contractions, sorry, it's got obscured by this video image. No phasic contractions, right? A normal looking bladder so far. Is this phasic? Is this detrusor overactivity? Yes or no? Who says yes? Hand, a show of hand. Who says no? What do the others say? Okay, so to be able to decide this, whether it's phasic contraction or, the first thing you need to check is when was the micturition command given. And you can see here micturition command, that's the place where this patient has been told to void. And then you need to be able to understand from the person who was standing there what happened. So this patient was told to void. Let's slow it down here. Was told to void, and that was not a phasic contraction. Okay, that's the place where the voiding is happening. You see here a high pressure, slow flow, female patient, dilated proximal urethra, consistent with a dyssynergic void. And in this patient, there is no neurological abnormality and the MRI is normal. So in the absence of a neurological abnormality, a high pressure, slow flow, dilated proximal urethra, no anatomical narrowing in a carefully done cystoscopy. This is all put together a dysfunctional void. You can get exactly the same view if the patient has an anatomical stricture in the distal urethra. It's possible to get that. Although usually that much of compliance is often not there because of some amount of scarring, but you can see a proximal dilatation with a stricture urethra in the distal urethra. Less common, but can be found. So you will be faced with situations where a patient, especially in children, this may happen, a child is brought to you, has some features to suggest lower tract dysfunction, but there's nothing overt to tell you is there a neurological basis to that. And so it's very important to see whether there's a low, or let's say a nephrologist refers a bilateral VUR to you, and you now want to decide is this VUR primary or is this VUR secondary? So what are the clues to a lower tract dysfunction in a patient in whom there is an upper tract abnormality? These are some of the clues. I'll just run through them quickly. Lower tract symptoms. So you have reflux, lower tract symptoms. Suggests a problem in the lower tract. Clinical indications of neurological disease, concomitant bowel and bladder symptoms or lower limb symptoms, a spine examination which is abnormal, bilateral upper tract involvement, especially if you have dilatation down to the VUJ, thickened bladder wall, elevated residual. So there's some situations where we start putting more credence or value to the thickness of the bladder wall. Not a common thing that I would normally place emphasis on, but in some situations the thickness of the bladder wall becomes important. Remember, the bladder wall is an elastic structure. Any elastic structure, the thickness depends on how much it is stretched. So the bladder wall thickness will alter with the amount of volume that the bladder is filled up to. So keeping all that in mind, if you have a gross thickness, we all recognize it. Minor differences in bladder wall thickness carry no meaning. Elevated residuals on the ultrasound, an X-ray showing bony abnormalities or X-ray of the spine, a poor stream, or an MCUG or video showing altered bladder or posterior urethral morphology, all this may be the clue to a lower tract abnormality in a child who has an upper tract, or an adult who has an upper tract problem. This usually comes across in children where the nephrologist has a problem in the upper tracts and you're trying to identify is there a problem below or not. And sometimes even the urodynamics is difficult to interpret. Let's say there's bilateral reflux, your storage pressures become normal because of that. You don't know it's normal because of the storage pressures or because of the fact, because of it's actually normal or because there's a reflux. Similarly, voiding gets confounded in children so many times because of the catheter. So you need to rely on all those things in such situations. So to conclude, in children, the interaction that you have with the child will be implanted on the child's psyche for a lifetime. It's very important that you leave behind the right impression. Sepsis can be life-threatening in vulnerable children. It's an inherent risk built into what you're doing. You may do all the possible precautions that you do. You'll still have a risk of sepsis. It's important to recognize that. And these two are so important in any child, which is why I put them right at the top. Which is why you should be clear in any child especially, do you need the urodynamics? And if you're not sure about it, you better be sure that it's required before you embark upon it. But for the child who needs it, it has to be done. So like high-risk neurogenic dysfunction. There will be challenges in interpretation due to inadequate patient feedback. The child can often not tell you what's happening. And because of lack of cooperation, especially in the young child, or sometimes even in teenage children for that matter. Imaging, either synchronous or metachronous, can be crucial to interpretation. And you get only one chance, especially in the child. In an adult, the patient comes to you, let's say your technician has done the study, he comes to your room and you look at the whole file, examine the patient again, and you decide, I want another round of testing. I wanted this maneuver. And you send this patient back to the urodynamics lab. You can't do that with a child. You shouldn't be doing it with an adult either. So it's very important you get one chance with the child to get it right. So make sure that you have all your resources devoted the right way. If you're going to use a video, make sure you see it, or somebody who really understands sees it. We have, for instance, a video feed into the OPD, so I can see from the OPD what's happening and so on. So it's very important that that one chance is taken in the right manner. Thank you. Any questions? Hold on. The dysfunctional void child patient? Okay. Maybe I might have missed it. Let me check. This one, let's see. Oops. Can I get the feedback? Yeah. Okay, which point? Are you talking of this? Okay, right. I'm glad you asked me that. The detrusor is a smooth muscle. All smooth muscles take time to recruit. So if you're observing when you do a laparotomy or laparoscopy and you see a peristaltic wave pass down the intestine, there is a time that smooth muscles take to recruit. Any sharp changes in pressure has to come from a skeletal muscle, can never come from a smooth muscle. So this rapid rise and fall that you are seeing has to be an artifact because there is nothing in the bladder that can produce this kind of a pressure rise. So these are artifacts of pressure subtraction. So the one is what I just told you. The bladder cannot contract this way, right? A smooth muscle doesn't contract this way. And then you've got to see what's happening in the other channels. So you can see there is some amount of disturbance here for certain reasons. The subtraction is not very good in this patient at this point. It's better as the bladder is filled up. Sometimes when the bladder is not very full, the catheter is touching its tip somewhere and you don't get a very good subtraction. But you can see towards the end, before the void, the subtraction is good. After the void, subtraction is good. So the fidelity of the tracing is fine, but you can see at some points we've not had very good subtraction. Sometimes the subtraction is slightly out of phase. So due to that also you can get some amount of deflection on the PDET. But this is not a phasic, this is not a bladder pressure. Okay? So when you get changes, which are sharp, if they are from the urinary tract, they have to come from the outlet, the striated sphincter or pelvic floor. That's again striated. So striated muscles can produce sharp changes in pressure, but the rest of the urinary tract system won't, sir.
What is your take on UDS in children with anesthesia?
So by and large, so number one, it's feasible. If you're doing it, you want to avoid neuromuscular blocking agents. Most authorities would suggest that it is ideal, if at all you're using anesthesia, to introduce the catheters under anesthesia and do the study when the child is awake. Right? And we've done that once in a while. But with experience and after realizing that in most of these children you're looking at storage, and most often you can get information regarding the storage even if the child is not 100% cooperative. So we have really reduced our anesthesia now in children. Now it's very rare. But I won't say we don't, but it's become much less common. So earlier in our practice, maybe every month, one or two children, let's say in a quarter, we were giving anesthesia. These days, I'm just trying to rack my brains when we did it last. We've not done it this year, for instance. So it's not been very common, although we handle a lot of children. But by and large, we're able to get the information of most of the children despite that. Oh, so regardless of whether you're going to give anesthesia or not, I think anywhere where you do interventions, you want to have a supply of gas. And if for nothing else, because if you're tackling neurogenic patients and a patient has autonomic dysreflexia, you might require everything there. So it's very important to have a crash cart somewhere close by, to have supply of gases, and to have your staff aware, especially of autonomic dysreflexia. And to monitor pressures in patients who have got lesions above T6 and so on. So it's important to have emergency supplies there or in the vicinity.
Sir, what is the significance of the detrusor after contractions? They're seen in kids more often. So
Right.
what is this?
By and large, so if the contraction is, so when we say after contraction, it implies that the bladder has already emptied. Right? If the bladder is already emptied, there's no real significance to it, to the best of my knowledge. So I don't think it really carries any significance. If the bladder has not emptied, we shouldn't be calling it an after contraction. But if the bladder is emptied, which is what is prerequisite for giving it that label, then it doesn't really carry any significance. We wouldn't judge the detrusor contractility based on the pressure achieved. So contractility indices, so I think that's the important thing to discuss here. Contractility indices are based on the flow at, the pressure at maximum flow. They're not based at on the maximum pressure achieved. So the after contraction often exceeds the contraction, the maximum contraction during the void, often. So you'll find there's a contraction during void like this, and then there's an after contraction like this. But that contraction pressure doesn't give us an idea of the contractility, because that's not how the indices are described. Yeah, so they do. So we, by and large, what the data seems to suggest is that if you have a tube of 5, 6 or 7 French in size, typically even for children, they say it should not compromise. Clearly, we are not talking of newborns and 1 and 2 year olds, because in them usually you don't do a voiding phase study at all, or you don't really get a good voiding phase. So for the young child, let's say above 5, 6, 7 years, that's what they say. But having said that, any tube has the ability to can compromise voiding. Even in adults, for that matter, it can. And so it's good if you're using 2 feeding tubes to remove one of the tubes when you're doing the voiding phase, if the voiding phase is critical to you. Or you've got 2 tubes in, you've had an excellent voiding, you know it's normal, you don't need to repeat your test at that point. The thing is, the moment you remove your second tube, you can't do a second cycle. So you've put two feeding tubes, you've got 1 feeding tube out to do the voiding phase. Now if you've got to go back and repeat a study, you've got to again catheterize the child. That's a challenge. So In such situations, we would often do our first cycle of voiding with both the 5 French tubes in, and that's equal to little less than 8 French single lumen tube. And if the child voids normally, we don't need to do anything, study's over. Doesn't void normally, refill, and then remove the second tube and do another cycle. Okay, thanks. Back to you, Gopi.
Next, I think, next I have Dr. Prashant Naik, who is from All India Institute of Medical Science, Bhubaneswar. He'll be talking on artifacts in urodynamics.
Can I run it from here? Actually, I have been given a difficult task. This is not my presentation. These are not my slides. Nitin was supposed to present, but unfortunately, sir could not be with us. So Arvind has just handed this to me half an hour back. So we thought the slides are good, has some learning material. So we'll just run through them, and I'll take inputs from the experts who are there on the floor also, right? So what is an artifact? Something observed in an investigation which is not naturally there, but it occurs as a result of the preparative or investigative procedure. So this is not what is the natural course in that particular patient, but it's only because of the procedure. This has to be the normal curve, which is the normal uroflow in a 30-year-old male. We have already dealt about that in the morning today. This is what we talked about, that this sudden sharp intake or uptake is probably an artifact, so you need to round it up. So you can see the Qmax may be around 19, but this is not 19, this has been rounded off here. This also has been discussed in the morning. So it's about 8 is the Qmax here, rather than the 16.6 that were recorded by the machine. So there are articles about this, that in a same patient, if you do it multiple times, there could be differences of 2 ml per second in 40% of the patients, right, if you do it multiple times. And there are various artifacts. So in 20% of the racings, up to 2 ml per second, up to 9% of the racings, up to 3 ml between the machine read values and the manually read values. So there is another one that says about 1.5 ml. The machine read values are 1.5 ml higher than the manually read or manually corrected values. So this is the artifact when you do your uroflow. WAG artifact, what Dr. Sanjay was showing in the morning regarding the dog doing. You have a patient who is wagging his penis all over the uroflow collecting chamber, then you could have this WAG artifact because he is moving the urinary stream in relation to the central exit of the collecting funnel. So you could have this. Patient artifact squeezing. So some people have a habit of squeezing the penis. Once, what happens is they don't have a good flow. Flow comes down, so they just squeeze it. Then the next time the flow improves. So this is the squeezing artifact. He gets a good flow, comes down, again squeezes, and then again he has a good flow. So this is the squeezing artifact where he has got this interrupted pattern. This is not actually his true uroflow pattern. UTI, this patient, same patient was done in October. Patient had a very bad flow, and then later once the UTI was corrected, it was repeated, and then look at the flow. So the flow improves because the total amount of voiding quantity itself comes down. She is not able to hold more urine, and that's why the flow was less, right? Similar restriction you may have in interstitial cystitis. So because of that, patient is not able to hold more amount of urine, so the actual flow is not truly representative. This patient, so look at this flow. So this quantity is very less, and that is why this interrupted pattern is there. This was asked to get repeated, and this is the repeat flow. So you see the repeat flow, and then this is the corrected flow. So this is the same patient on the same day. This is one flow with inadequate amount, and this is second time with an adequate amount. Sir, is that what this slide represents? Is it about the amount? Why was it asked who get repeated here? What was the reason this was repeated? You can. Yeah. Yeah. Even if you make the patient comfortable, he feels all right and all that, still the bladder may not be comfortable. So that is the syndrome of what is called bashful bladder. Patient is comfortable, he says he's comfortable, but if you have not given him surrounding, if you have not given privacy, then he may not void adequately well for the way he usually voids, right? So like sir says, if you ask him, is this how you void routinely? If he says no, then you better go ahead and do it again. So you repeat it. Voided volume, if it is less, you have this pattern. If the patient takes adequate water, has a good voided volume, then you get a better pattern, right? This patient has a normal flow when you do a uroflelometry. You look at this is a little bit sharp uptake, but after that there is a good L-shaped curve, 18.5 is the maximum. This is the same patient who is undergoing a UDS. So here you look at the flow here, right? So this is less. So if you do not find concordance between your UDS flow and your uroflelometry flow, you know that something is wrong, that this is not a true representative UDS for this patient, a true representative invasive UDS for this patient, right? The technical artifacts, most of the things have already been discussed. That rapid filling, if you do, about 33% less maximum systematic capacity. There could be kinking, knotting, filling through the Foley's catheter, suprapubic catheter could cause irregular race, catheter could get dislodged. There could be rectal spasm, which increases the rectal pressures. So these are the various technical artifacts which could happen during a storage phase filling systemetry. Air bubble, already discussed in the morning, can cause dampening. So the dampening causes this decreased amplitudes here. So that is, if you see this, you have to flush the catheters and make sure the air bubbles are cleared. So this is again a rapid filling detrusor activity, overactivity. You are seeing the filling is rapid, so you can see this detrusor overactivity. Same patient, it was repeated with a medium filling rate, and you do not see any detrusor activity now. Detrusor overactivity now. So this is filling rate related artifact. Improper balancing. So you see the rectal catheter, there is a rise, maybe the catheter was touching the wall or something, there is a rise, and then it was suddenly balanced to 0 in between. And then because the rectal catheter was balanced, so this has gone up, the heat rate has gone up and all that. So you get a improper reading or a false reading here. So improper balancing of the rectal catheter was done here. So again, this is about what Dr. Sanjay was recently saying, that what happens if there are rectal contractions. So patients get rectal contractions. So you can see these are the abdominal pressure artifacts which are getting reflected here, because the P vase is not changing, only the abdominal pressure is rising. So P vase minus P abdomen becomes negative. So you see these negative spikes on the heat detrusor. So this is the genuine unstable. You can see that there is a rise in the P vase also, and there is a simultaneous rise in the heat det. But these are negative, these are artifacts because of the rectal contractions. Again, this is another video which is showing the rectal contractions. So this is P abdomen, rectal contractions, which is showing reflected in the negative this thing in your heat rate values. So what are the patient factors? Small bladder capacity due to inflammation, infection, radiation could have a bearing on how the final UDS appears. There could be VUR, as excellently showed in the video. That's UDS picture. There could be bladder diverticulum. Instead of draining out, it is draining into the bladder diverticulum, or it empties into it, adding. So there could be leakage of fluid around the catheter. Patient could be on drugs and medications like anticholinergic spasmolytic, generally stopped 3 days before. But if you want to, in certain clinical cases, like you want to evaluate the effect of the medication, then probably you need to do the UDS with the medications on. So that was what in the morning Dr. Pavan was telling, that most of the times you need to stop the medications, but there are few clinical conditions where you need to do the UDS with the medications on, right? This is defecation. Patient has defecated in between and the PVS catheter has come out. So because the PVS has come out, that is where the EDAT also has gone down. Impact of catheter size. The larger catheters, any catheter can cause obstruction, but the larger the catheters are, then there is more chance of obstruction, which would affect the voiding phase of the UDS. So 10 French catheter incorrectly diagnosed bladder outlet obstruction compared to the 5 French catheter. So this incorrect diagnosis was increased by up to 32% as per this article. Catheter could slip, there could be a deflection of the urinary stream rather than it going right into the funnel. Equipment calibration error, these are other issues in the pressure flow studies which could happen. Physician related wrong technique, erroneous interpretation, inability to recognize artifact. What you don't know, you will not be able to recognize on the graph. So you should know about them. Again, urethral catheter has slipped out while hiding, so this is the artifact which is reduced. There is a flow and suddenly it has slipped out, so you are not seeing that. This is the after contractions that we just discussed. During the hiding phase, you can look at the flow. Flow has gone. After the flow comes out, still the EDAT contractions are increasing. So after contractions generally has not much relevance because this is happening after the flow. And as sir told, these peaks are not to be considered when you are discussing about the EDAT maximum in the study. Yeah, so Transducer overactivity during voiding. This is another entity. So while patient is voiding, there could be an overactivity that is imposed. So this should probably be evident when you look at this. So you're looking at it, and while there is a smooth curve like increase, suddenly there is a spike. So this is probably, this could be due to a Transducer overactivity superimposed on the patient when he's voiding. So superimposed upon the bladder pressures. Interruption of stream. So patient, this is a patient has interrupted the stream voluntarily, and that's why the pressures increase. What we discussed in the morning regarding the isometric rise in the pressure. So if you interrupt the stream, the flow has come down and the pressures go up. So this is an artifact during the voiding phase when a flow has been externally forcefully interrupted. EMG is the study of electric potentials, only direct aerodynamic measurement of striated sphincter muscle. Not very accurate, but it's a part of the pressure flow study, and so where you can see what is happening to the sphincter activity while the patient is voiding. Right, so how do you record it? There are anal, vaginal, intraurethral and skin patch surface electrode, and there are needle electrodes also. So what could be the various artifacts? Incorrect placement of the needle electrode, improper grounding of the equipment, close proximity to strong electromagnetic power sources, misidentifying spontaneous fibrillations and dislodgement of electrodes with poor conductance. So this could be the various reasons why the EMG artifacts should be seen on a trace. So here you can see the EMG leads lose contact, which cause a loss of EMG signal. So this area there is a loss of EMG signal and the EMG leads have lost contact. So that is this thing. And you can also see flaring because one of the EMG leads are lost contact, so the other is flared. So this is a flaring phenomena, and this is an absence of the EMG tracing because both of them have dropped out. Right. So tips for an error-free study: hands-on, expert observation. More important, you need to be the one who is doing it for you to interpret it accurately. Ensure that the pressure baselines is stable and movement-free before and after each stimulus. Wait for a return to, you can give a cuff stimulus, wait for them to return to normal. Straining and gross movement need to be noted and subtracted. Repeat the study if necessary. So this happens many times. So sometimes UDS can get a bit tedious because of the need to repeat the studies. But if you follow the rules and you follow the correct procedure, then you can try to minimize your need to repeat the study. Conclusions: a single abnormal aerodynamic study can be, if you have only a single finding or small finding that is abnormal, you should suspect that this is artifactual. Rest everything is normal, but you only find a small aerodynamic abnormal finding, then you should be careful that this could be artifactual, and you have to critically analyze that particular that particular finding. If a UDS fails to reproduce patient's symptoms, it doesn't mean that they don't exist. So it doesn't mean that what patient is saying is wrong. You just have to do your study proper, or probably ask the question that what kind of investigation needs to be done. Probably the kind of UDS that you're doing is not the right fit for that patient. So detection of an abnormality irrelevant to patient symptoms. So generally insignificant. If you find something that doesn't correlate to what the patient is complaining and what his symptoms are, then probably that is insignificant. So treat the patient and not the UDS report. Thank you, thank you, thank you. If you have any question regarding artifacts, you could ask. I think we have experts here with immense practical experience, so they would be happy to answer all your queries. Now we'll be having live UDS demonstration. So that's the next item on the agenda.
Dr. Arabind, are you ready?
Sir, 1 second, sir.
Dr. Arabind, Dr. Arabind,
Sir, ready, sir?
yeah.
Can you hear me?
Yeah, we are able to see.
Yeah, can you hear me now?
Yeah. So, would you please explain us what is happening? And I think.
He doesn't understand anything of Hindi.
So.
Yeah, can you hear me?
Yeah, you're audible.
So we patients, we are all
and
almost ready.
you're audible. We
yeah,
can.
We are ready. We're going to put the patient.
If it is not dangerous, you can. And if it is safe, you can remove your mask, so that it will be much more clearer. And. Yeah.
So I like to.
So, as anybody can tell us about the history of the patient.
The first patient is Mr. Ravinder. He is a 46-year-old man, and he has history of voiding lower urinary tract symptoms for the last 4 or 5 years. He has poor flow. I'm just going to give me a second. Yeah. Okay, he is 46-year-old and he is hypertensive for last 4 years. He is diabetic since 2 years. He had history of acute pancreatitis around 4 years back, and he also has seizure disorder. His symptoms are weak flow, urgency, incomplete bladder evacuation, and straining. He also has intermittency. He has normal bowel habits. In lab investigation, creatinine is normal. Sugars were high, 250 milligram. The CU was normal, pus cells was less than 1. And Dr. Gopi, can you show, I have opened his radiology on the computer. Can you just show his radiology on the computer, Mr. Ravinder Reddy? Dr. Gopi, can you hear me?
Yeah.
On the computer, I have opened his radiology.
Yes.
Just show that image. If you run down that image, that is the MCU of his, that's his MCU. Can you see the MCU?
Yeah.
Ready?
So this is his X-ray.
Can you ask them to show? They are not showing here.
Yeah, I think.
Yeah.
Take this on PIP, na? The one on the.
No, can you got it? Did you get his?
Yeah, I got it.
Yeah, radiology is seen. You can see.
We don't have it on the screen, Arvind.
Yes,
we're
sir.
just waiting for it.
Yeah. Ravinder Reddy, 46. ID बता रहा हूँ मैं.
IT personnel, can you just put the computer image on the EIP screen, please?
1169324.
The computer image
put
here.
This on the. This petna din meeta.
Yeah.
Systemetry.
ఇది ఏంది?
Systemetry plus EMG कर सकते हो? बस लगाना है आपके पास पैच? ECG पैच चाहिए ना बस? ECG लेके आना ना? 4 ECG, 3 ECG. So have you now been able to see his MCU?
No, we are just waiting on that, Arvind.
So, Dr. Arabind?
Yeah. You have been able to see the images?
Yeah.
We will be seeing it shortly. Yeah, now we are seeing it.
Yeah.
So, can we balance the transducers? लगा दिया आपने?
Do you have anything specific in the MCUG?
Yeah, so my suspicion, our suspicion is this could be this is a young man with lower urinary tract symptoms. He is diabetic, of course, but the diabetes is not long enough for us to get cystopathy or any of or underactive detrusor. So the point is we have to differentiate whether he has obstruction here. So that is the reason for doing the UDS.
Looks like BPH.
Yeah, he is 46. It might be BPH. It also might be a bladder neck obstruction. The prostate is not very big. It's only about 20 grams, and the PVR is low. So I'll just go through it again. And his PVR also is low. It's not very high.
Anything specific in MCUG?
Yeah, you have seen the MCUG?
Yeah.
So okay, we are ready now. We have put ECG electrodes. We have put the EMG electrodes also, and we are doing now a cystometry with EMG. Yeah.
This Arvind, can we have pictures from the OT?
Yeah, can we? I think we are now taking. Can we have pictures from the OT? Yeah, we are just going to send you the pictures.
Yeah, now we are with you.
So, before. before we go to the actual procedure, can you explain us how to put these tubes and how to fix up the tubes
that
in
is
and
something
around?
that we actually, if you look at the idealized pictures, there is no tape anywhere.
Yeah.
But what we have realized is if you don't put enough tape, these tubes tend to come out. And can we start? We are going to start here. This is a status machine, and we are going to start cystometry plus EMG.
What catheters do you have in Arabind?
Yeah, I have a double lumen rectal catheter inside.
Okay.
And I have 2 infant feeding tubes for the filling and the. Can you see them?
Yeah, intravesical.
We have 2 infant feeding tubes, one 7 French, one 6 French. Okay. I will remove the filling tube after our filling is complete.
Okay.
But then sometimes it becomes difficult with the with all the tape. But we'll see, and we have put the EMG electrodes also, just to see how the EMG electrodes works in this patient. That's it. Enough.
Okay.
So now you can look at the screen. Can you see the screen now? We'll turn the machine towards the
any difference of opinion or the way you all do it differently?
No. So for filling we use.
So you can see the start. Now we are going to balance the transducers. No, wait. So as I was talking about balancing the transducers, it's important to balance the transducers with everything open. Now I'm going to.
Can you show the external view, please? Yeah, sure.
Okay, now make it zero. There is some air in these. I can see some air here. Give me the flush. Other one. अरे दूसरा है खुला है
Yes, we can see the air bubbles.
Yeah, the air bubbles are coming out. It's not okay to have air bubbles. You are going to get and there are air bubbles even in this tube. Sometimes I feel we should use degassed, give me that. So degassed air, but that's always not possible anyway. So I'll just do a little bit of a flush. Just a second, I'll just flush it once. This is the P-vase, I have flushed it. Hopefully the air bubbles have gone inside the bladder. Now, I'm going to close it.
So you have connected the catheters?
Yeah, the catheters are connected because we just wanted to save time. It was not possible otherwise. And the problem is pushing air into the P-ab. That's not it's never.
That's not ideal scenario.
It's not ideal to flush. So anyway, now I'm going to zero to the atmosphere. Zero, please. Zero karo. Zero all. Done?
Yeah.
Okay, now I'm going to start the test. Now let's look at the P date. Now I have, let's see what the P date is. What is this? Yeah.
Yes.
Now you can see the P date is about 0.
Yeah.
But the P-ab and the, that's less than, again, it's less than 6. This is ideal, right?
Yes.
Close to ideal. So I think we'll ask him to cough. Can we have a cough, please? It looks good. Can you mark cough there? No, zero. Zero is already done.
Excellent. Fine.
एक्टिवेट होने के बाद वो मार्कर आएगा.
उनको जो कॉफ मार्क करो यार, हो गया. जीरोल किया था ना, नहीं किया था? जब मैंने बोला जीरोल किया था, हाँ बस ठीक है, उतना ही करना है.
So Arvind,
yes,
can we ask
this
you
is
to
the
cough
problem
once?
actually. He will keep on insisting कि नहीं अब zero करना है.
Start करो अभी.
So can we have him cough once?
Somebody did zero again.
Somebody has done
Oh
zero.
no, this is not the way to do it. I guess this is the problem. This is actually how you should not do it. Okay, this is how you should not do it. This
Somebody
is how,
did the zero.
Okay,
again.
they did the zero wall again. So I am again going to expose it to the atmosphere. Again I am going to do zero wall again. अभी zero wall करिए, start करके zero wall करिए. Okay, now I'll just turn it. Okay, now it is. I think we have got back to the same position. Okay, fine. Now we can start. I think. Perfect. It's perfectly okay. You can see those images. Quite acceptable, I think. Can you see?
No, currently the zeroing has been done with the tubes in the bladder.
Yeah, with the tubes in the bladder, but exposed atmosphere. I closed the.
No. But abdominal pressure is
zero.
Still zero.
But abdomen and vesicle are still at zero, so they're reflecting the zero pressure now.
It was earlier. It was all right before somebody.
Before somebody did. I can't help it, right?
It's.
Again, I'm going to try. Again, I'm going to try this. 1 second. Okay.
Open to the
So
atmosphere.
this is open
yeah.
to the atmosphere.
And then try zeroing.
Wait. Open to the atmosphere. Open to the atmosphere.
No.
Yes. Now you can. Now you should
It is open to
write
atmosphere.
zero.
Can
Yeah,
you
now
do
zero.
all?
Now zero.
No.
No. Now if it does zero, it will go up.
No, this is not correct.
No, this is not correct right now. But
No, it has to. It has to.
So there are a lot of air bubbles coming. So we have to flush again. Just a minute.
No. The block thing has to come downwards. Has to go
But I
downwards.
have to flush one. Just excuse me. So there are air bubbles here. I can't help this. One second.
Yes, it has to stay like this.
Yeah, 1 second. Let me just flush it.
It has to stay like
no, this.
this.
Is flush. This is flush. This is not. This doesn't have to stay like this. 1 second. This is flush.
This flush.
1 second. See, there are air bubbles. It's difficult to remove these.
So the tube hanging from the top of the transducer, is it going in the bladder?
This one?
The tube hanging from the top.
The one at the top. The one coming out of the top of the transducer.
That's NS. That is NS.
No.
Not that
On the
one.
transducer.
On the transducers, the one coming from the top.
Now I am going to open it to atmosphere. Both of these. Wait a minute.
Arvind, can you show that?
Which one? Which tube?
The tube.
This tube?
No. The tube that is the line.
Yeah, yes.
Where is this attached?
That is going to the rectum. Pre-apt, that is right.
That is going to the rectum.
Yeah.
And the other one?
Going to the bladder.
The other one is going to the bladder.
Yeah.
Then when you are exposing to the atmosphere, then the communication should be from atmosphere to the
rectum and the bladder.
To the rectum and the bladder.
Yeah.
So out of the 3 pointers, the straight one, that means the stop one should be facing downwards.
No, but if I do this, it's okay. Zero all kariye. No, that's not how to do it.
Arvind, another way to do it is
zero all.
Arvind, this is basically getting zero to the patient. Another way to do this is you disconnect the tubes from the catheter.
I think.
Can you hear? Is this? No.
Now this is okay.
Yes, now it is okay.
Yeah,
Can we have a cuff?
When you close this, this becomes okay. Now we start.
Yeah, we can start now, I think. No.
One cuff.
Yeah, that's fine, I think.
That's one
Perfect.
cuff.
This is the cuff?
Yeah, that was a cuff.
Start. Pump speed 20.
Arvind, can you ask him to do the cuff again? Because we didn't find the cuff to be very characteristic.
Khasi kariye. I think it's a very good cough. But I think it's too much. Cough, khasi kariye. I think it's okay. That is little bit of, there is little bit of a problem in the P-West catheter, I think.
Okay.
That.
More or less okay, but.
Yeah, that much is
now
okay.
everything
I think
looks all right.
we have started
Up
the
to
filling.
70% of the taller one.
I can try to correct the P-West catheter. There could be a bubble or two somewhere. Okay, we have started it. You can see, and this is we'll proceed at a speed of 30.
So Arvind is going to proceed at 30 ml per
minute.
Yeah, 30. We're starting at 30. Yeah. Can we start the next patient? We will. Yeah. Ready? Are you ready there? Huh? Raise the table. Put the CM inside. आपका जो पानी जाएगा, that has to be with the contrast. You are aware of that? Contrast भी डालेंगे, CM डालेंगे अंदर. Even if it is, we'll show the CM separately. Okay? So you take a 500 ml normal saline, and 500 normal saline में boss. 500 ml normal saline में वो contrast डालना. Take 100 ml out. Take 100 ml out.
Can we look at the graphs?
Yeah, can you show the graph please here? Please show this. Please show this. Please focus on this graphs.
There is some issue with it. It's not recording.
Which one? This one?
At least the graphs. Okay, fine. Yeah, all fine. We got another image.
Do we have a, okay.
Is the EMG functioning? Can you ask the patient to give some squeeze, rectal
खांसी करिए
squeeze?
एक बार. Okay, that's cough.
Not functioning.
Okay. जरा आप ना अपना जो ये जो pelvic muscle है ना, जरा tight करो एक बार. हाँ, yeah, you can see. छोड़ो. So you could have seen that EMG little bit of spike was there, not much of a spike. छोड़ दीजिए, relax. A little bit of spike was there.
Not very responsive.
So I am getting the next patient ready as well at the same time. So this we have started. We will now start the next patient. I want to show you here. Can we focus here? Are you able to see the next patient?
No, we are looking at the graph, Arvind, of this patient. Yeah, now we are seeing the other patient.
Okay, this is continuing. I'll let you know what's happening here.
Yeah, now we are with you with the images from the next patient, Arvind.
Yeah. So this is Mr. Madhukar. He's a 40-year-old male. He had fracture dislocation of T5 of dorsal thoracic vertebrae 5 and 6 with paraplegia and spinal shock. And he had posterior decompression and spinal fusion D5 to D7 with dural repair in February 2011. He was on an indwelling catheter all this while. He has never been on CIC. He came to me asking whether he could be on CIC. So we are doing the UDS to see what is the compliance and the capacity of the bladder, and whether it is a safe bladder or unsafe bladder. But having said that, ultrasound showed mild dilatation of bilateral PCS. Urine culture was E. coli. He has been treated more than 10 to the power 5, significant. Obviously, he was on catheter for a long time, but we have treated him with antibiotics before doing this study. His creatinine is normal, 0.5. So here we were not able to combine the module to do the video UDS, but what we are doing is we are recording the CM images separately, and we'll try to show you picture in picture at the same time.
Okay.
So what can be the explanation of bilateral hydrouretronephrosis?
Probably he has neurogenic detrusor overactivity, and sometimes that can be significant even if it's there on a indwelling catheter. It's not sometimes sufficient. The bladder is thick walled, and these patients, if they have to be on an indwelling catheter, they also need anticholinergic at the same time. We have attached the EMG module here as well, and we have put, you can see actually he is leaking here. We emptied the bladder. He was on a Foley's catheter and he has leaked twice. You can see, can you see he is leaking a bit here of urine? So probably this is a neurogenic detrusor overactivity, probably a UMN type of bladder. Anyway, so we can start now, and are you ready? Where is the saline? Only it is only saline, or you have put contrast? Why don't you put the contrast? We're giving you the contrast there, right? Where's the contrast bottle? Brother. Yeah, we've got the contrast here. So this is the contrast. Why don't you put the contrast inside? You can do it with this, or you have already got 1 liter there. Huh? Do it with 500 ml. I don't think he will sustain even 500 ml. Just empty a little bit. Okay, we are going. आपको लगा कि आपको पेशाब. Okay, so he has a feeling. We are coming back to Mr. Ravinder Reddy. He has got first desire, and that's about 180 ml. आपको मेरे को बोलना पड़ेगा जब आपको नॉर्मली लगता है आज पेशाब कर सकूंगा उतना टाइप लगता है तो मेरे को आपको बोलना पड़ेगा. अभी जस्ट है कुछ पेशाब है ब्लड ऐसे ही लगा रहे ना. So he has got first desire. You can come back.
Yeah, we got it.
Yeah. So एक बार खांसी करिए. That's the cough.
Okay.
No, that's okay. Both, I will take care of that. Okay. Now, Bharju. आपको लग रहा है कि आपको पेशाब हो रहा है ऐसे नॉर्मल जैसे पेशाब करना है वैसा लग रहा है आपको ठीक है सो ही हैज नाउ फ्रॉम इट इज नाउ 213 ml of filling and he has normal desire can you see the graph
Yes, we can. We saw that the patient has got normal desire now. Yeah.
normal desire now so we have filled around 219 ml we are filling at the speed about 20 ml per minute
Okay.
there the other side we are ready to start the video UDS आपको अगर जोर से पेशाब लगे तो हमें बोलना
In this patient, we don't expect any.
No, I don't expect any
Yeah.
detrusor
Yeah.
overactivity. Only thing I'm going to expect here is there obstruction at the level of the bladder neck or prostate?
Exactly. So we can. So why have you selected to go slow? Why not little bit faster?
I think already 237, 238. The true reason is I was not ready with the next case.
Okay.
So
Fine.
I thought, well, we'll just pull this case a little along.
Okay.
So you can see excellent compliance. The PDAT is 3. And
Okay.
Khasi kariye zara. Okay, you can see that.
Yeah. We saw the cup rep.
Little bit of issue with the PVS, but it's okay. PVS catheter, but I think that's okay. Slightly damp, but that's okay. I think acceptable.
No, it is absolutely perfect.
Absolutely acceptable, I think.
Biphasic.
Yeah. He did will generally appear as biphasic.
But that biphasic is
आपको क्या जोर से लग रहा है पेशाब जोर से लग रहा है तो हमें बताना है हाँ तो बताएंगे हमें कोई जल्दी नहीं yeah I think I will increase the speed little more here this is excellent pump I think status has got their act together since I last used their machine
Yes.
जरा आपको जो मसल है ना जरा टाइट करिए एक बार Okay, छोड़ दीजिए. So he was just tightening the muscles, but I didn't really see the EMG activity.
Yeah,
I think
we
the
did.
EMG activity, EMG has to slightly, improve. But the other transducer seems to be working well.
I think he did an abdominal muscle contraction.
Abdominal muscle rather than the pelvic
So
muscle.
I
But
think
we'll see. We'll wait for his.
It's more of an issue in understanding rather than
ये पैखाना का रास्ता टाइट कर सकते हैं पैखाना का रास्ता टाइट करिए पैखाना का रास्ता Okay, I think again it's abdominal. That's fine. I think that's okay.
Yeah.
खांसी करो एक बार. Gentle. Okay, that's okay. Fine. So he's still at after beyond normal desire. Are you ready to go here?
Best way to make a male patient understand how to do a pelvic contraction is to ask him to give a jerk to his penis as if it is an erect penis.
Yeah, that will be difficult for me to explain here. So the next patient is ready. नीचे करिए जरा and they get the CM working. Can we see the CM images please? इसको ऊपर. ये डाल दो ना इनके ऊपर रखेंगे वो लग रहा है पेशाब करेंगे और रोक नहीं सकते ऐसे लग रहा है आपको आया ओके ही इज हैविंग स्ट्रांग डिजायर सो आई थिंक It's 326 ml now. It's not maximum capacity, but it is strong desire. So I think I'm going to mark. Zor se aa raha hai na pishap? Zor se aata. So we are now at strong desire. I have marked strong desire now.
Yes.
At 334.
Yeah.
So, yeah, that's fine. But there's very good compliance.
Absolutely no drama at all. Nice.
The other patient is paraplegic. We are a little struggling with positioning him. We are trying to get him down on the video UDS chair so we will get a good image. आपको लग रहा है पेशाब लग रहा है पेशाब कर सकेंगे बोलूंगा तो कर सकेंगे पेशाब या और वेट करेंगे जरा ठीक है he is only strong desire he has not reached his capacity
have we increased the rate now the rate is 30 now okay fine
I think 30 will continue okay 34 I'll make it now
yeah.
As you can see, the fluid, we had put a 500 ml bottle and we are almost at the fag end 100 ml left.
Yes, and the graph also showing around 380 ml.
Yeah, so I think we are all okay with that.
Yeah, I think.
Can you show the graph now, please?
We are seeing the graph.
You are seeing the graph?
Yeah.
So I think, ठीक है, पेशाब करेंगे अब? हाँ ठीक है और ठीक है और 30 सेकंड रोकेंगे Are you ready? Can you it is slightly angle here you will a slight angle you will require here जरा angle oblique करो ऐसे
in this kind of because he is non-neurogenic his count for prostate
okay no need to change bottle I think we are done ठीक है करेंगे now I am going to end filling phase. Okay?
Yes.
So I am ending the filling phase here. The pump has been stopped. I am going to give him wording command. Huh?
Wide on automatic.
हाँ पेशाब करिए अभी आप हाँ we are asking him to pass urine now.
We are not going to take out the catheter.
I think that's a good idea to take out a catheter. Give me 2 gloves, please.
No, not required probably.
No, it is not required. Anyway, is voiding.
He is voiding now. Anyway, we are getting good pressures.
Where is the queue?
पेशाब करो
Yeah.
बहुत अच्छा था पेशाब करो बढ़िया
आया नहीं आ गया
he is void but not
you can see that his speed rate went up to about 100 okay 100 so and then it is flat now
flow rate 2 ml 4 ml it is BPH.
But the EMG did not show any variation. I think my verdict will be this excellent transducer. If you are looking for a machine that can give you the basic aerodynamic function, this has done its job very well. And earlier software, I could not know how much exactly filling is done in each area each time with each event. With each event, can we know how much? Wait, let him finish. Okay, excellent. I mean, they have really done a great job since I have last used their software. Here we can even know, you can even know what we have filled at what time. Excellent, I think. Last time, the fill we could not know. Now with each event, each cough, you can actually know the fill. So I think that is quite good. As long as you are making the patient cough every minute or so, you have a rough idea of how much filling when you get the final printout.
No, I am using this machine and I am using it at my clinic as well as at one of the other hospitals. It's working fine, except for the EMG trace, which are at times not satisfactory. Otherwise, this machine is good.
Yeah, I am quite happy with it. For this case, it has given us the answers.
So, what is your interpretation, Arvind? The audience wants to know.
That is, I would think this patient is obstructed.
Audience has to tell the interpretation.
Yes, audience has to tell the interpretation.
Akers,
बहुत अच्छा हुआ.
anyone wants to interpret?
पेशाब हुआ खत्म? कितना पेशाब किया?
You know the history?
So he has voided 247 ml. So there is a bit of urine still left inside. और पेशाब नहीं हो रहा? बंद हो गया? Stop. So I think we'll check the PVR. We'll just let you know about the PVR also. Injection दिया था? Amikacin दिया? दे दो. 751 ग्राम देना. 1 ग्राम amikacin फार्मेसी से लेके देने का. फिर PVR चेक करना. ठीक है?
Just give some hypothetical value to PVR.
You know, as per this, it should be around 150 ml plus whatever has come out
as
from
per
the
this
kidney.
around 150 ml, it has to be 150 ml. We have to check, I think.
You can write some hypothetical value so that
he has worded around 246. I am giving 150 ml, but it may be more than that. We'll just let you know how much it is.
It might be more.
It will be more than that, but we are going to let you know how much it is.
Yes.
Okay, there is a little bit of obstruction because of the catheters also. Not totally representative, but anyway. But I think I am quite happy with the results of this machine.
Anyone wants to interpret? Any residents?
Okay, can we start here? So, you need to attach the transducer, sir. Can we start? Please attach. You attach, please. Okay. Tape remove कर दो, हो गया. बहुत अच्छा हुआ. लेडी को लगाने का, ये मशीन को उस रूम को शिफ्ट करके या वो करके लेडी को उस रूम में कर देने का. हाँ, प्राइवेसी भी मिलेगा. Now we are starting the next case. The next patient is ready. Air नहीं है ना?
Actually, it is recommended that whatever you have done,
very nice.
Bring it to when everything should be. Should not delete it. Looks bad. That in fact increases the reliability.
It's like a study trial. If you have 100% score, then you do something.
Yes. You should give graph for everything, every little detail that you have done, every flush that you have made, everything.
Shall we? Are you ready to start? Yeah. Huh? Yeah. You have to do the atmosphere that.
So Arvind, what are we looking for in this patient? What are the urodynamic questions?
Yeah, the urodynamic question here is how is the compliance of this patient wants to do CIC. So I want to know the compliance and the capacity of this bladder, and because he had a looks what like a UMN bladder, I want to know if there is any DSD at the same time, and I also want, so these are the two questions which I want to know, because then it will become quite an unsafe bladder if that were the case. So here we are going to again, can you see these transducers? This is the imported machine, so quite expensive.
We are not having a picture of the transducer.
Yeah, here are the transducers.
Which machine is this one?
This is Albin.
This is Albin.
Okay, now can you see?
Arvind, not yet. I think the cameraman is coming around to you now. Can you get closer and have a look at the transducers alone? Yes. Yeah, now we can have a look.
Okay, so you've got a P-ab here and a P-vest here. Okay, so I'm going to open it to the atmosphere. Okay, open it to the atmosphere, and I'm going to balance the transducers. When I say 0 all, you have to do 0 all. I know. Are you ready? Okay, can we 0, 1 minute, can we 0 all now, open to atmosphere, all of these? Yes. 0 all? Yeah, done. Okay, then I'm going to close it. Now can you show how much is the values? This also is quite acceptable, I think. Can you see? Can you see the graphs?
Yes, we can see the graph. It is coming as broken line. The graph is coming as
No, it is a straight line. It's a very thin line. Khasi kariye ek baar. Dagande?
No. So normally this comes as a full line. It's coming as a broken line for some reason.
Yeah, Arvind, we are seeing it here in the auditorium as a broken line.
Which one?
All the three lines, the P-West, P-abdomen, the P-det line.
No, I think it's coming properly here, no problem. It's, I
Oh,
think, a
then
problem
there
with the transmission.
Something wrong with the
I'm
transmission.
not able to see the transmission here, but can you close up on this?
Already.
You can see how high the P-det has gone.
Yes.
Can see, this is the baseline. And, okay, can we fill,
Now we can see.
Yes, now we can see it continuous lines.
Yeah. So you can see, I mean, I haven't even started the filling. Have you started filling? No. And you can just see how high the P-det has gone. This is a neurogenic detrusor overactivity. I think this is very unsafe bladder here. So so should we start the filling?
How
So
can
this
you
is a
start
cough.
filling
This
in a
was a cough.
contraction?
Now it has come down. The DO has come down now. I think we can start the filling. Can we start the filling? Slow fill, please. 10. Siam on. आपको पहनना पड़ेगा एक बार वो. Can someone wear, please? I don't wear normally, but that's okay. आप पहन लीजिए. Yeah, please start. Please start, and you can wear this. Start. Okay. 10. Started at 10?
Yeah, started, sir.
Oh, we have started at 10. Can you screen?
Arvind, we are not getting the Siam image.
Yeah, I will give you the Siam image. Screen, please. Go down to the bladder, please. Once we, पूरा दिखाओ ना, bladder दिखाओ. आर्टरी फॉरसेप्स देना मेरे को एक. आर्टरी फॉरसेप्स देंगे. छोड़ दो, ये दे दो. Okay. Screen, please. Screen. Okay, it's fine. This is up, this is down. Okay. Go down more. Screen. Okay, now towards that side. Screen. A little more.
Yeah.
Screen. Okay, can you see that?
So we can actually reverse the PIP.
Can we reverse the PIP, please?
Yeah, we got it.
And bring it to yes.
Slightly to the, this is.
Yes, that is fine.
Catheter, come up a little bit. Come up. I want to see the bladder. Screen. Yeah, you can see the bladder now.
Yes,
up.
we can see.
Okay.
The bladder can be shown upright.
The Siam picture, can it be reversed? Yes. Okay, that's better. Yeah.
No, back to the earlier PIP.
Can you go to the PIP? Yes, thank you.
So the pressure seems to be okay, amazingly, no?
The lines are still they had improved, but now the lines that are being transferred are still broken.
No, the lines are quite okay actually. Here the lines are okay.
Okay.
Actually,
Okay, so
can we put
after the first contraction now is it silent?
Yeah, khasi kariye, khasi. जोर से खांसी करो. Okay, that's it. I think reasonable. I think not a. What
Not very happy.
Not very happy with the cough, right?
Yeah, the cough is not getting reflected.
जोर से खांसी करो, पूरा जोर से.
I think not with the.
खांसी करो, गगन.
So if you see the EMG is reflecting very well in this.
Yes. EMG.
Whenever he is coughing, the EMG is going up. I mean, the EMG is showing that.
The EMG traces are very responsive in this.
But the cough one could have been better. Again, if you look at this, there is a very little, what we are saying is there is a very small distance between 0 and 100. And secondly, I am also not, because maybe he is lying down, he is not able to produce the abdominal pressure, I don't know.
No, can we see the complete graph? Whatever has happened till now.
Can you show the complete graph?
Only after it finishes.
No, they can't do it. I know they could do it in status, but they could not do it. They can't do it here. I think they don't do it in laboratory also. I think once it starts running, it has to finish before it gets compressed and shows as one paper.
Oh.
जोर से खांसी करिए. एक मिनट.
नहीं क्योंकि
जोर से खांसी करिए. दगंडे. Is this better? I even pressed his abdomen at that time.
Yes.
So, basically 20, 30. I think the P-ab is not, P-ab may be an issue a little bit.
Yes,
So now
P-ab has come to close to zero.
So now following the cuff, he has his detrusor overactivity.
Yeah. Yes. You can see the detrusor overactivity following the cough.
And along with that detrusor overactivity, there is an equivalent response of the pelvic floor. He is contracting to avoid a leak.
Yes.
But he is leaking.
Yes, but I'm saying the EMG is showing that when the detrusor overactivity came, he tried to contract to avoid the leak.
Yes. And you can show this here, please. Can you show this here?
I don't think he is voluntarily trying to do that.
Otherwise, this cannot go up.
Reflexly, that is happening.
He is paraplegic, may not be happening voluntarily. That's also a good point. Okay, go back to.
No, then if this is reflex voiding, this indicates DESD.
So, are we looking at a leak? Yeah, there is some amount of leak.
A little bit of leak was there. Leak was there. Not all there, but a little bit of leak was definitely there.
Yes. So that is the advantage of the newer machines with the leak detection. Although that is not showing on the graphs here, but the newer, as Dr. Sanjay Sinha was saying in the morning.
What is this artifact that is coming here right now?
That's on the flow line.
Somebody hit the flow meter.
Yeah.
Somebody hit the flow meter. That was the artifact. So they can see that also.
Yes. Excellent teaching demonstration.
खांसी करिए, लंबा खांसी, खांसी करो. Okay, cough here.
How good is EMG?
Little faster fill. Yeah. I'm increasing the fill from 10 to 20.
Okay.
We will be sitting here all day if we're going to do at 10.
He may not hold a lot of this thing also. So.
So here he is explaining the EMG to me. Can you see this? Can you put this image on this one? Okay, can you see this? Can you just focus on this?
We are only seeing the graph on the patient.
There are three things you can check. You can manipulate the gain of the EMG. You can do audio EMG. You can have a volume there, and there is this threshold. Threshold is at 0, of course. The volume is at 10, and the gain is at into 32. So we are seeing nice image.
Audio. What is audio EMG?
I think that produces a sound. I think. Can you show us audio EMG, sir? Okay. This is audio EMG. You can hear the sound. खांसी करिए. So it's like a Doppler, not a duplex scan, like a Doppler.
But you are using surface electrodes only.
Yeah, surface electrodes. It's like a Doppler, it produces sound. Now you can mute it. Can you hear that sound?
Yes, we can.
Yeah, mute. So when you have that spike, a little bit sound will come. But what we got is intermittent detrusor overactivity. How much have we filled? Screen, please. Show the screen. Screen kariye.
About 100 ml has been filled. 110 ml. Yeah.
Here you can see that it's not a first ship bladder. This again we had to tape this catheter because when I initially put the catheter, as I looked away, the catheter came out. So I realized very well that this is not going to work like this. You have to tape the catheter. report.
Now it's again coming, another detrusor overactivity.
Yeah, you can see another detrusor overactivity.
This time it's spontaneous, and if you see the sphincter EMGs again,
yes.
So if we consider this to be reflex voiding, then this is DESD.
DESD.
No, लिख देंगे report. लेके आ जाओ फाइल पहला पेशेंट. Report लिख देंगे पहला पेशेंट. What is it? Infusion value. Okay. So Albin is explaining something to me that they measure the infusion through ways. There is a peristaltic pump here. Can you see that pump?
No, we are not. We are just looking.
On this.
Can you go from the CM image to what Dr.
This
Arabind
is not required actually. This can come here.
Yeah. We have the patient image and the graph.
Yeah, the graph can continue. Patient image is not required.
Yeah, we can see
what
you
can see. This is a peristaltic pump here, and this is a load cell. So basically, he's saying that.
Can you please?
This one is a load cell. This
can
one.
You please get closer?
This one. Can you see this?
Can you show the peristaltic pump again?
This is the peristaltic pump.
Okay.
Okay. This is the load cell. Can you see this load cell?
No, here? Not yet. Not yet. He needs to show what you are showing. Yes. Yeah. Okay. Now, Arabind, you can explain. Yeah. What is that?
So this is a load cell. Basically, this also calculates the weight.
Okay.
So as the weight reduces, they'll know the infusion value.
So basically, the how much is being infused is coming from this load cell.
Yes. So they do both load cell and calculation, and then they do some sort of I think middle path. They take a middle path. So they do an averaging, I think. So anyway, you can see he had 2 episodes of detrusor overactivity, and you can go back to this. Yeah, patient image.
So what more do we want to see here?
I think nothing more. Can we have another screening, please?
Yes, we want to see whether the bladder has increased in size or not.
Screen.
CM screen, please.
I think I have to screen there. I think I got nobody here. Let me go and screen.
So it seems that the bladder has come to stay at some level of fullness, and whatever extra is coming, and it is discharging by means of overactivity or reflex.
I'm just going to increase the speed of filling now. We'll see if we can, because I was filling a slow fill only. I'm going to increase the speed now from 20 to 30. Let us see what difference is happening. Yeah.
Arabind, is it leaking now? Or
now there is no leak, not at the moment, but he leaks.
Yeah, whenever he has a EO, he leaks.
So this is detecting a leak?
No, this doesn't have a leak detector, I guess.
Okay, now we are filling at rapid rate. Give a little more. पेशाब लग रहा है आपको? लग रहा है कि पेशाब है? नहीं लग रहा है. He has no sensations at all. He has not reported a single sensation to me till now.
DO started coming again.
Yeah, another DO.
Okay, so खांसी करिए. Oh, now you can see. No. Now you can see the detrusor overactivity again. And now you can see the leak. Can you see the leak?
Yes, we saw the leak.
Yeah, you can see, mark the leak, please.
Yes.
So
if you look at the graph, the DLPP is around 40 in him.
Yes.
No, you cannot say that is DLPP. Every time he is leaking, it is during a contraction. So that is not DLPP.
Sorry,
DOLPP.
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 So you can see this is a
overactivity leak.
This is a sustained DO. And I think this bladder is very unsafe. I don't think he is a fit candidate for any CIC.
No,
so now, Arvind, you can stop the filling to see if the baseline pressure comes down.
Yeah, I'm stopping the filling now. Stop filling, please.
Because this now looks to be transforming into poor compliance, unless it was the increased pressure.
We are now stopping the filling now.
Yes, so if it comes down, then it's not poor compliance, which it is, which it looks to.
It's come down. I have stopped the filling and it seems to have come down. The compliance is back where it was. It has come down. You can see the compliance has come down. I stopped the filling.
Yeah.
So actually he is DESD, but the bladder has not yet been challenged, and because he has remained on catheter throughout. So it is only detrusor overactivity that is manifesting now.
Detrusor overactivity with whenever there is reflex voiding, he has DESD.
DESD. But if you remove his catheter and allow him filling, then
so I am going to do.
Probably we will also see in sometimes some deterioration in compliance.
I am going to increase his. I am going to increase his filling again. When he is going to have this, we are going to screen and see. Is it okay?
Yes.
So that's what I am going to do. So start the filling again. Increase the filling to 50. And when he leaks, you have to press that continuous screen. Okay? When he leaks, continuous screen. Just keep looking at this. And this screen, when he leaks, make it continuous screen. So we have a look at the bladder neck.
Or we can screen when he has another.
When he has another DO.
Yeah, when he has a DO.
खांसी करिए. Okay, I am trying to precipitate another DO. It's not happening. Even though we are filling at, he's having the DO. Screen now. Continuous screening.
And we see
continuous screening. You can see that.
image. CM image, please. Yes.
CM image.
Yeah, we are seeing.
Screen, continuous. Can you see that TSD?
Yes, we can see that.
Yes.
Can you see that TSD? I think you want to get a better image than this.
Yes.
Yes. Stop.
Is the audience able to appreciate?
Can you see this? Then you see this prosthetic urethra?
Yes, we can see
clearly
that.
delineated.
Yeah.
Okay.
It's a nice
So
app.
he has a DSD here. These photos do you want? You saw them? So I think we have got our answers here. Shall I terminate?
Yes, I think we have got the objectives. Anything else?
Anything else you want to see? Dr. Sanjay, sir.
That's what it is.
Sanjay sir wants to comment anything, say anything. Dr. Vipin?
No, it's a nice demonstration, Arvind.
So I think sir will terminate. We have got our answers. You want me to continue for anything?
No, we can stop this.
Yes, we can stop.
Very well done.
Again, screen again. And actually he is having a lot of, what you can see is
there is no reflux also.
There is no reflux, but there is a lot of rigidity here when he is having that sort of this thing. So it's a high one. I don't know. I haven't checked his blood pressure. I should have. Can we check his blood pressure, please? Do you have a monitor to check his blood pressure? Monitor laga dene ka. See, I think one of the things that we can do when we are doing these patients is to continuously monitor with a BP monitor to see if he has any autonomic dysreflexia. Okay, I think that is done.
Can you show the final
graph? Can you stop?
Yes, final graph.
Catheter dalna hai.
Because DSD appreciation will be very clear for everybody once that comes.
Boss हो गया? हाँ? EMG connect कर दो.
Arvind is asking for a residual volume. Maybe you can put a hypothetical volume and then you can have the.
I think there is a very low residual volume. Can we screen once more? Last time. The bladder has become completely small now. I mean, it won't be more than 40-50 ml.
And then you just write that 50 ml and.
Yeah, 50 ml.
We can have a look at the last.
Not even that, and that too because it's lying down.
Okay.
And I don't know about the thickness of the bladder issue. I don't know that there are two this thing there.
Just enter 50 ml and put OK so that
50
we
ml
can.
and put OK, yeah.
So that you can see the graph.
So, वो लगाइए जरा BP कफ लगाइए.
So we'll just check the blood pressure. That is something that we need to know in all these neurogenic patients. We need to check. There are two things I want to show you. Can we have that meter scale? So these are two things, two things which we should show. Can you see me here? Can you see me?
Yes, we can see you now.
So this is a leveler. Okay, this is a fluid level and this is a meter scale. So when we are using it in a chair, for example, if this is the chair, we measure the level of symphysis pubis, the upper border of symphysis pubis, and then we'll level it like this to make sure that the transducer is level.
Okay.
Okay, this is not expensive. I bought both of these on Amazon long time back. There's one more thing I want to show. You have that small baby sitting.
You got this from Amazon?
Both are from Amazon. This is not very expensive. Yeah, here it is. And we have this when we want to do a pediatric. The children tend to fall inside that big one.
Okay.
You can see the BP is okay, pressures are okay in this patient. So you can see 120/80. Can you see that?
Yes.
Yes. I use this for pediatric aerodynamics, so my kids don't fall inside the pan.
Yes. Great.
So this is not expensive. Again, I bought this on Amazon.
Great.
We'd like to see the complete graph, the final.
Yeah. He is going to show you the complete graph.
Yes.
We have one more patient which will be starting anyway. I won't be staying here, but this is again a very interesting patient. Where's my phone? Phone किधर है? मेरा phone किधर है? Call करो एक बार.
So in fact,
phone किधर?
Baseline is same.
So this is the third. This last patient is the, I'll just tell.
Okay.
She is Miss NM. Age is 23 years. She has had a lipomyelocele at 6 months age, and she had operated. She has a surgery at that time, and now she has a little bit of difficulty in walking, lower backache, urgency with urge leak, and stress leak. Ultrasound, both kidneys are normal, creatinine is normal, CUE is normal, microscopic is normal, pus cells are nil. MRI showed a spina bifida L4 S1. Lipomyelocele L3 to S1 extension, and there is a low-lying spinal column with conus medullaris. So that is our third patient. They started here, and we'll see how best we can do with it. Okay, can you see the graph?
Yeah, we are seeing the graph. We can see a cuff-induced overactivity. We can see a spontaneous overactivity. And we can also see sustained overactivity.
Okay, I think that's it. They will start the next patient. They let me know.
And again, each time there is a DO, you can see that the sphincter activity, the response increases. So the sphincter is contracting. So that is probably the diagnosis of DEST in this patient.
Yes, that is. I was just wondering whether can we really give him, make him do CIC?
With anticholinergics?
We should try first with anticholinergics and give good, start in the beginning itself. We should start with higher doses.
Yeah, higher doses.
And maybe after 4 weeks we should repeat this. See if there is some stability, we should put him on CIC.
Yeah.
And then if required, maybe augmentation and CIC.
Yes, augmentation CIC is an option. Sir, any other options, sir? In this patient,
sir,
what do you want to do? Management?
I actually didn't see the. Let's see the full trace once.
Yes, yes, sir.
Yeah.
That's it.
Okay, so this patient has neurogenic diffuse overactivity with DSD, NDO with DSD, and what's the capacity?
Sir, after every around 100 ml, it is leaking.
Yeah. So this patient has been on indwelling, is it? Was the patient on an indwelling?
Has been on indwelling for last 11 years.
It's not bad actually. The patient has been on indwelling. It doesn't look like a tracing of somebody for last 11 years on catheter. So I'm not very sure whether that history is right, because you would ordinarily expect a much poorer compliance. The compliance looks good here. For whatever, you can only measure it for over 100 ml or so. After that, you get a phasic contraction. This patient requires antimuscarinics and CIC, and this patient should do well. Yeah. I don't see any role here of discussing augmentation at all. So the odds are, I'd say 80-90% medication, antimuscarinics escalating with a CIC diary record, aggressive constipation care, and
so you want to start him on antimuscarinics and review him after another month with another UDS, or you can, no?
We start antimuscarinics in CIC, we review with the CIC diary.
Okay.
So all the initial dose adjustment is based on the diary record.
Okay.
And once either that's the policy we would follow and what we published also actually in IGU. Once we reach the ceiling dose of antimuscarinic or the CIC diary looks good. So either the diary looks fine based on whatever we've done, that means the patient is, this kind of patient needs to be in a full CIC 5 times a day. So let's say that this patient is doing CIC 5 times a day, the CIC diary shows 24-hour urine volumes are right, there's no incontinence episodes in between, there's no urgency sensations repeatedly in between, no repeated febrile UTIs which just suggests that there's a problem. Once you reach that point, then I would do a repeat study. Or if you have reached the ceiling dose of antimuscarinics, I have no further to go, and the patient's symptoms are not yet taken care of, I would still do a CIC at that point.
So is this an indication in this patient if he stops leaking? Because he has no leaks because of the detrusor overactivity. Right. You start antimuscarinic and the leaks stop. So does that also indicate that it's working?
So it tells us that it doesn't tell us that the patient has become safe, but it does tell us that benefit has happened. So I mean, you need to have some, you can't keep doing UDS each time. So we would do non-invasive assessment, and you don't need to. So you do non-invasive assessment. Once you reach the ceiling dose or it looks fine, then you do the study now with a clear decision as to, so let's say I've given 5 milligrams of solifenacin, and this patient has no leaks.
1 minute, sir. Will you like to remove the catheter and start on anticholinergics, or will you like to start anticholinergics first and after some time
Practically speaking, let's say there will be very few patients who will come from next door to us, right? So I would start this straight away, train this patient in CIC, put the antimuscarinics, tell them you may leak for 3 days, doesn't matter, and start off, right? So I will also give initially for the first 10-15 days of prophylaxis. I don't know whether you do it. First 10-15 days I'd put them on prophylactic antibiotic. After that I'd stop. No antibiotics long term. So they would start, come back after let's say a month or so. The first visit is actually at 10-15 days. That's a technical visit to see whether they have difficulties with the catheterization process and so on. And at 1 month or so I'd see their CIC diary. And once let's say at 5 milligrams everything looks fine. Now the purpose of the next study is to see it looks fine, is it actually fine? Or if they've reached a ceiling dose, to take a decision what to do next.
So I'll just add one thing here.
Yeah, boss.
So when, so in this patient is otherwise safe, looks safe, upper tracts are normal. The problem is incontinence.
Yeah.
So if the antimuscarinic solves that problem, I am anyways not expecting an upper tract issue. I don't do urodynamics like sir said. But let's say he had poor compliance with upper tract issues with incontinence. So there is data that if the incontinence improves, that does not say that the safety has improved.
Yes.
So in those cases, if I am not sure of the safety, then after you give Botox, then you must repeat, because the symptom may have improved, but the patient still may be unsafe.
May still be unsafe.
No, in fact, his being on catheter would mask the compliance issue now.
When they reach the ceiling. Okay.
Guys, any questions?
So abdominal trace is gone, is not seen here on.
I think rectal catheter has come out.
Yes.
Yeah.
But if it comes out, it generally.
It should fall.
Next start is Arvind. Dr. Arvind.
Are we doing the live or are we going to the next?
Dr. Arvind. Yeah. So we have this.
Please proceed to the next session. We will be doing the third UDS and we will be putting picture in between.
Okay.
Please proceed to next session.
Yeah, Dr. Arvind.
Hello?
Yeah, I'm Dr. Gopichand, Dr. Arvind.
Yeah, tell me, sir.
So, should I start this?
Yes.
Interactive case discussions.
Yeah, please start that with Dr. Pawan. Please start.
Once you come back, we will do that UDS reports.
Sure. Please start the interactive case discussion.
Yeah. So, we'll have this interactive case discussions. I request Dr. Pawan Vasudev to please come onto the stage. How can urodynamic help us in decision making and counseling? Would you please invite your panelists, Dr. Pawan, Dr. Sanjay Sinha, Dr. Arun Chawla, and Dr. Prashant. Sir? Dr. Bipin, please join them as panelists.
Okay, so clinical scenarios.
आप जा रहे हैं ना?
Yeah. Okay, so we're already running late, and I will try to. So we have we'll discuss a couple of cases of female stress incontinence, go on to overactive bladder, then discuss female voiding dysfunction, go on to one index case of non-neurogenic male LUTs, and then go on to the neurogenic case discussions. So we start with the first case. So a 40-year-old lady who comes with stress urinary incontinence for a few years. She has moderate to severe bother, and otherwise everything is all right. There is no other lower tract symptoms, no hematuria, no dysuria, no constipation, no other relevant surgical or medical history. BMI is normal. She's had 2 full-term normal vaginal deliveries, and on the exam, the ICS uniform cuff stress test is positive. The urethra is hypermobile. There is no prolapse. She has tried conservative measures and has not benefited much. So, sir, what would you want to do next? 40-year-old, history-wise, pure stress incontinence with a positive cuff stress test.
Do we have a residual urine check on her?
Yes. So at this stage, she comes to you. She's been taught some conservative measures which have not worked. Now, how would you want to evaluate her further?
What is the voiding diary?
So you would want a voiding diary, and
what about the investigations?
So exactly. So what all would you want at this stage?
So initially, we want a urine test.
Okay.
One uroflelometry.
Okay.
And already PVR. So 3.
And the diary,
things.
right?
Yes.
So so the voiding diary was essentially normal. The complete urine exam is normal. PVRU is negligible, and Uroflow is normal. So, Dr. Nikhil, what do you think is the role of, I mean, she's essentially come in for a procedure because conservative measures have failed. What do you think is the role of invasive urodynamics in a 40-year-old woman who's apparently looking uncomplicated?
Oh, I'll just intervene.
Anji.
Do you have any radiological study also?
No.
So
PVR is ultrasound, but not if you, I mean, no MC, I mean, there is no other radiological study. PVR is done by ultrasound, which is normal. MCU has not been done.
So this, looking at the clinical picture,
yes,
this falls under the category of an index case of SUI.
Yes.
And the debate and controversy is whether to go for a urodynamics or not.
Okay.
But still, since now conservative measures have failed and we are going to plan a sling or surgical management on her, so I would like to have a urodynamics on her.
Okay. So the guidelines which were published in 2019, of which sir was the chair, so you do not need to perform invasive urodynamics prior to initiating non-invasive treatment. So as long as whatever you're doing was non-invasive, you did not need urodynamics. But now that you're thinking of doing urodynamics, the statement actually says that invasive urodynamics may be omitted before surgery in women with uncomplicated stress incontinence, and all other women should undergo stress incontinence surgery. So which brings us to this question that what is actually this uncomplicated patient that need not get a urodynamic done. Sir.
So there's a long statement in our guideline document,
which I'll just go through
which I'm sure you'll be showing.
Yes.
So essentially, this falls under the category unequivocal symptoms, a clinical stress test which demonstrates that there is that there's stress incontinence, no major degree of prolapse beyond the introitus, no background history of pelvic surgeries, radiation therapy, and things like that. The age group under 70 years. So she falls under all the, I mean, no history of voiding difficulty and investigations showing low residuals and a normal flow. So we had this requirement of checking the residual and the flow for labeling them as uncomplicated prior to surgery.
Yes. So sir has covered most things. I'll just run through it again. For somebody to be labeled as uncomplicated, all these things need to be fulfilled. Age needs to be less than 65. She needs to be a pure SUI case with no urgency, no voiding symptoms, no pelvic surgery, no radiation. On exam, you should have demonstrated a cuff stress test to be positive. The urethra should be hypermobile. There should be no POP beyond the introitus. You should have done a UFR and a PVRU, which should have been normal. All of this, if it is there, then it is an uncomplicated case, and then you may omit urodynamics before putting in a sling.
I will like to emphasize that only lack of voiding symptoms is not enough. Low PVR and uroflelometry, normal uroflelometry are essential.
Absolutely. Without non-invasive urodynamics, you cannot operate, and without non-invasive urodynamics, you cannot go to invasive urodynamics, both things. But what I will like to just bring to your attention is, see, the impression that we are getting because of that the value trial was that uncomplicated patient does not need urodynamics, and uncomplicated patient, for us, we hear it as an index patient or the normal patient or the majority patient who walks into our clinic. That is the impression that one gets when you talk about the index case not needing urodynamics. The fact is, the index patient is actually not the usual patient. If you look at the same trial which said that you do not need to do invasive urodynamics, in them 66% were actually not index. The other trial which said you do not need to do urodynamics, again 64% patients in them were not index patients. So if you were to follow this guideline also, that index patient does not need SUI, does not need invasive urodynamics, at best you would end up omitting invasive UDS in 1 out of 3. So 2 out of 3 patients still would require, your patients will still require, because index patient is not the usual patient. That is, you would agree? So that is what the data at least says. Now, coming to this 1 in 3 patient, sir, do you do urodynamics in these patients as well? I mean, is there, the question is there risk that even in this, so in 2 and 3 you are going to do, because they will turn out to be uncomplicated. My question is, in the 1 in 3, which is fulfilling all your criteria and is following in the uncomplicated category, do you think you still may lose out in information if you do not do invasive urodynamics, or what is your practice? Would you do it in all patients before putting in a sling? Dr. Nikhil.
Yes, I will like to go ahead with it.
And why? What do you think you can, I mean, what is your take on, it's uncomplicated, so what are you expecting, or what do you think? I mean, what is the information which is missing for you?
No, nothing is missing. One can go ahead also. But if at all some problem happens later on, then I will have a baseline. That is my main intent.
Sir.
So that is, I think that should be okay even now.
So if you choose, if you believe that you're going to choose a different procedure based on the patient's presentation, then you would be doing a urodynamics. And so I would do it for the resident. Exam question, you'll say you don't need to do urodynamics. There's no confusion on this. Because if you tell your examiners in an uncomplicated patient you want to do urodynamics, you're going to get into trouble. All you can tell is that you have to be diligent in making sure that the patient fulfills each of the criteria. But as long as the patient fulfills each of the criteria, no urodynamics before surgery. Practically speaking, I would tailor my procedures, not just which procedure to choose, but also perhaps how to do the procedure based on the findings. So I would always do it for all my patients.
In your practice, you do it for everybody?
That is what I find that almost all academic centers globally do despite the recommendation.
Dr. You would
How you change the procedures?
I'm just coming to how urodynamic can impact. Would you do it in all patients?
Yes.
You would do it on all patients?
It's better to proceed. One for the counseling of the patient, and second also means you can find sometimes, hidden things which can be picked up.
Okay, so I will just share data from these same trials which said that you do not need to do, so earlier we were doing it in all patients before, there was no uncomplicated, complicated. After this trial this came up, but within their data of uncomplicated patients, this is what is there. So in their data of uncomplicated patients, they found unsuspected ISD in 10%, in more than 10%, 13% in the value trial. So in that 1 in 3 patient, in that one also 10% will have ISD. And ISD has an implication, and we shall see that in a subsequent slide. In their uncomplicated patient, they found unsuspected voiding dysfunction in another 10%. And in fact, they evaluated their results and found a success rate which was lower in the population which had voiding dysfunction. And again, in their own population of index patient, they found detrusor overactivity in 10 to 20% of patients. So 10% patients 10% of uncomplicated patients in value trial had ISD, 10% had voiding dysfunction, and 10 to 20% had detrusor overactivity. 66% were anyways out of so this thought that SUI surgery urodynamics is not important is actually we would also do it for all patients.
Yeah, in fact, the trial was never designed to pick up voiding dysfunction, so it's underpowered for that.
Yes.
The other is that if you look at all this trial was from the UITN group, and it's a very big trial because if you look at the Cochrane review, it's published in British Journal. If you look at the meta-analysis, this trial gave the biggest weightage, a huge weightage. This is the only UITN trial, Pawan, out of a large number of trials where the success primary outcome is a subjective outcome. All the other UITN trials have multiple objective and subjective outcomes for defining what's their success.
Yes.
This was the only trial where it was not so.
Yes.
It was almost as if they designed the trial to get this outcome.
Exactly. So there have been studies, there is literature published after that which has pointed out to conceptual flaws in how this trial was carried out. So so what is the consensus that would you actually recommend even in the uncomplicated patient? I think the consensus is you may miss things and you may want to consider a UDS even in the uncomplicated patient. Am I correct to draw that? I'm not talking from a exam answer, but I'm saying within this panel, the consensus is that they would do urodynamics in all patients.
Even for exams, sir, it is written in Indian guidelines that...
No, our guidelines say that uncomplicated patient you need not.
No, our guidelines are very clear. Uncomplicated patient, no need for urodynamics.
Yes.
That's what they must answer the exam.
So what we are trying to get across is, in 2 lines is, one, the uncomplicated patient is not the norm. The majority are actually complicated, and within uncomplicated also, you will have 20 to 30% of patients which will have one of these 3 problems, which may impact the results of your surgery, which we will just see. Should we move to the next? Yes. So this patient, the ALPP was 120, and she falls into the non-ISD group, and so the guidelines state that any of the 3 procedures are standard surgical options for uncomplicated stress incontinence. Now, the same case, the stem doesn't change. She's a 40-year-old lady, again, stress incontinence, pure stress incontinence, no other problems, cuff stress test positive, urethra hypermobile, no prolapse, conservative measures tried, no benefit. This is, again, complete urological sorry, urine exam normal, PVR normal, UFR normal, but this is her urodynamics. And the ALPP is now 53. So, Dr. Pal, does your procedure change with this urodynamic report, or it doesn't matter? So the first line is P vesicle, the second is P abdomen, and the third is P det. She has, I don't know if it's coming here. Yeah, so at a 53 ALPP, she has leaked urine. So in this scenario, does your choice of procedure change, or this urodynamics does not impact your choice?
No, my...
I mean, I'm asking in two, so there are two questions. Does the counseling change, and does the plan change?
For me, it will not change. It will remain the
Okay. Both counseling and plan doesn't change. Dr. Nikhil, does the counseling or plan change?
Yes, if there is a component of ISD, I will avoid any transobturator tapes. I will go for a retropubic.
Retropubic tape. Any difference in counseling?
With retropubic tapes, more chances of avoiding dysfunction.
Sir?
So first is, does this match up with her history? I mean, does she complain of a more severe form of incontinence, something I would look back at? But in any case, if somebody has ISD, then number one, you need to counsel that regardless of what procedure is chosen, her odds of getting recurrent incontinence is higher than the average patient. That's the first thing. The second is, she's a 40-year-old lady. She has got ISD. I would be much more inclined to offer this patient an autologous sling. So in fact, even if she didn't have ISD, I might be more inclined to offer an autologous sling at that young age. Because she's really young if you're going to be doing a stress incontinence surgery, assuming she's completed her family, of course.
And does the nature, retropubic versus transobturator, does it change for you?
Yes, so if it were a choice, let's say if she chose a mid-urethral sling, then I would be more inclined to offer a retropubic sling to her. Or if I'm doing a transobturator tape, I tend to keep it more snug. It's a soft science.
So when you said autologous, you meant a pubovaginal sling. You meant a pubovaginal sling.
Yes.
So I will just summarize what Sir said and what the literature is also saying. Regardless of what procedure you choose, if the patient has ISD, the cure rates are lower at 1 year. So that is how your counseling will change. And this was mentioned in the guidelines as well, that women with ISD will have inferior outcomes. And regarding the change in plan, if you have ISD, then TOTs tend to do worse than retropubic tapes. So this was this trial which found that 1.4% of TVT patients versus 20% of TOT patients required repeat surgery. So the risk of repeat surgery was 15 times higher, and the median time to surgery was 3 times shorter. So 15 months versus 43 months. There was then this another trial which looked at 157 women and again found that TVT is superior in this case. And then another meta-analysis which said that the cure rates are higher in the TVT group. So in somebody who has a low ALPP, you would agree that a pubovaginal or a TVT may be a better choice than a TOT?
I think the data seems to suggest that. So you don't have very good quality. There's only that one single randomized trial by Steerlitz. There's no other. It's surprising that it's an important issue. Just one randomized trial is there with us. And that data which they have shown, I'm not sure whether our anecdotal experience matches up to that.
So what we are
I
now
don't think the difference is that dramatic.
Okay, so what now next 2-3 cases what we're discussing is a little softer science, because if it was there, if there was conclusive evidence, then obviously it would be there in the guidelines that do not do this and do this. But it's still not, but in your practice you would prefer one of these two over a TOT in ISD patients?
Yes.
Okay. Dr. Nikhil?
Yes.
Okay. So, the stem remains the same, that again 40-year-old lady, uncomplicated stress incontinence. Here what happens is that her PVRU is 100 and her Uroflelometry is, the maximum flow rate is 13, average flow rate is 9. So does this change, so now would you want to do a urodynamics in this patient?
Yes.
This becomes a complicated patient, right? So this is the urodynamics of this patient.
So she's got an acontractile detrusor.
So with an acontractile detrusor, does the plan change and does the counseling change?
Yes.
How would the counseling change and how would the plan change?
See, with an acontractile detrusor, any incontinence procedure will increase the risk of voiding dysfunction, increase the risk of retention and need for CIC.
Okay. And plan, would you change your plan based on somebody having voiding dysfunction or no?
No, so incontinence surgery goes out.
No, she has stress incontinence. I mean, if we were to look at what tape we could use, is there a preference if somebody has some kind of voiding dysfunction? Are you more inclined to use something over the other, or the plan doesn't change for you?
See, if already some voiding dysfunction is there, then a transobturator tape should be better, should be
better.
considered.
Sir, would you?
So I would be inclined to think that this woman should have some voiding symptoms. So if she has any voiding symptoms at all, and if she's truly acontractile on repeated pictures, it's representative, I would actually discuss with her to initiate CIC first to see what happens.
Okay.
I have seen patients like this, you initiate CIC and they say the incontinence is 90% reduced and I don't want a surgery. So I would first initiate CIC, see for a few weeks what happens, because it's quite possible she may anyway require it.
Okay.
It also makes the patient aware of what might need to be done, and then plan my procedure. And then if I've got to do the procedure, I may again discuss with her, is it better to do an autologous? You're going to be instrumenting the urethra all the time. Would you prefer that? Or would you that's one choice. So there'll be a little bit of discussion involved here. But if at all we are doing a mid-urethral sling, then a transobturator tape has a lower odds of new onset voiding difficulty as compared to a retropubic.
Okay, you would agree, sir?
But autologous will also increase the risk of voiding dysfunction.
Sir was saying autologous from the age point of view, but
these group of patients for me are dangerous patients.
Sorry?
They are dangerous patients. So I will not like to touch this patient surgically.
Okay, so I'll just send the message. I mean, so the data is that if the patient has been using any accommodating maneuvers, which could be straining, bending forwards, or Valsalva or something, then there is a twofold increase in the risk of incomplete emptying post-procedure, so you need to warn them accordingly. So voiding dysfunction can get aggravated. And the other thing is regarding change in plan, if you were to do one of the two procedures, and I agree with sir that we could start CIC and C first, but if you were to do one of the two procedures, then there is data that the voiding difficulties are lesser with a transobturator tape when you compare it with a retropubic tape. And this is also mentioned in the USI guidelines that a retropubic tape may be more likely than a TOT to aggravate pre-existing voiding dysfunction. Okay, so let's see why. Yes. No. Yes. So this is so the next case, this is a 55-year-old lady.
What if in the same lady?
Yes.
We get ISD like picture. Can that also happen?
That we get both
ALPP less than.
It can happen. So then it's then you don't want this patient in your OPD. Basically, an ISD patient.
Then start self-cath and an autologous.
Basically,
if somebody is on self-cath, then you can.
You always go. So in those situations, 100% always initiate CIC first.
Yes.
Basically, there is some data to lean towards a retropubic for ISD, and some data to lean towards TOT for voiding dysfunction. And that is where urodynamics can help you if you do it in the uncomplicated patient. Now coming to the next case, this is a 55-year-old lady
with history of mixed urinary incontinence for a few years. Moderate to severe bother. The urge component is a little more bothersome than the stress component. Now, the ICS cuff stress test is negative because the leak started with and persisted beyond the cuff. So she did leak with the cuff, but that persisted beyond the cuff. The urethra is hypermobile, and she's tried conservative measures. There's been slight improvement, though she is still not satisfied. Diary, the frequency is 8. The maximum voided volume is 200 cc. She's had one episode of urge incontinence. The urine exam is normal, PVRU is nil, and UFR is normal. And this is her. You would agree that she would need urodynamics?
I would first initiate maximum conservative management for urgency.
Okay.
And I would titrate to the full dose, whatever she needs. So,
Okay.
so if the urgency is either taken care of and incontinence still remains bothersome,
Okay.
or the urgency is not completely taken care of, I would
Okay.
now do the urodynamics on medication.
Now, if the situation flipped and her stress incontinence was more bothersome than urge incontinence, you
I would still do the same.
do the
I
same.
would still do the same.
Okay.
So I would titrate to tackle the urgency,
Okay.
and I would do the test on the medication.
Sir, but so just for my knowledge, we also understand that if you operate for stress incontinence, the urge settles in some, in a large proportion.
Yes.
So,
especially if the patient has ISD.
Yes.
actually.
So, but your default setting usually is that you would tackle the urge first and then see if you need to tackle the stress.
Yeah.
Okay. You would agree? Nikhil? You would agree?
I will agree. That is
Okay.
more
So that's the next slide. But anyways, we did urodynamics before that, and this is what we got. So if we look at, so we have both with the cuff there is incontinence, and also there is incontinence with the DO. So we have here we have SUI, stress incontinence, along with detrusor overactivity incontinence, and this question has already been asked whether we should treat the urge first and then consider surgery, or do it the other way around. So most people would deal with the urge and then operate stress incontinence if required. So she was started with yes, sir.
So just wanted to say, so if this is done on full doses of medication, so let's say she has, that's the way I would do it. So let's say she's on combined OAB therapy and this is what is found. There is some recent literature, and we've done it occasionally, where we've actually treated both simultaneously. But if you've got to choose one, you would always choose the urgency component first, rather than choosing the stress.
Okay. So we started her on mirabegron 50 milligram. The wet OAB became dry OAB. So urge persisted, but the incontinence subsided. The stress was still bothersome. She was willing and wanting a procedure. Now, so does your plan change for the stress incontinence if she has DO? In this case, does your plan change?
In general, we know the more the obstructive the procedure, the more the odds you have post-op urgency.
Okay.
So I would choose transobturator approach for a patient who's got already some element of urgency.
Okay. Doctor,
soft science.
Soft science. Dr. Bipin, you would agree? You would agree? So this is what basically the data shows. Then this was published in 2008, where they found that persistent DO or persistent urge incontinence was predicted by the sling type, with the autologous pubovaginal sling having more than the retropubic and having more than the transobturator. And there is an explanation for that. But but again, there has been a recent meta-analysis which said that there is no difference. But most people would probably prefer a TOT if you find a DO during UDS.
If we assume that your urodynamic was done with all the maximum anticholinergics.
No, it was done without antimuscarinics.
No, I'm just saying if we assume that it was done with all the maximum anticholinergics, and then we need stress incontinence, and do we give a Botox also? Can we escalate?
What I said was that there's some recent published material on doing both together. This is not an exam answer, please. So there's some recent publication on doing the combined therapy, and we have done it in the odd patient. That means giving botulinum injection along with stress incontinence surgery. The patient did well, except that after some time the effect of the botulinum wore off, obviously. But that's not an exam answer, please. So if you would ordinarily choose in such a situation where you have urodynamic mixed incontinence, which is what this is showing, you would choose botulinum toxin injection in most situations rather than stress incontinence surgery as your next step, if the patient is already on medication and you found this.
So for me, if this was, if this urodynamic was done,
so let's assume this is done on medication.
I would do a stress incontinence surgery.
You would do a stress incontinence surgery?
Because there is data which says that after stress incontinence surgery, the urge incontinence actually disappeared, and the rationale was that because of that small leak into the urethra that precipitated a DO. So there is, I mean, we don't know why it happens, but there is some data to say that the urge subsides after a stress incontinence surgery. So instead of, I would probably think of...
so it works both. There you can argue both ways. The only reason why I would choose botulinum, and so now we are saying that this is done on medication. The only reason why I would choose botulinum and treat the urgency, if I had to treat one of them first, is typically urgency incontinence is much more bothersome to patients than stress. So my focus now is the urgency, not the stress. And although I agree that stress incontinence surgery can sometimes take care of urgency, it's more common if the patient has an ISD, which this patient doesn't, and it's not entirely predictable. You can have an aggravation of urgency if the patient doesn't have a resolution. So actually the other way around can work. So the odds of harm are substantial with stress incontinence surgery, and it's not reversible. So I would do a botulinum injection which is perfectly reversible. Don't harm the patient.
So I would go as...
Secondly, if I have to do incontinence surgery and Botox, so what about CIC, teaching CIC? Required, not required? Will you consider that?
So the idea of this case was basically to bring out that if urodynamics brings to you DO, then the choice of the tape may change if you decide to do a stress incontinence surgery. Okay, so we go to the next case. A 54-year-old lady with primarily irritative symptoms, frequency, nocturia, urge incontinence, daily for 2 years. Moderate to severe quality of life impact, no stress incontinence, no voiding symptoms, no hematuria, dysuria, constipation, passes stools once every 2 days, has to strain off and on. Comorbidities, she's obese, hypertensive, no other medical surgical history, 3 full-time normal vaginal deliveries, physical exam is normal. What next? Dr. Bipin?
What's our water intake? Again, the voiding diary.
So you would want a voiding diary?
Yes.
And?
And a urine test and a uroflelometry again.
Okay, so this is the voiding diary. The output is 1920, day so day output 1450, night output 470, day frequency 8, night 2. Maximum voided volume is 260, 1 incontinence episode. The intake is 1700, complete exam, urine exam is normal, ultrasound normal, PVR normal, UFR normal. So this essentially becomes a case of wet OAB. Now, so how would you want urodynamics now at this stage, or would you want to proceed with therapy?
No, she's an obese lady.
Yes.
To take that in consideration.
Okay.
And, the first thing I will ask her to lose the weight if it is possible.
Okay.
And then if required, then I'll get a MCU again done.
MCU? You would want an MCU?
Yes.
Okay. Dr. Nikhil?
After that, if required, UDS we will.
Okay, so conservative measures were tried for 12 weeks, constipation improved. So she had 10 to 20% benefit, but is still having troublesome wet OAB. Now, would you advise any further testing or any invasive urodynamics at this stage, or would you want to give therapy?
Conservative measures include anticholinergics?
No, not as yet.
Uroflow was
this is where we are.
Normal?
UFR has been done, and UFR is normal, and conservative measures tried, not improved.
Okay, so we'll start on anticholinergics.
You would want to start on anticholinergics. So the guidelines clearly state this, that you should not perform invasive urodynamic testing unless prior to initiating non-invasive treatment. So unless as long as you're giving oral drug therapy, there is no need to do invasive urodynamics. She was started on 50 milligram mirabegron, improved, but she was still not there. Solifenacin 5 milligram was added. Now she was not having any more wet episodes, but urgency was still troublesome.
So the solifenacin was increased to 10 milligrams. She developed constipation. So we were back to 5. We tried introducing another antimuscarinic. That did not work. And so she landed up with what we call as refractory OAB. Sir, would you want to talk about refractory OAB and what the guidelines... so the guidelines actually defined what refractory OAB would be.
Right. So I mean, what we did, and Pawan and Nikhil were part of our guidelines panel. I must immediately tell that we for the first time actually defined refractory urgency incontinence to include a requirement for combined OAB therapy drugs, as well as a requirement for having scrutinized avoiding diary. So as he's just put the definition up there, it defines refractory urgency incontinence as a patient with unsatisfactory response to drug therapy, including combination, and conservative management at 12 weeks in whom avoiding diary has been examined. This, I think, was let us say, ahead of its times. It's only now that actually some of the other guidelines are including some of these things. In this particular patient, I would actually, before proceeding to the next step, two important things. One is to ask the patient whether she wants further therapy beyond this point. And the other is, I might actually like to see another round of a bladder diary. She was somewhat overhydrated to start with almost a 2-liter urine output. So I would just like to take another look. Sometimes patients' symptoms improve, they increase their fluid intake further, just to make sure that we have done everything else that we need to do. And if she still wants therapy, invasive aerodynamics.
Okay, so let's say the diary has been, I mean, I don't have the diary again. So let's say we have the diary and she wants the surgery. Would you inject Botox without urodynamics, or would you do urodynamics?
No, so I would always do urodynamics. So again, for the residents, there's a discordance between the USI guidelines and some of the other guidelines on this. In most of the international guidelines, you do not have a requirement for invasive urodynamics testing at this point before injecting botulinum toxin or sacral neuromodulation. So to proceed to therapies for refractory OAB or urgency incontinence, in the Indian guideline, there is a requirement for urodynamic testing. And there's reasons defined in the guideline which you should go through. The reason is not a demonstration of detrusor overactivity. The reason is to rule out other conditions which can present as urgency incontinence or urgency. And the implications of doing things like putting a neuromodulation or injecting botulinum without a full understanding of the lower tract function. You must also recognize that in our guideline, invasive therapy is restricted to these two. Percutaneous tibial nerve stimulation, which is a simple mode of treatment, is not part of the guidelines at this point. It's actually at an earlier stage in the guideline.
Yes. So like sir said, we are not doing, the urodynamics is actually not being done to demonstrate detrusor overactivity. And if you don't find detrusor overactivity, that does not mean you will not inject Botox. So why we are doing, so one, we need to understand that if you would have done UDS in these patients of refractory OAB who you were planning to inject Botox, in 45% patients you may not find DO. But does that change the course of the patient? There is a review already which says that whether you could demonstrate DO or you could not demonstrate DO will not change the result if you would have injected Botox. So the idea was not to demonstrate the, and then there was this study that if it was there, then they may have done better. But all guidelines are clear on this, that if you're unable to demonstrate DO, that will not change whether the decision for botulinum toxin. And this trial is currently underway to clarify or to give the final word on this. But the guideline says that invasive urodynamics is recommended in men and women with urgency incontinence prior to invasive therapy. The primary reason is you want to rule out some other diagnosis. Sometimes avoiding dysfunction can come up with urge incontinence, and we will see that subsequently. But the idea is to rule out another diagnosis than to confirm a DO for which you want to inject Botox. You will inject Botox even if you don't find a DO. Am I correct?
Yes, just wanted to add a point that the data with regard to men is very, very minimal. You have very few studies which have actually examined men. And in men, if you inject botulinum in patients who have not had a TURP, the odds of retention is substantially higher compared to men who have already had a TURP.
Yes.
So that's one. And so doing urodynamics might tell you in the male patient whether there's an element of obstruction, which is not uncommon, and we know obstruction can present as storage symptoms in men. And we also know that treating the obstruction can give rise to long-term resolution of storage problems. So it's a one-time therapy. So that's one thing for men. For women, the underlying evidence with regard to botulinum toxin and sacral neuromodulation for bladder urodynamics primarily examines only their response to the therapy. There are very few studies which have examined the complication of therapy. So if you're looking at data to see, do you have data to show which women will develop retention following Botox, botulinum toxin injection? There's very little data on that. In fact, most of the trial data which is there, they don't even talk about voiding. They're only talking about detrusor overactivity. So it's a blind spot in the literature which needs to be addressed.
So, so there is consensus that we should be doing invasive aerodynamics before injecting Botox. So this was this patient's UTS. There was a detrusor overactivity with leak. She received 100 units and is asymptomatic and did not have any voiding dysfunction thereafter. Coming to the next case, so how many can we discuss? How many do you?
We can change the panels.
No, we can get more people. However. Okay. So we'll. So this was a 42-year-old lady who had primarily irritative LUTs with mild obstructive LUTS, no incontinence, hematuria, dysuria, major quality of life impact, no other comorbidity, medical surgical history, physical exam was normal, bladder diary was essentially non-contributory. This was her flow rate. So essentially, somebody who came with primarily irritative symptoms and mild obstructive symptoms and had this UFR. Now she received antimuscarinics, mirabegron, not satisfied, and somebody counseled her for Botox, and she had come in for a second opinion. So we did her video, and this is what I'm not sure if you can. It's a little whiter than on after converting, but I'll just tell you the salient point. The compliance was good. And if you look at the video picture, you can see that the bladder is irregular. Now she was given at 168 capacity, she started voiding. Now if you just look at the voiding picture, the bladder neck really doesn't open, and the pressures reach more than 90 on the UDS. These pressures continue to rise. She will, if you continue to look at the video, she will void to completion.
Oh, the proximal urethra
just
looks a little
second.
dilated.
No, if you look at the initial, I'll just come back, sir. Okay, if we can go back. So she voids to completion, and there is so she voided to completion, but there was some dye left in the diverticulum. But if we go back and if I run this again, sir, actually when the pressure rises till to about 90 odd, the bladder neck even doesn't open till then. Bladder is irregular. There is, what I think sir is saying is there could be an issue. So once she is given permission to void, you look at her urethra, the pressures have already reached 90 by now, and that is the you would call this dilated?
To me, the proximal urethra looks a little dilated.
I thought that the funneling was not, it wasn't opening.
Not opening very well. It's opening, but
And more importantly,
now this looks okay. Now this looks dilated, but
so maybe we were doing it real time at that time. So this was the picture that we got.
definitely has a bladder outlet.
So she's obstructed. There's no doubt that she's obstructed.
So
she has bladder morphological changes. it's possible that the storage symptoms that she is having is a manifestation of bladder outlet obstruction. This is high flow obstruction.
Yes.
So she is obstructed.
So for us, she was, so basically this was a lady with pure irritative, I mean not pure, irritative symptoms with some obstructive symptoms who actually had bladder outlet obstruction, and she was planned for Botox, so which again reasserts that you should get invasive aerodynamics upfront before putting Botox in a patient like this. Anyway, for us she was a bladder neck.
Uroflelometry before.
No. So if you look at if you look at this case, her free flow is 17. Her free flow.
But there is some pattern is not good. Free flow is.
I don't know. So even if you look at UDS, her UDS flow was also 17. The last line. So she was voiding with high pressures, but the flow looked okay. So we anyway, this was.
So I mean, there are patients who have a component of dysfunctional void. It presents with a significant storage component. So I mean, I would be hesitant to do a surgical procedure on her straight away. I would actually think of pelvic floor relaxation training and all before I think of operating. Because to me, it looked as if the proximal urethra was a little dilated. She may turn out to be obstructed. You've done a BNI, so obviously you have some answer. But a patient who's voiding with that kind of flow, it becomes difficult to actually assess the results of anything that you're doing, that you do on this patient. So I would actually first, my primary label for this patient would have been a dysfunctional voider, along with a component of storage abnormality.
Okay, so
and I would actually screen her spine neurologically.
That was normal. That was normal. We actually did a BNI, and her irritated.
Before BNI, actually, I would like to put her on alpha blockers, and before surgical procedure, one more pure MCU without a tube.
Okay. Okay, but I mean the idea for today's purpose was a role in botulinum toxin. But this patient did improve after a BNI. Maybe I mean, so 30-year-old so this is not my case. This is from a friend in Brazil. So this is a 30-year-old mid-urethral sling put for pure stress incontinence. At 3 months follow-up, she had mild obstructive LUTs soon after surgery, followed by irritative LUTs, which were de novo, no stress incontinence. This is the flow rate, where the free flow showed was 14 ml per second. Bladder Diary, Bladder Diary most voids were 200 to 250 cc, 1 leak, 8 frequency. The tape, there was no erosion on the tape. Would you consider a urodynamics in this patient?
MCU.
So basically a video was done. So would you think a urodynamic is necessary for this case?
Yes.
Symptoms post tape, which are obstructive to begin with, and then she gets irritative symptoms. There is no tape erosion.
So I think we are back at the same thing. Non-invasive testing before non-invasive management. So what we need to understand with the patient where we are. So if we are at this point,
so we were at this point now.
So I wouldn't do a urodynamics at this stage. I would also point out the hazards of doing a mid-urethral synthetic sling for a woman who's 30 years old. Many of them. So that's something that's in the first line of this presentation. You should be cautious in operating. First, you should be cautious in operating stress incontinence at that age with a surgical procedure. And if you are operating, even more cautious about putting synthetics in that younger woman.
So she received pelvic floor rehab, antimuscarinics, mirabegron, alpha blocker without benefit. Would you consider a urodynamics?
So if she's symptomatic,
yes.
Yes. I mean, she's planning further therapy, yes.
In a patient post-sling, why should we do pelvic floor rehabilitation?
I mean, they tried conservative measures, which didn't work.
I think straight away, why should we not consider that sling may have caused?
Okay, so this is the urodynamic, and these are the findings.
No, that would depend, Nikhil, on what's bothering her more. She has a combination of storage and voiding symptoms. It makes sense to try all your conservative measures, because reversing a stress incontinence surgery may sound easy, but it's not practically always that straightforward. Right?
No, reversing it, I'm not saying that. But if we see, evaluation should not wait. Because if we find bladder outlet obstruction because of sling, so reversing at 3 months would still be easier than reversing at 6 months.
No, so there is data
Reversing
that
earlier will be
so there
easier.
is data that if irritative symptoms develop due to uncorrected obstruction and you delay your surgery, you may de-obstruct, but the symptoms will not go away. So there is data for that.
I know, I have seen that, and I still have many questions about that data, because I have seen any number of TURP patients whose storage symptoms regress, and I cannot understand why it would not happen the same way in a woman who has post-obstruction urgency. But in any case, point taken that if you sit on it for a long time, it's possible that the urgency problem may worsen. Which is why I'm saying we need to discuss with the woman what's bothering her more. She's got storage and voiding symptoms both. And if her storage symptoms are bothering her more, I would not be I wouldn't be rushing into treating her, trying to take down her tape. And if I'm not trying to do that, then I might not really do a urodynamics at that stage.
Storage symptoms, but in presence of outlet obstruction.
No, see, she has mild voiding symptoms. That's what she has. She has a flow of 14 ml per second. I can show you any number of patients who have no voiding symptoms post-stress incontinence surgery who will have a flow lesser than this actually. And many of them, if you do a urodynamics, you might be able to demonstrate a degree of obstruction. We know that we call them non-obstructive, but all stress incontinence surgeries do create some element of obstruction. So it's possible that if you do a test, you'll be able to demonstrate an obstruction. Does it necessarily mean that that's responsible for the symptoms?
So this was a urodynamics. PDET Qmax 30, Qmax 12, BOI index 3.6. Now, so basically this was combined with a video, and the video showed that there was an infravesical obstruction after. So basically, what I wanted to bring, she underwent a sling incision and she was fine. The wet OAB got converted to dry, which is now well controlled with antimuscarinics, no recurrent incontinence. Now, you would agree that for female voiding dysfunction, you would do a video UDS rather than a UDS for all patients? Yes. You would agree? Dr. Pal? You would agree? So for female voiding dysfunction, you really can't reach a diagnosis unless you add a video to it, or have a MCU, or have some fluoroscopic, otherwise it becomes difficult. So we've covered stress incontinence, we've covered urge incontinence, and we've covered female voiding dysfunction. Now we will go to the index male LUTS patient. It's their call. He's
tired. Are you guys coming?
Arabind and Prasad.
Everybody. No, we can have one more chair up if that works. So we will now move to the male. So this is a 70-year-old man who has bothersome obstructive and irritative LUTS. Obstructive LUTS more than irritative, IPSS 21, quality of life fairly bothered, no other relevant medical surgical history, PR moderately enlarged benign prostate, folk FNE normal, PSA is 1.3. He was taking an alpha blocker for a while, and he says his condition worsens when he stops the medication. Now he went to this free health checkup camp. He was told that his prostate is enlarged and that he should get operated. The ultrasound upper tracts were normal, pre-void 350, post-void 120, prostate 60 cc. This is the Uroflow trace. So maximum flow rate 11, he's voided 250 and average flow is 6. So what is your thought about doing an invasive urodynamics in such a man, 70-year-old man?
Just going back to, yes, so yes. He doesn't have diabetes, doesn't have any other...
Nothing. 70, I'll tell you the salient things. 70-year-old man on alpha blocker with a pre-void of 350, post-void 120, prostate 60 cc and Uroflow being this.
Yeah, Qmax is around 10, it's not more than 10 here.
Is 11.
So, you can offer him TURP, you don't need a urodynamics here.
So my first question is, do you think detrusor underactivity is common?
Yeah, around 20% can have underactivity. It's not that they cannot have underactivity.
Okay.
But my management will not change. Even if there is detrusor underactivity, I would still counsel him and I would still go ahead with surgery. It will not change.
So I'll just answer these.
Why surgery continue on alpha blockers? Is happy with
No, he's
alpha
bothered.
blockers?
He's bothered. He wants.
Less than 10 surgery indication is there.
So I'll just go through a couple of things. So detrusor underactivity is not uncommon. The EAU guidelines say it's in the range of 11 to 40%, and there was this study which showed that in people who are aged 70 to 74, it reaches about 40% and then increases after that. So if detrusor underactivity is common and is not uncommon, and we are going to offer him a TOR, do you think you can differentiate between bladder outlet obstruction and detrusor underactivity reliably with non-invasive urodynamics with the information that we have?
It is not possible to differentiate it reliably, but if...
In how much, could you put a number to that, okay, I'm going to be all right in so many times I'm going to be normal?
8 times out of 10 would be...
So the ICS BPH study said that if your Qmax is less than 10, then the positive predictive value of having obstruction is about 70%. So you will be right 70% of the times, and 30% of the times he may have detrusor underactivity. So if we believe that detrusor underactivity is not uncommon and that we cannot differentiate it with non-invasive urodynamics, then the next question is, does it really matter if he's obstructed or does he have underactivity? Do the results of TOR change if somebody has detrusor underactivity?
The TOR is definitely going to improve his flow in this patient. But only thing is he may not be completely relieved if there is an underlying element of detrusor underactivity.
So you're saying that the results may be inferior, but they will still help him?
Yes.
Okay, so
management may not change, but the satisfaction level upstream trial wherein they had done urodynamics for all the patients, definitely patients who had undergone urodynamic study, they were more satisfied than patients who have not undergone. So upstream trial was like, to do urodynamics all the cases, yeah.
So I'll just come to the upstream trial, but you would agree that from a patient counseling point of view, the results are poorer if you have detrusor underactivity. So that is what this meta-analysis showed, that if you have preoperative detrusor underactivity, then you have significantly poorer degrees of improvement in the IPSS and Qmax. Now coming to the next question, that would you still want to de-obstruct what is not obstructed in the first place? So I'll frame it again. So I'll frame it again. We also in practice may think that kar dete hain, some benefit to, something will. I'm saying, do we have data to say that people with detrusor underactivity who were not obstructed and further de-obstructed, did they do better than patients who were not offered any therapy?
My point is, how do we know there is not obstructed? There is detrusor underactivity.
That's what I'm saying. So why would we not do urodynamics? And if he is not obstructed, and we believe that de-obstructing somebody who is not obstructed is not going to help, then with urodynamics, after urodynamics, I will not operate him.
The point is, obstruction is diagnosed by checking the resistance to flow. If there is underactive detrusor, there may not be much flow, and therefore resistance to flow, the point does not.
No, if the UDS is inconclusive, that is different. I'm saying we agree that DUA is not uncommon.
Not uncommon, yes.
We agree that we cannot get to it by non-invasive urodynamics.
Yes.
We agree that if we operate a DUA, the results are at least poorer.
Yes.
So my next question which is it that if we do not operate a DUA, or if we operate a DUA, does he do better than the person who is not being operated?
Yes, I think there is some evidence that it is better than
So there is this study which sir mentioned in the morning from Thomas, which is a 10-year follow-up study, which said that if you, for people with DUA who were operated and people who were not operated, at 10-year follow-up, there was no difference in either the symptoms or the urodynamic gains from a TUR. This is from Paul Abraham's group only. Paul Abraham's, I think. So with this, and we also understand that detrusor overactivity, if it is there with DUA, then the results are even more inferior. So with this background, so obviously the upstream trial which came said that you do not need. So with this background, would you, why would you not offer TURP to everybody? I mean, you are going to be, you yourself say that 70% times I will be right, 30% I may not be right, you know. So why is this, so for CA prostate, we say we will do free PSA also, multiparametric MRI also, everything to just bring down that you know, unnecessary biopsy or unnecessary. So why here, why do you feel I don't need to do urodynamic in everybody? No, we don't know what he has. Does not have signs of obstruction. He has lower urinary tract symptoms which could either be obstructive or because of detrusor underactivity, which we do not know unless we do a urodynamic. And we understand that in 30% of cases we may be, you know, we may be borderline or incorrect. So I also may be doing the same thing, but my question is, why do we believe that we do not need to do urodynamics in everybody?
Because in this 30% group also, this is an overlap of obstruction with underactive. So the idea of doing URP is to take care of the obstruction part, and then the underactive, the symptom eases because the obstruction part is relieved.
Sir, what is your thought on this? Because in many cases we are like 20%, we are not sure, so let's add this test, let's add this test. But why here at a 30% you know, grey zone, we are ready to
so I think first from the resident's perspective, which are the patients in whom you need to do urodynamics?
I'm coming to that.
You're coming to that. Okay.
So the guidelines says that this is who you need to do urodynamics in. This is the USI guidelines, which says either a very young man or a very old man, or where voided volume is less than 150, basically where you couldn't do a UFR, or where the Qmax is more than 10, PVRU more than 300, or if you're doing a recurrent TUR surgery. So our patient does not land up in that group. So from the guideline perspective, we do not need to do it. I'm just asking, what is your opinion?
So now we are essentially talking of men who are between 50 and 80, who have a voided volume more than 150 and who have a flow rate of less than 10 and a PVR which is less than 300. So that's the group we are looking at. So now it's a kind, so guideline wise, you don't need to do a
guideline wise, right? Guideline wise, in this patient you need to do because his Qmax is 11.
Qmax is 11, right? So what I was trying to say is, let's say if his Qmax was 9, for instance, so he would not fall into the guideline group for doing a urodynamics. In all these patients, you are fine if you don't do aerodynamics. Now, only thing is how your discussion goes with the patient. What are the other subtle signs that you're looking at? Let's say this patient has a 15-year history of diabetes and evidence of peripheral neuropathy, for instance. Or the higher the flow the patient's flow is, the more the odds that you are actually getting into a, so this 70% is when you take the cutoff as 10. You make the cutoff 12, that percentage changes, right? So the lower the flow rate is, so if this patient has a flow rate of 5 ml per second and a prostate gland of 60 grams, it's a no-brainer, right? But if the flow rate is 10 or 11 milliliters per second and the prostate is, let's say, normal in size, we know on average, if you take 100 patients, larger prostates are likely to be more obstructed patients. In the individual patient, it may not matter. But on an average, larger prostates are more likely to obstruct, which is why we get more alert when we have a normal sized prostate. Although we know for the individual patient, it doesn't matter. But in general, if there's a big prostate and a very low flow, no other markers, no need for urodynamics. So I think it's a way, if you have a patient who is very questioning of you, see, it also depends. So one of the clauses which is there in the EAU guidelines is where either the physician or the patient require more information. So there are times when your conversation with the patient goes along such a line that the patient asks you this question. So if he's going to ask you this question and then you don't offer the test, he may not ask urodynamics. He may ask you a specific question, can it be a problem with my bladder? It happens. And then if you don't offer, you might get into trouble. So I think it's an individualized decision.
Point taken. So that is the consensus that this is the group in the male uncomplicated LUTs, non-neurogenic, who you want to operate upon. So I have a question for my, so let's say the patient is on a catheter. Now you can't have all of this, then what do you do? The guidelines doesn't cover
So
that.
for a catheter, the dynamics changes. So on a catheter, your discussion with the patient is at the upper limit. Let's say if the bladder if I were to do a urodynamics and if your contractility is very good, your odds of becoming catheter free is close to 100%. At the lower limit, if you have an acontractile bladder seen on the urodynamics, these odds, depending on which evidence you look at, falls to somewhere around 30% at the lowest. So it doesn't fall below 30% in any study. So if the patient is comfortable with the thought that if you don't undergo surgery, you are 100%, you have a 0 success because you are not getting off the catheter. If you do a surgery, you have some chance of success, but that success varies between 30 and 99% depending on what your bladder is. And many patients may say, it's fine, I'll go ahead with surgery. That's okay. So for the patient on a catheter, it's reasonable to go ahead with surgery because he has nothing to lose. Right? But even here, I just had this discussion a couple of days ago and my patient by the time we had the discussion at the end, he said, no, I want to check. So sometimes it becomes difficult, especially, and it also depends where you are practicing. So in my practice, a large number of patients come with problems with patients who've got these kind of problems anyway. They expect something different from me. But for every individual person who's practicing and will be practicing in this room, your practice will pan out differently. So you'll have to take an individualized decision for this. But in general, patients on a catheter don't necessarily need a urodynamics if they have nothing to lose.
What is my question? Opinion? My question is, suppose we do aerodynamics in that patient on a catheter and he doesn't generate pressures. There are two scenarios here, that he is underactive retrocer. 2, he did not generate pressure. We could not because of the test itself. And in that situation, what were you going to do? Are we still going to go ahead and counsel the patient and go ahead with TURP?
So
if the answer is that yes, I'm going to counsel the patient and go ahead with TURP, then with the patient on catheter, the TURP actually, the aerodynamics actually did not help. It would help if there is showing a good detrusor contraction. Then as I said, 99%.
So that question, Arvind, it's the answer which not you, it's the answer that the patient will give.
Yes,
right?
Yes.
So you have to ask the patient that if your test shows a 0, and I ask them clearly, if your test doesn't show power, your odds of success will be 30%. Would you be fine going ahead with surgery with that? If they say yes, I won't do the urodynamics.
Yes. So now, coming back to your original query that the oncologist does so much and we don't do so much. Yes, that I think, I'm just thinking that is a point there. And the oncologist, I just want to say that they tend to overdo things because they have
total PSA, free PSA, velocity, density, multiparametric,
yes. They have the robot sitting on them and they have to show robot functionality.
So probably the consensus is that not for everybody, and within the realms of these guidelines, that is what you would agree.
I wouldn't argue with if somebody says I do a UDS. The UDS.
No, I was only throwing this that I am surprised that we have a number that we agree upon, which is 30%. The data says 30%, but we still, after that data also, we say it's not required. It's
a gray area.
Maybe.
I wouldn't argue if it's there. Yeah. Maybe we should change and we should do perhaps.
So I'll move now to the neurogenic cases. So this was a 31-year-old male, known hypertensive, who had a cerebrovascular accident 10 months back. Complains of urge incontinence for 6 months, no UTIs, no other significant medical, surgical history, physical examination, motor sensory normal, FNE normal. What would you want to do?
We need the entire non-invasive, including the uroflelometry, the urine.
So this is what we have. We have the complete urine exam is normal, bladder diary, 5 frequency, functional bladder capacity 350 cc, 2 incontinence episodes, upper traction normal, UFR is normal, PVRU is 20 cc. Sorry. So I just show this slide that the AUA guidelines actually say that you just need PVRU and urine exam, but we would probably agree that for
for a male patient who comes like this, we would do uroflelometry,
Yes.
because I think in our setting it's easy to get a uroflow done. So
Uroflelometry.
all this has been done.
With
Now,
an ultrasound also, yeah.
Yes, so all this has been done. Now the question is, do you want to start therapy or do you want to do an invasive urodynamics? I'll just summarize: 31-year-old with urge incontinence with a normal uroflow and normal upper tracts, who had a CVA 10 months back. So do you want to start therapy or do you want to do urodynamics?
We will start treatment now.
You would start treatment. So for neurogenic patients, you don't think that you need an invasive urodynamics?
Yes.
So the first slide, please, just once.
Sorry.
31-year-old.
31-year-old CVA patient has OAB, the UFR is normal. Upper tracts is normal. So for patients, for neurological patients, the question is, do you do urodynamics in everybody before you start therapy, or do you, or would you start therapy in this patient?
Ideally, we should say, ideally I would do urodynamics in this patient, but that's an ideal world.
So you think you would do urodynamics? You would do urodynamics?
I would do urodynamics ideally, yes, but
you would do urodynamics?
Yeah, I do agree, because he has this incontinence episodes also.
Yes, you would
So
do
we
urodynamics.
don't know what it is like,
You would not. So the guidelines actually have changed a bit, and they talk about now low risk neurogenic bladder and high risk neurogenic bladder. The low risk, anything that is suprapontine, suprapontine, they say because there's only going to be detrusor overactivity and no DESD, so they are the low risk neurogenic bladders. So the AUA now says that at initial evaluation in patients with low risk, the clinician, you need not do upper tract imaging or multi-channel urodynamics or renal functional assessment. So the CVA patient, the Parkinsonism patient, if the because in these lesions, while the timing is wrong, it's coordinated voiding and the pressures don't rise dangerously high. So in these patients, unless you have some other thing to for you to do urodynamics, let's say you have elevated PVRs or you're getting recurrent UTIs, you can start therapy without doing a urodynamics. While the EAU guidelines still has not divided these patients into a high risk and a low risk group, and they continue to say that for neurourological patients you should do a urodynamic. So this was the yes. So this was the urodynamic where the capacity was 500 cc, the compliance was normal, and there was a terminal detrusor overactivity with a PDET Qmax of 37 and a Qmax of 24 with negligible PVR. So basically he did not have any obstruction, and so started on conservative measures, time voiding and mirabegron, with which he settled down.
Now, my question is, should we give mirabegron in these patients where you have a neurogenic? There are the data regarding mirabegron is a little sketchy.
No, data is
AUA does recommend it, but rest of the guidelines are very clear. Mirabegron is not recommended for neurogenic.
No, so after those guidelines were made, there are enough articles. So we have also published one on mirabegron in CVA. There are enough articles which talk about the role of mirabegron in both spinal cord and in so in the guidelines to come, it will sooner or later be incorporated. But I mean, if somebody wants to start antimuscarinic, it is.
But in an old patient, again, antimuscarinic has its own issue.
Yeah, but this was, I think, a 30-ish guide. Right. So for a low risk neurogenic bladder, you may want to start therapy without urodynamics. You would agree, sir? So next case, 63-year-old Parkinson disease for 6 years, complains of urgency, urge incontinence, increased frequency 1 year. Exam is normal, and the Qmax, the only thing that changes is that the Qmax is now 5.6, the voided volume is 152, and the PVRU is 37. So now would you want a urodynamic invasive study, or would you want to start, this is the flow. There is no upper tract involvement.
Yeah, there is. So we can start treatment initially and then.
So as per the guideline.
What is the post-word residue is 37.
37.
No, I think there could be a mixed pattern here. There could be both obstruction and there could be urogenic detrusor overactivity. This is one patient, again, if you want optimum treatment, would benefit from UDS. Optimum treatment, that again, it's where you practice, how you practice.
So he received an alpha blocker and mirabegron was added. He was a little better, but still not happy. You would want to do invasive aerodynamics then?
Yeah, if it's not working, then I'd go for invasive.
But at the outset, he is not a patient who's low risk because he has a poor PVR. So he comes out of that AUA definition of low. Okay. So let's presume.
In the sense, I would maximize medical therapy unless he says he has refractory voiding difficulty. His primary symptom is urgency.
5.6.
I know, but his
Qmax is around 5.
I understand that, but look, the thing is, his primary presentation is with storage. Yes. We know Parkinsonism patients often, I mean, these patients are not the best patients for operating.
Yes.
And his residuals are very low. The risk that you will precipitate retention by adding antimuscarinics is actually quite low in this patient. I would be fine trying everything before proceeding to something invasive.
So I don't think we did. So this is what we had, and then we did a urodynamic, and in the urodynamic, why is this? This is PowerPoint versus. Okay, so basically when we did a video, the urethra was normal. There was no posterior,
consistent with obstruction at the bladder leg.
Yes, which was consistent with obstruction. The Qmax was 6. PDET Qmax was 120 with a BOI of 108, and he underwent a TOR and was sorted. So what would you, to summarize UDS in suprapontine lesions, what is your take? I mean, your current practice?
So I would always, in such situations, do a urodynamics before operating. For many of the patients who are labeled as Parkinsonism, they may actually have Parkinson plus MSA and those kind of conditions, and those patients don't do well at all. And in fact, diagnosis of MSA is contraindication for operating. So looking at the temporal timeline of how the symptoms presented in the course of the patient's neurological illness may give you some idea. MSA patients tend to present with the urinary symptoms straight away. In Parkinsonism, it tends to happen late. Residuals tend to be high with the MSA patients compared with the Parkinsonism. So I mean, if you have such patients, always I would do a urodynamics.
And you would be comfortable instituting non-invasive therapy in suprapontine lesions without a urodynamic. So we are more selective in the suprapontine group. Is that a consensus? Yes. Okay. So we move ahead. 23-year-old man, cervical spine injury, resulted quadriplegia. Following a road traffic accident, he had urinary retention, was on POC, then started on CIC, which was caregiver CIC, continued for some months, was mostly continent, but since some time he's on a condom catheter since the caregiver is not there, and now they're doing abdominal tapping. So no UTIs, constipated, moves bowel once in 2-3 days, higher functions normal, quadriplegia, moderate spasticity, the anal tone is increased and the BCR is normal. So upper tracts, no hydronephrosis, pre-void 150, post-void after abdominal tapping is 60 cc. So my question is that do you do invasive urodynamics in spinal cord injury patients routinely?
Absolutely. I would do.
Even when upper tracts are normal.
Even if the upper tracts are normal, I would do.
So the initial, so that is what the recommendation is. That there are two categories, which is spinal cord injury patients and spina bifida patients. They are considered high risk, and in them you must do urodynamics before you start whatever therapy you want to start. So because in these patients, not only do you have detrusor overactivity, you also have associated DEST, which makes the pressures dangerous. So what is the timing of invasive urodynamics in your practice? When would you do invasive urodynamics after a spinal cord injury?
I think around 3 months I would wait before I do, so it becomes a little more
And would you do a video study?
If I have video, I would do video.
You would do video. Sir, would you wait for 3 months?
Yeah, so you need to wait for the spinal shock phase to go away. But you know, many of these patients are having multiple problems, not just a spinal injury. So if all other things are taken care of and they are ready for urological management, yes.
You would, yes. So that is what the guideline says, that that you do it at the end of the spinal shock phase, and for the first round you should do a video if possible. Now the key, and what are the things that you want to look for in UDS in these patients? See.
Looking at the detrusor overactivity and looking at whether the filling phase is safe or unsafe, and also looking at the DST pattern in the voiding phase.
You would, so basically we are wanting to see if the patient has any high risk factor for upper tract damage, which we had discussed in the morning, which includes all of these high amplitude or a longer duration of NDOA or a sustained compound DOA, or if the compliance is low, the leak point pressure is high, if he has DEST, or if you have high grade reflux on the video. Now this was the static cystogram of this patient, and this is the video of this patient, where we found the NDOA amplitude was 120, and along with the DEST, along with sphincteric contraction, and the urethra was dilated. Again, at 140 cc, at 140 centimeters of NDOA, at 140 cc filling, and subsequently, if you see this, this is the abdominal tapping, and this is when they tried to make him void, and this is what you got. So so any change in plan now? Would you allow him tapping and voiding?
I think tapping is a very bad idea in this. Tapping is a bad idea. What is happening? We are trying to stimulate a detrusor overactivity, and that would overcome the sphincter.
So basically, in this, sir, would you allow tapping?
No, I wouldn't. I mean, so in this particular patient, obviously, it's precipitating a dyssynergia and he's getting high pressure. So the patient is at risk.
So tapping can only be allowed if the pressures remain low. At these pressures, tapping will ultimately damage the upper tract. So he was shifted to cath and antimuscarinic. Should we stop or should we?
If there were no pressures like both the leak point pressure, if it was a safe bladder, then we could still allow tapping? No?
Yes. So if it is a safe bladder, he is voiding in the sense he is emptying adequately at low pressures, then tapping can be an option. But the UDS has showed that he is not emptying. Should we stop or should we?
Depends on whether you want to catch your flight.
I want to catch my flight. But obviously he will.
It's okay to just finish this and we stop.
Okay, so this one we can. This was another. This is again a high risk urogenic bladder which we can leave if we want to. Yes, so I'll just come to this. So after your first UDL, after your first urodynamic, when do you schedule your next urodynamic?
Yeah, that's a very interesting question. Guidelines vary on this. In an unsafe bladder, annual is actually recommended by many guidelines. And in a safe bladder, you need not repeat. You can follow up with biannual ultrasound also.
So there is data.
In a safe bladder, he comes up with new symptoms. Again, you have to.
So you need to follow up. It's not that you are going to say nothing to doing in this patient.
So ultrasound is not enough for you to be following these patients. The guidelines say that after you do your first UDS, you should repeat one UDS at 6 to 12 months. And after that, if your patient, long term, if your patient is, depending on the level of lesion, or have you been able to make the bladder pressure, have you been able to make the bladder safe, then you could do it yearly or even 2 yearly. Of course, all these things, if you get change in bladder behavior, new onset symptoms, recurrent UTI, new hydronephrosis, you may need to do it, unscheduled. And you should pay particular attention in patients who are high risk by the nature of disease, that if you were unable to suppress the detrusor completely, or if they had VOR, or if they were having DST or if there was poor compliance.
So I think, Pawan, there has to be a, sorry, interrupting
Yes,
you. There has to be a difference in approach between situations where the patient is stabilized, everything is fine, and you are thinking when to do serial surveillance evaluation.
Yes.
Here we are not at surveillance. We've done one assessment. So the next assessment has to be determined by what you found on the first assessment. So the first assessment showed a really high risk situation, and let's say this is not spinal cord injury, it's a myelomeningocele. In India, a bulk of your patients will be myelomeningocele, which is not common in the West. If you wait for 12 months for your next assessment, you may find your patient come with a creatinine of 3 by that time.
No, this is the second, so the first one at 3 months, and then the first rescheduling.
Oh, so you've done a baseline, you've done another one at 3 months, and then you're looking at when to do the next.
No, the first one you've done after spinal shock.
Right.
And the
I got that.
And the guideline says that now you cannot forget the patient, you must do it by this.
Right, so what I'm trying to say is, one is the surveillance of a patient who is already in a stable picture. You know the patient is fine. There, all guidelines say high-risk disease, periodic surveillance is required. They may vary on their frequency, and most of them don't ask you to do it more than once in 2 years. Okay, but right now we are talking of the first phase where you're not sure whether the patient is actually fit to get into surveillance.
Okay.
So at that point, you have to tailor it based on what you found in the first assessment. Let's say the first assessment, I mean, especially if it's an MMC, and the first assessment shows hydronephrosis, or there's, or there's a very high-risk bladder. You can't wait 6 months or 12 months to do your next assessment.
Yes, agreed. So, so the opinion is that in spinal cord injury patients, I mean, the consensus is...
See, one of them should be routine, first one should be routine, second one is variable. The another point is...
No, second one is also routine.
Yeah, unless it's...
But after that, it is depending on whether you achieved safety or no.
Yes. And the second point, and the point is, sometimes you can have these mixed things. You can't really predict how the bladder will behave based simply on the anatomical lesion, because it just may be a cervical cord mainly, but or it may be a lumbar L5 mainly, but also there will be cervical cord contusion which coexist.
Absolutely.
So you absolutely need to do a UDS.
So this guideline is only for sacral and infrasacral?
No. This guideline is for spinal cord injury patients, that your first urodynamic will be...
That has to be very clear.
Yes. Your first urodynamic is at the end of the shock, and then you must repeat one within 6 to 12 months, in which sir said that if your patient is unstable and you've instituted some Botox or something, then the guideline within that Botox says you must repeat your urodynamics in 3 months. I mean, you need to establish safety. I think...
That's it.
Okay, thank you.
How many do you have?
So I just give the very quick vote of thanks here. Thank you so much for coming. I think it was a very exhaustive session for most of you. There is coffee outside for those who want. And I just like to thank everybody who has come here. I would like to thank all my faculty who has come here, who have taken the pains to come here. This program would not have been possible without the efforts of a lot of people. The staff at KIMS are people who arranged our sponsors. Please, I would request all of you to just visit your sponsor's stall once. That's a special request from me, because they have helped to put this program together. It would not have been possible without their help. I can assure you, it is very difficult to get any help, though it's a USI program from the USI. And I would also like to thank USI-ISU for giving us the opportunity to host this program. I would like to thank all the people who have sort of contributed to this, for the stalls, for the audio video. It's extremely kind of them to spend their Sunday here to do this. I would like to thank all the employees of KIMS who have worked very hard to make this a success. Thank you so much. All of you can come for a photo session, just one very quick one. All of the outside can also come in, and we'll have a quick photo session.
Hope you enjoyed all the things.
These are all. Thank you, everybody. Thank you. చుట్టాలు వచ్చిరంట మళ్ళీ క్రెడిట్ కార్డ్ ఏం కాదంటుంది. ఏమి నీకేమైంది వస్తాడు ఏంటి దాంట్లో ఎందుకు పోతలేదు సార్ ట్రై చేయండి కదా సార్ దాని నెంబర్ కూడా ఒకటి పంపించా కానీ ఇప్పుడు అలా పోతాడు ఇంటికి పోతాడు ఎంత చేస్తున్నావు నాకు హలో ఏంది ఎవరికన్నా ఇస్తారేంది పూల